Good morning, colleagues and friends, and clinical practice. This will include discussion and interaction over the kingdom and our international guests. So, without further ado, let's start our conference opening with Sheikh Ahmed Abu Al-Ainain for Holy Quran recitation.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن الذين لا يرجون لقاءنا ورضوا بالحياة الدنيا واطمأنوا بها والذين هم عن آياتنا غافلون أولئك مأواهم النار بما كانوا يكسبون أولئك مأواهم النار بما كانوا يكسبون إن الذين آمنوا وعملوا الصالحات يهديهم ربهم بإيمانهم تجري من تحتهم الأنهار في جنات النعيم دعواهم فيها سبحانك اللهم وتحيتهم فيها سلام وآخر دعواهم أن الحمد لله رب العالمين. صدق الله العظيم.
Almusa Heart Center at Almoosa Health Group offers a wide range of cardiac services and advanced technology to expedite diagnosis and treatment, featuring the latest cardiac technologies such as advanced such as advanced echocardiography modalities in form of speckle tracking, atrial and ventricular strain, 3D volume that aid in early diagnosis of cardiac dysfunction and have a unique role in cardio-oncology patients. Myocardial perfusion scan using nuclear imaging, a hybrid operating room with combined catheter and surgical modalities, and an electrophysiology lab, all ensuring better outcome for Al-Ahsa patients. Now, I will leave you to enjoy a video about the secrets of teamwork and the role of echocardiography in guiding heart disorders early diagnosis.
الطبيعة، الألوان والمعمار. أحب الحياة بكل ما فيها. اخترت الهندسة المعمارية، أبعاد وخيال واتصال مع الطبيعة اللي أحبها، بس أغمض عيني وأبدع. أنا أحمد، كلمتكم عن نفسي، لكن نسيت أقول إني انولدت بروماتيسم في القلب وضيق في الصمام. من مدة ركبت صمام معدني، لكن تحسن كان بطيء، واليوم ضحت.
أحمد، الإيكو مبين معنا إن في كتلة كبيرة في الجزء الخلفي من القلب وضغطها على الصمام المعدني، ودي هي مأثرة عليك في التنفس دلوقتي وقوة الضغط، فأنت محتاج عملية فورية دلوقتي إنقاذا للحياة. موافق إن شاء الله؟
Count backwards.
10 9 8 7.
We removed mass from backside of the heart, but we discovered another big mass thanks to transesophageal echocardiography during the surgery. And Alhamdulillah, we removed also this big one and the small one. And you are doing fine, everything is good. Inshallah, we will discharge you very soon.
صار لي زمان ما تنفست براحة وعمق. اليوم ببدأ رحلة جديدة في مكان شدني تصميمه، هندسته وتكوينه. متحمس للي جاي، لتأهيل القلب، متحمس أرجع للمعمار، متحمس للبدايات الجديدة. أحب أشوف
Now, please welcome on the stage Dr. Abbas Al-Mutir, the Deputy of the Academic Affairs Director, to give a speech on behalf of Almoosa Health Group Academic Affairs. Please welcome him on the stage.
Assalamu alaikum. Sorry. MashaAllah, this is the second Eco International conference at Almusa Health Group, and last year we had a rain during the conference, and the same during this year. So inshallah, it's all khair. Your Excellencies, guests, and honorable speakers, I'm honored actually to welcome you all to the second Almusa International Eco Conference, which has always been a platform for healthcare providers and researchers and faculty members to present and share their knowledge, and also results of their interesting research and achievement. Well, this event can be considered a step into the future science, given the valuable collaboration, and also the second ECO conference aims to encourage and contribute to science by sharing the knowledge. With this being said, I would like also to thank the invited speakers for participating and bringing their expertise, innovative ideas to this important a conference. A special appreciation to the organizing and scientific committee who have put an interactive program, and also the organizing committee who guided the organization of this event with the creativity and enthusiasm. I would like also to express our sincere gratitude to our CEOs, the hospital CEO and the group CEO, for their endless support and encouragement. At the level of the academic affairs at Almusa Health Group, will continue also to use innovation and creativity aligned with our 2030 vision, and also our vision here at Almusa Health Group, through collaboration and contribution to the global community. Thank you very much.
Now, it's my pleasure to invite Dr. Ala Khalil, the conference director, to the stage to give the speech on behalf of the conference scientific and organizing committees.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد وعلى آله وصحبه وسلم. It's my honor and the privilege to welcome you all to the second Almusa International Echo Conference. Since I joined here to Almusa Hospital 3 years ago, and I am dreaming to repeating my previous events, which was doing already at Jeddah in the western area for about 8 consecutive years, with the same group of the speakers and the same participant in the other area. And since that time, I was dreaming to do this here in Al-Ahsa, and Alhamdulillah, this dream came true last year by holding the first Almusa International Echo Conference. And Alhamdulillah, it was also highly appreciated by most of the attendees last year. This encouraged us to continue the same event this year. The success of the conference last year was helped by the wonderful effort and great assistance of the speakers, as well as attendees at the time, who already participated in the giving lectures and also in the active participation in the discussion, fruitful discussion at the time. This work couldn't have been completed and succeeded except with continuous motivation and the constructive support of the hospital administration headed by Mr. Malik Al-Musa and Dr. Zainab Al-Musa, and also by the rest of the administrative assistance team. Also, this event couldn't have been possible without tremendous effort of our academic staff and the marketing group. The conference activity started yesterday, as you know. We started yesterday by 2 workshops. One transesophageal with Dr. Osama Abdurraouf for the physician. Already attended for this workshop about 46 participants. And also another workshop for technician headed by Miss Mariam Bouhamsin, and attended for this 37 participants. And it was very fruitful workshop, hands-on. After that, we started yesterday interesting ECO forum, case forum. Already was completed 14 doctors from all over the kingdom, and also some from outside, from Egypt. And already will announce, inshallah, after the next video, we'll announce about the winners for the 3 best cases yesterday. We'll give them very good prices. And also ended the day yesterday by JEOPARDY with Dr. Osama Al-Muqbil, and already it was 2 rounds, and already succeeded for this. We have already 6 winners. And also all these winners will be awarded after we seeing this video, inshallah. And good news also to tell you today, there is also 3 big prizes for the who will continue attending with us till the end of the conference. By only just هنعمل سحب الاسامي اللي انتوا حاطينها بره كلها. يعني كل اللي موجود حاطط اسمه على اساس هيتعمل سحب في النهايه ان شاء الله. 3 very good prizes. طبعا نظام سيارات والحاجات دي انتوا عارفين يعني. ان شاء الله. So keep with us, supporting us until the end of the conference. And now just we'll see this video, and after that we'll give awarding for the prizes. Now we came to the most important thing now, just to give awarding the people who already won yesterday. We'll start, first we'll invite Dr. Abbas just to welcome all the people here. I think all of you now waiting for the who already won yesterday. We'll start by the third one, Dr. Abdurrahman Jamil.
كيس برزنتيشن دكتور نفس الهدايا.
الكيس برزنتيشن مش دول كيس برزنتيشن. الثالث فين؟ كله زي بعضه. حطهم بس. بس. دكتور. شكرا حبيبي. بالتوفيق ان شاء الله. الله يبارك فيك يا حبيبي. Second one, دكتور هدى شحاتة. اتفضل يا دكتور. الله يكرمك. الله يكرمك. لا بس. And now came to the first one. Which one you will expect? from the cases yesterday? Huh? He didn't attend. The first winner is Dr. Tariq Al-Hussein. لا موجود.
Because my case was very weak.
فين ال What is the third one? فين فين الجائزة بتاعت الدكتور طارق؟ هناك السنة صور. أنا بدور على الجائزة بتاعتك. شكرا شكرا حبيبي. And now we'll announce, all of you know yesterday for the JEOPARDY, we'll announce it was 2 rounds. The first round, it was already, the first one was Abrar Al-Ali, but I think she's not available now. And the second round, it was the first one, Dr. Akram Niazi. The second one in the first round, Dr. Jamila Jaber. Jamila Jaber. It's not available. مش عارف. خلاص خليها. طيب ماشي. Third one in the first day, Dr. Akmal Ahmed. Akmal Ahmed. Second one in the second round, Dr. Hatem Khirallah. الله يبارك فيك يا شكرا. And the last one for the first day, Dr. Mahmoud Shahata. And now we'll invite all the already got the prizes just to come here for the photo with the referee yesterday, Dr. Hassan Shams Basha, Dr. Abdulhalim Kinsara, and Dr. Ashraf Anwar. نيجي هنا. Thank you for attending the opening ceremony, and now let us start our scientific events today. Companies, sorry. Still we have the appreciation for the companies.
Also, now we would like to appreciate the companies who supported our success, starting with Al Faisaliya Medical System Company, Philips. Also, Novartis.
Novartis company? Nobody? Okay.
And finally, or lastly, Bristol Myers Squibb.
Bristol Myers Squibb? Bristol Myers? الله يكرمك.
Abdurrahman Al Qasaibi Company, Welch Allen and Fujifilm.
شكرا لك الله كده. Thank you for attending our opening ceremony. We'll start now. We'll invite Dr. عبد الحليم كنصارة, Dr. عبد الله العلي, and Dr. طارق الحسين for sharing this the first session today.
شكرا. السلام عليكم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. So we'll start our second day. And as you see, that is, we have really a very comprehensive program covering a lot of topics. So I encourage all the speaker kindly to stick to the time. We give you a reminder 1 minute before you end up your session, so you have to wrap up in this 1 minute. We'll start with the first speaker. أسامة عبد الرؤوف. أنت حدد الثاني. لا حنرجع بعدين مرة ثانية.
Okay, so welcome you all this morning, and the speaker will be Dr. Osama Abdul Rauf. Dr. Osama, please. He's a consultant cardiologist at Prince Sultan Cardiac Center in Almoosa. Dr. Osama is practicing in Prince Sultan for quite a good time in here, has extensive practice and covering echo for structural heart disease. He will speak about echo and ASD.
شغال؟ Okay. Assalamu alaikum. Today our presentation about the role of the echo in ASD closure. ASD is the most common congenital heart disease encountered in adults. About one in 1,000 live persons are affected by ASD. ASD is more common in female with the percentage 4:1. Transcatheter has become accepted alternative to surgery for ostium secundum ASD. Extensive experience has the safety and usefulness of this procedure. The echo has very important and essential role during the diagnosis and during the interaction with the device. This is the three common views we can evaluate the ASD: mid-esophageal for chamber and aortic valve short axis view, and of course the favorable view is bicaval view. And this is the modern data, how to see the interatrial septum by 3D. And as you see, it is not just a line, it is like a sheath. We can see it from different direction. And here a beautiful 3D image shows the details of the ASCD as seen from the right atrial perspective. You can see the fossa of valves, you can see the eustachian valve, and even the coronary sinus. And this facilitates too much the intervention procedure. TE has very important role before and during and after the procedure. بعد إذنك I think الباتري هنا. Before the procedure, the diagnosis depends on transthoracic and transesophageal echo as regard the confirmation of the diagnosis, the size, the multiplicity of the defect, and the shunt direction. Here, again, how can we see the ASCD secundum by the transesophageal echo? Transesophageal echo will give a great image about the site of the defect, the size of the defect, the direction of the shunt, and also the right side and pulmonary artery pressure. We should also assess the four pulmonary veins, the left upper, left lower, and right upper, right lower pulmonary vein, and this is very important during the procedure. Here, the beauty of the 3D, you can see a real image and a real size of the septum. It is not just discontinuation as we see in the transthoracic or transesophageal. It is a real hole, and this is what the surgeon will see at the operating room. Here you can evaluate the defect from the right atrial perspective and the left atrial perspective. Again, through anatomy, which facilitate communication between the echocardiographer, intervention, and the surgical team, if needed. Here, swivel motion, you can move the picture in front of you and you see the ASCD either from the left or the right atrial perspective. Here another case of ASCD, but this time the shape is little bit different, and as you see here it is oval shape. We can see it from the right atrial perspective, from POCUS, and from the light view. We can measure it accurately by the 3D and even determine the size of the used device. Here, this is very important picture of the 3D as regards the ASCD. In one picture, you can determine the size of the defect and you can measure the whole rim in simple and accurate way. So, only one picture, you can get all parameter and all what you need. The 3D is not only beautiful, but also informative. Here, you can also evaluate the integrity of the rim, especially the inferior one, because this will affect the decision of use of the ASCD device. Here, there is multiple small ASCD. Here, this is the main hole, and beside it, you will find multiple small ASCD. And as you see here, the 3D picture resembles true anatomy to a great degree. So, during the procedure, TE play an important role. Here, during sizing balloon, this is the fluoro picture, and this is our picture. I want mouse, please. Mouse. لا عاوز احرك الصورة بس. احرك من هنا؟ طب برسي. Okay. Yes, yes. Okay. Here, this is the fluoro, the device inside the sheath. Deploy the first one, left atrial disc, and the right atrial disc. You will see now. Okay. This is left atrial disc will pull, and this the right atrial disc. Look at our picture, what we obtained by the transesophageal echo. You will find clear view of the deployment of the device. Here, after deployment of the device, the interventionalist will do testing. This is wiggling maneuver, and here the fluoro picture, and here our picture. He is pull and push technique to test stability of the device. Again, the transesophageal echo picture is very clear. Here, the device seen after finishing of the operation. All what you see is the device. Compare this picture with our picture. We see exactly where the device, we see the valve, we see the contraction, we see the right ventricle status. So by our picture, we even add more information than the fluoro picture alone. We test the stability of the device and absence of the shunt after the procedure. Also, we can detect the early complication or immediate complication, like what happened in this situation. Embolize device from its place. We can exactly know where the device and how much the device is liable for embolization through the mitral or aortic valve. So what about the value of 3D, or what can 3D can add in the procedure? Very valuable information. You can see the sheath while crossing through the septal defect. You can confirm it when you see it in the left atrium. No need to check even by fluoroscopy or pressure gradient or saturation, nothing at all. You can see it very clearly and very accurately. Here, during the deployment, you see here, this is the left atrial disc, and you can see also the right atrial disc. And this is after successful deployment. The device is stable in place and closing the defect within the septum. And here you can confirm also the post disc, ensuring complete closure of the septal defect. So, what other data really you need to know not shown by the 3D? If you are interventionalist, can you tell me what other data? Number 2, with such a clear video, do you think that fluoroscopy is still needed? In other words, in the near future, can ASD device closure done in the echo lab rather than in the cath lab without the need of radiation from fluoroscopy? Interventionists really do a great work. They are professional. They are doing a major job. We consider them at the pilot of the brain due to great job. This is their real position. But if you are the pilot of the brain, which drives the brain, remember that we are here in the guide, guiding you. Thank you very much. Allah يخليك. شكرا دكتور.
Thank you very much. till the end, yeah.
Okay.
So thank you very much, and I would like to welcome our second speaker, Dr. Hisham Abdul Naim. Dr. Hisham is a cardiologist with an interest in echocardiography. He's from Medina Cardiac Center. He completed his MSc degree and MD degree from Al-Azhar University, and he's board certified in echo, as well he's a fellow of the American Society of Echo. So welcome, Dr. Hisham.
المشكلة
هذا البرزنتيشن
هات المحاضرة السلايد اللي بعديها.
انت كبس من هنا انا فورورد
مش هيشتغل الفيديو برضه. السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Ala, for inviting me to this nice lecture. I saw all my colleagues in ECHO, all from all the kingdom. Very nice to see you. I will talk to you today about the paravalvular leak closure. Paravalvular leak closure is not an acute problem. It is a chronic problem in most of the cases. It is a pathology in the valvular ring, and it is association with the tissue of the valve of the patient. It is not, in most of the cases, a surgical complication. That's why if you see a patient with paravalvular leak and you close this leak, you expect in the near future it will have another leak in another place. So you close the leak. All this happened in our patients all the time. So it is a pathology in the ring itself, in the and in the interaction between the the valvular ring and the patient tissue itself. That's why in some patients they didn't have paravalvular leak at all, and in another patient they have paravalvular leak and continue to have it once you close it. This is the short axis view of the aortic valve. You can see here this is a mechanical aortic valve, and with the severe paravalvular leak here. The best view to see the paravalvular leak in the aorta is the transgastric long axis view. This is the view that can show you the leak, can show you the direction of the leak, if it is anterior or posterior, and you can tell the interventionist now that this leak is toward the mitral valve in this side. That's why he can try to cross the wire at this side exactly. This patient have also mechanical mitral valve. And this is the paravalvular leak in the aorta. And there is some dehiscence in the aortic valve. You can see it here. This is a paravalvular leak, and there is some dehiscence in the valve here. This patient at the same time has a tricuspid valve ring, C-shaped tricuspid valve ring here. This patient have severe tricuspid regurg inside the ring. So he have mechanical mitral valve, mechanical aortic valve, and tricuspid valve ring, severe paravalvular leak in the aorta, and severe tricuspid regurg on the tricuspid ring. This is the ring here, tricuspid. So in most of the cases, you refer this patient for surgery to do aortic valve replacement and tricuspid valve replacement again. But this patient have 3 times redo, and he is very high surgical risk. So we try to solve his problem by percutaneous option, to close the aortic valve, paravalvular leak, and to put a tricuspid valve in ring percutaneously. This is the tricuspid valve in ring done already. And after you put the tricuspid valve in ring, we find that there is severe paravalvular leak outside of the implanted tricuspid valve, immediately in the cath lab. That's why we bust the wire here. This is the wire passing through the paravalvular leak. And we close this paravalvular leak with device. I think it was 12 millimeter vascular plug. This is a device clothing the paravalvular leak on the tricuspid valve. And after closure, there is minimal tricuspid regurg, and all the severe tricuspid regurg disappeared. This is a closure device on the tricuspid valve ring. And also we close the paravalvular leak on the aortic valve. So in the echo, we measure the annulus, we measure, we are putting a balloon expandable valve. In the tricuspid position, you put the biggest valve you have, because the ring is C-shaped, it is expandable, and you expect to put, at that time, the biggest valve was 29 valve, we put it, and although we have a leak outside, and we close it as we see by a device. So this is the 29 valve, and this is the closure device here on the tricuspid position. The mean gradient is okay, and patient is doing well. This is again the severe paravalvular leak aorta, closed also by device. So this is a 3 valve, and this is the bull and cage valve in the aortic position. You can see the closure device here, first device. We are following by transgastric view all over with the interventionist. After putting the first device, the paravalvular leak decreased, but is still there. So we go with another device. After putting the 2 devices, the tricuspid, the paravalvular leak on the aortic position disappeared completely, and the patient aortic valve is okay. Then we go to the tricuspid ring. This is the C-shaped ring, you can see it here, and this is the wire passing. This is the valve, implanted valve in the tricuspid position. After the valve implanted by echo, we find, as I told you, severe paravalvular leak on the implanted valve. So we went outside the valve with this wire, and we put another device here, and that's why this patient 2 valve problem is solved percutaneous. by closure of the aortic paravalvular leak and by putting a valve in tricuspid valve ring and also closure of the leak of the tricuspid valve. So the trick here for the tricuspid valve, you put the largest valve you have because the tricuspid annulus is expandable one, and you expect to have a leak after you put the valve. In this case, you go to the leak and you close it by device on the same situation. This patient is doing very well, and he's follow up like 3 years after was doing well. This patient is young patient, 30 years old. He have also 4-3-do operation, and he has very high surgical risk for surgery, and he have severe paravalvular leak on the mitral position. You can see here the leak is coming everywhere. This is a mitral valve, and this is part of the leak. Closure of paravalvular leak in the mitral position have many tricks. The most important one is if you have the leak is medial leak, it is toward the septum, it's very difficult to close it by transseptal. So after experience, we choose to go transapical from the apex. If you go from the apex, you have the whole mitral valve 360 degrees in front of you. So you can easily cross anywhere, medial, lateral, anterior, posterior, no, it didn't matter. So from our experience, if you have a medial leak and you expect, don't lose time to go transseptal. So we are doing in this patient transapical approach. And this patient have also the same problem with the other one, severe tricuspid regurg on the tricuspid valve ring. Here is a severe paravalvular leak, one here and another one here. And this is the, I think, tricuspid valve. This is the mitral valve. And we start to put devices transapical. Transapical, you can direct the operator to any hole you want. This is one device, this is another device. Still there is leak. This is a tricuspid valve, severe tricuspid regurg. We put also another valve in ring in the tricuspid position. This ring, this valve in ring was good and didn't require any paravalvular leak closure. So we have here one device, another device. These two devices was bought like a couple of years ago. And during this echo, this patient have severe leak from this place also. As I told you, it is a chronic process. If you put device here, the leak will appear here or there or anywhere because it is a pathology. It is not like a surgical complication or something like this. This is a tricuspid valve and the paravalvular leak on the mitral closed by third device. This is the third device, 1, 2, and 3. So we solve the problem also by closing the leak on the mitral position by transapical approach. And this patient has 3 valves also, the same as the previous patient, but the parent Kush valve here on the mitral position, not on the aortic position. See this ring? It is different from the other ring. The other ring was C-shaped. This is complete ring. That's why when you put 29 valve on this ring, it was fit very well and it didn't require any leak or any problem after that. And you can see here the mitral valve. The blockage here is the aorta. Mitral valve, we have 1 device, 2 device, and 3 device. 3 devices on the mitral position. We have one patient at the end, after a couple of sessions, you have 10 devices surrounding the mitral valve. So this is the apical, transapical approach. That's why if you want, if you have multiple leaks on the mitral, go transapical. Transapical will help you too much, and you can direct your wire to any place for the operator. I think this is for the the mitral valve. Transapical, you can go anywhere 360 degree, direct the operator to put the wire in the leak itself. And the most important part here of the echocardiographer is the leaflet stacking. So don't look for the device, look for the leaflets. And we have many patients, they have what we are calling intermittent leaflet stacking. Not all the beats, like 2-3 beats, and then you have stuck leaflet for 1 or 2 beats, and then come back again to work. This intermittent stacking can be transferred easily after you release the device to complete stacking. So be aware and follow the leaflets at least 10 beats to be sure that there is no intermittent stacking and the leaflet is moving freely. In some of the cases, we abort the procedure because we cannot implant any device without stacking of the leaflet. This depends on the distance between the leaflet itself and the ring and the tissues of the patient outside. It's rare cases, but it happened that there is no device, because there is some devices without disc. We can put device like vascular brake 3, I think, without disc, didn't have disc. But also, some of the leaflet is stuck in this valve. Of course, leaflet stacking is not an issue in the bioprosthetic valve. It is an issue only in the mechanical valve. So, paravalvular leak closure is very challenging procedure, especially in the mitral position. Transapical approach is very beneficial. Take care from the stacking of the leaflet. And also, paravalvular leak can happen during implantation. I finished already. During implantation of the valve itself. So this is very important. One more notice is, if you close a leak, it may cause hemolysis. If you have a large leak and you close it like 80%, the smaller the leak, the more the hemolysis. We had one case reported with severe hemolytic anemia after closure of the large leak and remaining only a small leak. After reclosure of this small leak, the hemolytic anemia disappeared. The last comment is the timing of the paravalvular leak closure after surgery. We have a case, we close the leak after 2 weeks of surgery. After 2 weeks of open heart, the patient has severe leak, severe heart failure. We close the leak of this patient by device, another device, and the first device is embolized because the tissues is friable. It cannot catch the device well. So we recommend, if you are going with paravalvular leak closure in acute situation, close like leave moderate leak, like 3 to 6 months, and then you close the other one later on.
Thank you very much, Naeem. I think we have to stop here. Dika al-afia. Okay, so our next speaker is Dr. Fetal Dallak. He's a consultant cardiologist and echocardiography at King Fahad Medical City. He's going to talk us about Watchman device closure.
That's good. طيب. Assalamu alaikum wa rahmatullah. Good morning, everybody. I'd like to thank Ala for his invite. I'd like to thank you all for attending, and I'd like to thank the organizing committee. So, TE in Watchman device, this is an important topic. Most of us are working on daily basis. We have a lot of Watchman devices, not only Watchman, other than Watchman. So the first one implanted Watchman was in 2002 in Germany by a German physician. His name is Karl Hauptmann. That was the first Watchman device implanted in a human being. There are like multiple other devices followed up like Amulet and Lariat and multiple other devices and vendors. As you can see here, on not only Watchman, we have a lot of devices in the market that might close the left atrial appendage. As far as you know, we use Watchman because 90% of clots happen in the left atrial appendage in a non-valvular disease. So we talk about the vast majority of cases has clots in the left atrial appendage, and that's the reason we close it in patients who have bleeding due to anticoagulation. And of course, you know, hemorrhagic stroke in Watchman device is less because we didn't use any anticoagulation. You might go only with aspirin. So in the long run, Watchman device in those who bleed is having better outcome. So how can we do Watchman? We go through the femoral vein into the right atrium to the left atrium, passing the septum and putting the device, as you can see here in demo. So this is just a chest X-ray. Looks like a chest X-ray. That's what we see in chest X-ray. In the left border of the heart, I don't know if the pointer is working here. So this is just similar as a chest X-ray. So if you look at here, the left border of the heart is formed by the left atrial appendage. Then you can see what comes in the front of it is the LAD going to the groove. This is the pulmonary artery. And this is what you can see here, the border of the left side of the heart. What comes to the right is the right atrium, and that is the sternum. So this is what we see in AP view or PA view of a chest X-ray. If you go to the lateral side, you can see the appendage, left atrial appendage in here. You can see what beside it is the left upper pulmonary vein, and what's in between is the warfarin ridge. This is anterior to the sternum, this is posterior to the spine, and the circ is passing just behind, going posterior to the heart, left circumflex artery. So that's what we see in a lateral side chest X-ray. This is just only to make you imagine what's going on. This is how it looks like in real life. This is from a cadaver of left atrial appendage Watchman. So our first case is a 70-year-old gentleman. He's a diabetic hypertensive. He's having ischemic heart disease, atrial fibrillation. He came multiple times with GI bleeding. His CHA2DS2, as you can see, is very high. So we have to start him on something. We cannot start him on anything, even a Bixaban 2.5, because if kidney function is down. He also bled, so we have to take him for Watchman device. Sorry. So in Watchman, what we do, we pass through the femoral axis, and then we make ourselves into, this is the right atrium, and we have two views. We have the first view, which is the short axis. You can see here we're in about 60 degrees or 50 degrees. That's the short axis. This is the aortic valve. This is the septum. So we try to go a little bit posterior, not too much posterior because you don't want to touch the pericardium in here. You would like to be into the posterior side. And if you go a little bit higher angle, between 90 to 120, this is the bicaval view. You want to like poke the septum inferiorly because you will be away from the SVC. This is the SVC in here. This is the IVC. So you would like to be a little bit to the inferior side beside the IVC. So that's where we prick the septum in most of the interventions. That's the safest area. And if you like do the right puncture, then the rest of the procedure will be easy. So this is the 3D. Probably it's mentioned by first speaker. That's, you can see here, this is the SVC, this is the IVC, and this is the aorta. So you would like to be away from aorta as a posterior, and you want to be away from the SVC a little bit inferior. So that's probably where you would like to poke your patient down in here. It's a little bit slow, sorry. So in this case, we went to the left upper pulmonary vein, as you can see here. So we park our catheter, then we get our delivery system and we adjust ourselves and we go into the left atrial appendage. Clearly you can see the Watchman device has been implanted in position. There's no paravalvular leak, and we measure a few things after that. So you can measure how much is the size of the device. So the size of the device has to be bigger before you put it inside. So if you put it inside, it has to be smaller because you squeeze it in a small area. So when you look at the size here, 1.6, the actual size of the left atrial appendage is about 2. So you're talking about 40%, 30% compression. And that's really good. So here, this is a reasonable Watchman device implantation. And of course, you would like to see the shoulders. There's no shoulder. That's what you call a shoulder. You measure from here and here. And that's where we implant our patients. So, sorry. This is how it looks. This is probably the 3D. This is the final outcome of this Watchman device. And that's where we decide. So sizing of Watchman device, we look at the diameter of the device itself. Probably there are like diameters in here. So the LA diameter is 19. You go a little bit higher, getting bigger devices for a smaller area. So when you put it in and you balloon it, you squeeze it into the right and proper position. So the morphology of LAA, or left atrial appendage, we have like multiple morphologies, like windsock, we have like chicken wings, cactus, cauliflower. It looks like multiple shapes, and even more than this, multiple shapes of left atrial appendage. And when we implant, like when we wanted to implant the device, we have to get it exactly in the proper position. So here, if you look at this area, this is like a smooth part of the left atrial appendage. This is the warfarin ridge in the top, and this is the left atrium appendage. And this is a smooth part. It gets a little bit wrinkled in here. That's where the pectinate muscle, and probably that's where you would like to put and land your Watchman device in here. So you want it to be exactly in this position. This is the LCX, and this is where the difference between the smooth part and the wrinkled part of the pectinate muscle in here. So that's where you would like to put your device. I think, yeah. So if you can open, so excuse me, I don't know if, can you let it run, please? So in here, clearly you can see, this is the left main comes in here, yeah. So this is the left main comes in here, forget about these. Left main comes in here, and what comes beside and goes posterior is the left circumflex artery. So that's exactly where you want to put. This is just, imagine, this is the LCX happening here. So exactly you want to put your device. The tip of the device has to be at the side of the LCX, because that is that is exactly the place that we want our device to be. So here, and that's here. So posterior. This is exactly at the circ area. And so if you look at this warfarin, this is the left atrial appendage. This is the left atrial appendage, and this is the pulmonary vein. So you want your warfarin ridge. If you look at the warfarin, it's not in the same plane. It is actually swirls down and goes. So it's a little bit down. So you want to be exactly down here at where the LCX is. So that's what would make like a precision of your device. Next. So we take multiple images from different views at 0 up to 135, and then we take the biggest diameter, and that is exactly what Watchman device is. And probably as we mentioned here, this is a cut of 45 degree, and this is the cut of 90. This is the bicaval view. This is the 45 degree, and that's where we want to put ourselves. It's a little bit posterior. It's away from aortic valve, that's the most important, and it's down a bit inferior, away from the SVC. So that's where we want to poke our patients. In here you can see it in 2D. This is a 45, away from the aortic valve, and this is a bicaval view away from the SVC. So that's exact spot of a transseptal. If it is done properly, then the rest of the procedure is going to be easy. So this is a second case, 81-year-old gentleman. He came to us, he's diabetic, hypertensive, multiple PCIs. He has a limited mobility of the left side because of old stroke. And he had like mitral clip done before like couple of months. And you can see there is significant MR. So he came with two problems. The first one was heart failure because of this significant MR. And the second is recurrent bleeding. The guy came with hemoglobin of 5, 6, multiple time bleeding. So he's atrial fibrillation. You cannot keep him without any anticoagulation. The guy can barely walk, but he's still having weakness on the right side. His CHAS-VASc is very high, as well as his HAS-BLED score. So you have to put him, to give him something that prevents the clot and at the same time doesn't increase the bleeding. So you can see clearly here, this is the previous device or the previous mitral clip done. So we have to go and fix it. The highest jet is coming lateral to the, this is the like what we call the 2D image or two-chamber view of the LV. So here is the medial part and this is the lateral. You can see there are two jets, one of them is medial, one of them is lateral. So the most or the biggest jet is lateral one. So we have to tackle at least one. He's 81-year-old. You don't want perfection in those kinds of patients. So you'd like to fix the mitral valve disease. So we fixed it. We went with our mitral clip, lateral to the first one, and that's where you can see it's in here. And this is the device exactly on top of the jet. You can see where we're going. And probably, can I get back? Okay, get back. Probably this is a reasonable result for us. That's the last one. So it's actually a reasonable result, getting like mild MR after we fix the first one. And you can see in here, there is the first one in here. That's actually when we passed into the mitral valve, and you can see just only mild MR. So we fixed the first problem, which is the mitral valve disease. The second thing, in the same sitting, we went into the left atrial appendage, and that's where you can see we implanted, crossing the septum as we mentioned before, and then we went into the left atrium, and clearly you can see the device is placed in position. You can see that just there is no leak. We made our measurements. The device is just exactly where you can see the circ in here, LCX, and that's how it looks. Fluoroscopy. Usually we, when we do and go into multiple procedures, most of the procedures, we go into the area, whether caudal or cranial. Usually the cranial, we look at the proximal part, but the caudal, we usually look at the very distal part of the left atrial appendage, and it spreads most of the left atrium, and you can let it go a little bit deeper into the left atrium. So this is how it looks. This is the cranial. This is a short like 45. That's exactly how it looks in transesophageal echo. We're more or less the same, but a little bit of counterclockwise moving the image. It looks like the same. So we're always on the same page. There is a synchrony between the echocardiographer and the TE. Clearly you can see here at higher angles, this is 135 degree. In a RAO caudal, this is where you spread. Actually, this is 135. We look at mainly the distal part of it, how many loops, how it's spread. It opens the left atrial appendage, and it makes it really clear, the distal part of it, especially if you look at like saddle thrombus or anything that you cannot see. then the higher angles are the views to see. So if you counterclockwise them, this is what we see in our RAO caudal view in the cath lab. So probably, again, we're in the same page. So when we follow the patients for a Watchman device, what we look for is looking for clots, as this patient seen here. There's a clot and the position of the device is not very well sat. There is a thrombus on top of it. So in these cases, this is kind of a complication that might happen if the sizing is not really done properly, if the device is not really implanted in a proper way. Sometimes the echocardiographer giving a smaller size to the interventionist. So it's always good to be in the same page, trying to make sure that you do your best in sizing. Sorry. So, can I move the videos here? So in summary, that's how the interventionist work if he's working alone. Can you open the other video, please? And that's how they park if it is guided by echocardiography. That's all. Thank you very much.
Thank you very much, Faisal, for this nice presentation. We'll move to the next speaker.
Our next speaker is Dr. Mustafa Rifai from Al-Babtain Cardiac Center. He will spend a few minutes with us talking about the role of echo in management of patients with the left ventricular assist device. Dr. Mustafa, please.
ما احتاج هذه ممتاز كده كويس كده شربك طيب فتحت ما شاء الله اكسلنت يا فيصل واو السلام عليكم ورحمة الله وبركاته. So this is our center, Babtain Cardiac Center in Dammam. So can I, okay. Can I go to the echo? No. Go back. Go back to the first. No. Go here. There is a play. Next. Okay. Echocardiographic evaluation of LVAD. Down. Yes, this one. Okay, open. Next. Okay. So LVAD or left ventricular assist device, it's used for advanced heart failure. So around 6.5 million patients in the United States, they have heart failure. And among these 6.5 million patients, 10% they have advanced heart failure. Advanced heart failure mean they require heart transplant or LVAD or LVAD as a bridge for heart transplant. And the definition of advanced heart failure is severe symptoms of heart failure with dyspnea, fatigue at rest, or with minimal exertion, New York Heart Functional Class 3 or 4. And there is an episode of fluid retention like pulmonary edema, ascites, peripheral edema, ascites, and reduced cardiac output with peripheral hypoperfusion. And there is objective evidence of severe cardiac dysfunction, like low ejection fraction below 30%, severe abnormality by Doppler echo showing pseudonormal or restrictive mitral inflow, pulmonary capillary wedge pressure by right heart cath more than 16, and mean right atrial pressure more than 12, and high BMP or pro-BMP in the absence of non-cardiac causes. So here, severe impairment of functional capacity, inability to do exercise, 6-minute walk test less than 300 meters or less, and VO2 max between 12 to 14 ml per kg per minute. History of at least one hospitalization in 6 months, and the presence of feature despite optimal medical therapy using diuretics, ACE inhibitor, beta blocker, aldosterone inhibitor, etc. And in some cases, when there is left bundle branch block, CRT if indicated. So there are four major indications for LVAD. So number one is a bridge to transplantation. So we know the definite treatment for advanced heart failure is heart transplant. But the problem of heart transplant, there is lack of donors, shortage of donors, and many patients, they die while waiting for a transplant. So the idea of left ventricular assist device came as a bridge to transplant or a destination therapy. And in one study, around 125 patients, they compare who go for medical therapy alone or LVAD. They found the mortality is better in the LVAD, and the is much better in 1 year and in 2 years. So the third one is bridge to recovery and bridge for decision. So we use the Intermax. The Intermax, when the patient presented with cardiogenic shock, what we call it crash and burn. So this LVAD should be within hours. If you have patient sliding on inotrope, with days. If he is dependent on the inotrope, maybe within weeks to months. Frequent flyer to the hospital, patient with severe LV dysfunction, with frequent coming to emergency room with pulmonary edema. So it can be weeks to months. And patient who is really housebound because of severe heart failure. So variable in urgency, if you walk with minimal, again the same, and is a placeholder. This is Intermax 7. So can you click on the double click? So maybe you go to the beginning and found, no. So go to the, before that, if you find a play, from the beginning, play. Well, if it is not coming, it will. تحتاج هذا go في شيء اسمه play, or you have to put this one maybe. في شيء play, not play play alone.
Play bar.
Play بس.
This one, play, right?
No, not play bat. Play.
Assalamu alaikum. Okay. It's an honor to be here today again this year in this conference. I thank the organizers committee and Dr. Ala in particular for this invitation. I'm going to talk this time about the echo assessments in the mitral valve in valve implantation. أي واحدة؟ هاي? Okay. So I have no disclosures, but I have acknowledgements to Dr. Gilbert. He's a well-known cardiac surgeon, interventional cardiologist. As you know from years that we've been having multiple cases of mitral valve bioprosthesis and mechanical mitral valve prosthesis and aortic valve replacements, and we started to shift to cases where we're having a tricuspid, aortic valve TAVI, percutaneous implantation. And it used to be, according to the people who are doing it without guidance from the echo, that they can do it by intervention, just doing the annulus and leaflet calcifications, and that will be the end of the TAVI. However, in cases of mitral valve and valve, which I'm really happy and thrilled with this, that we have to be there with them in order to do the complex procedure of mitral valve and valve percutaneous. As it is growing up and shift from the mechanical valve prosthesis to the bioprosthetic valves, especially in the mitral valve era, you could observe that because of the longevity of those mitral valve bioprosthesis, it's just short for 5 to 10 years. We're seeing and we're facing lots of malfunctioning bioprosthetic valves. And this has been, again, a shift in the guidelines in 2017 from re-operation to re-intervention. When we look at the cases of the mitral valve bioprosthesis, we see that the failure mostly it is because of regurg, and there are lots of causes contributing to this. The other causes are stenotic and combined causes. Why we are preferring the transcutaneous rather than the reoperation? Because of this, you're avoiding that the patient has CABG or AVR or mitral valve surgery before, and redo and exploring the valve and excavating that valve. It's a bit complex and increase morbidity in those patients. So when you have an immediate hemodynamics with those mitral valve percutaneous, you have a very rewarding outcome of it. Except, unfortunately, in certain cases where you have to go for surgery in cases with endocarditis and LV obstruction, or if the patient is going for other valves, other cardiac surgery like CABG or AVR. There are lots of devices has been used during the era of the mitral valve and valve, but the commonest one is the Edwards Sabine 3, which has different sizes, and this has been accommodated according to the CT guidance and to the TEE annular measurements. As you can see, it has been progressing. The blue line is the one which is transcutaneous, percutaneous, mitral valve and valve, which has been progressing and increasing in number in comparison to the redo surgery by mitral valve, with no difference in mortality, at least in 1 year time. So we have been observed in that cases when they have done the registry that those patients who are referred for transcutaneous mitral valve and valve were higher SDS score and more comorbidities and significant pulmonary hypertension and other lung diseases. On the other hand, that you're having those patients with the percutaneous, they have less cardiopulmonary bypass utilization, shorter ICU stay, no ventilation use, ventilator use, and less new atrial fibrillation. When we are assessing patients going for mitral valve and valve percutaneous, we have to know exactly what's the type of the valve, if we can, as possible as we can, and the cause of the mitral valve degeneration or malfunctioning. And there are lots of things we can see from this one. Mainly, there are flail degenerative valve with significant mitral valve prolapse. Oops. And How can I press on the same to run? Right, the other one, please. And here you could see that there is, you can appreciate the cusp. There is no laser. Anyhow, cusp perforation as a cause of the malfunctioning mitral valve. And that was only 2 years after. But sometimes it is secondary to the valve itself, that during the surgery it has been damaged. And because we couldn't find any other cause for the malfunctioning valve and tear. The other is the fibrotic, necrotic, calcific valves with obstructions and malcoaptation. So after we have diagnosed the patients of what's the cause of the underlying mitral valve bioprosthesis dysfunction, the plan for assessing the valve itself in order to say which valve size is the one which we are going to use. The modalities that it has been used is the TEE and the CT scan. The label usually the label size of the prosthesis which we need to put it is not the same size as we are doing it. The true one is the one which is between the leaflets. Unfortunately, I don't have the pointer, but the true one, as you see, TID is the internal dimension between the leaflets and the sutures implantation. However, when the CT gives you the measurement, it gives you the one with the plaques and pannus. So one has to be careful in adjusting the size of those patients. For each one of them, there is a caveat. TEE, because of the calcifications, and the same for the CT, we might underestimate or overestimate the size of the valve. When we are sizing as well, we have to make sure when we are implanting that valve that you can do a well implantation and expanding of the valve to its range, and you could go exceeding it for 1 millimeter at least, and this is what is recommended in order to get a good hemodynamics outcome without higher gradients or acceleration of leaflet degeneration. At the same time, do not overexpand because you are proning this patient for an AV block or myoannular rupture. The other thing that you have to be careful about when you are implanting that valve to make sure you're having a ratio of the atrial to the ventricular ratio. And this patient has been implanted nicely, but then it has been migrated because it was a little bit undersized. And it did migrate into the atrial side. The other complications that you need to see and to avoid, if you can we play it, please? Excuse me. Is embolization. Sometimes if you undersize that one, it's just because of the high pressure over the mitral valve, it's usually higher than the aortic valve, the closing pressures. So this can cause embolization if it's not properly implanted. The second issue that you need to look at in those patients is the LVOT obstruction. There are so many factors that you need to look at. One of them is the anterior mitral leaflet of the bioprosthetic valve degeneration. Sometimes when you apply the valve inside, part of that leaflet goes into the LVOT and cause an obstruction, so you have to be careful of this. Other parameters that you have to go for it, I'll go one by one, is the when you are implanting, you have to make a ratio which is exactly between the atria and ventricle and not to exceed 20 to 80. It means that you're not supposed to be more in the ventricle, more than 80% of the size of the valve, because this will cause an obstruction. The second thing, when you are flaring up the lower part of the mitral valve, make sure you don't over-inflate it, because this also will cause an LVOT obstruction. The angle which is between the aortomitral annulus. This is another area where you have to clearly see if it is less than 115 or 110, you are more prone to have an LVOT obstruction. A gradient which is in the LVOT, if it is more than 10 at baseline, this is a predictor for LVOT obstruction. Another term which has been used, predicted new LVOT, which means that you are relating this in the CT scan, it's like something diagrams. You do it and play it, and you put the valve size that you are planning to do it with the LVOT specified on the diagram. The new one, which you get it here, is the new LVOT area. And if it is less than 1.7 to 1.9, it means you are going to have an LVOT obstruction. And this will worsen the prognosis, at least, and mortality of the patient. The approach to those patients in access, usually it is transseptal, transapical, and transatrial. The commonest one is the transseptal. And when we go, as exactly explained by even Fetal, that it is, you go into the inferior posterior, not anterior. And you have to make sure that you are at a level of around 2.5 to 4 centimeters away from the height of the mitral. The study has been seen, just a registry 1-year study, and they have seen a mortality of as high as in a repeat surgery 11%. And you could see here, appreciate that the blue one is the transseptal and the apical is the one which is going down. So the trend is to use more of transseptal. And when they compare both, they have more mortality and going to surgery in cases of transapical. So they prefer the one which is going for transseptal. So they recommended usually transseptal approach is the best one to be guided. The second one, which is for 5 years, this is another interesting point, that when you are having it, you could see that the mortality is going very nice for very good prognosis for those patients who are transcutaneous. And then after 1 year, there are crossover, and there is evidence of worsening of survival in those patients. And this is expected because they have high, as we said initially, STC score and worsening in their lung disease and pulmonary hypertension. However, their recommendation saying that the clinical hemodynamic and echocardiography follow-up for those patients support the midterm prognosis of those patients, and they still recommend the percutaneous one. One of the issues that has to be taken in consideration, the same as the mitral valve bioprosthesis, is anticoagulation because they have more thrombotic evidence. So in conclusion, transcatheter mitral valve in valve is preferable for redo surgery and to be a standard care of patients. طبعا احنا we're using it now only for patients who are rejected from the cardiac surgery. However, we did one of our patients has been refused by the patient himself. He was around 45, and we did him, and in fact, he's doing excellent now for almost 5 years. I'll just share with you one quick case. It wouldn't take 2 minutes. 70-year-old female patient. She has a mitral valve replacement bioprosthetic. She has been found to have mitral regurg just a few months after surgery. And this is, I don't think it's the magnum. This is the valve which we have been having an issue with it. But she was doing well and asymptomatic. After a few years, she came back with a significant MR, TR, pulmonary hypertension. We offered her surgery. She has lots of comorbidities. She refused, and we were happy, so we took her for the percutaneous. Can we run, please? So you could see that there is significant MR, significant TR. Valve is not opening well, and it's eccentric. It's a mitral valve stenosis around 10 milligradient. The next one. You could see that it's a heavily calcific valve. Only this was 3 years after the surgery, and you see it opening not bad and in a good shape, but when you close, there are lots of gaps, and this is the cause of the mitral valve regurgitation. So we decided to do for her percutaneous mitral valve in valve, and this was done by Dr. Rida Abul-Ata. We're really thankful for him. That was the first case for me in the complex when I did this one. And as we said, we have to go with the parameters that we stated, and in our case it was 3.25, so we went. طبعا رضا أبو العطا does not take anything of my measurements. He just go, mashallah, tabarakallah, doing all the cases with his experience. So this is when we went through the transseptal approach, and this is all at the same time where he is going inside. And then he inflated the valves in the balloon. He inflated the balloon first inside the valve before putting the valve, and then we implanted that valve into the mitral valve bioprosthesis. And with this, you could see it here nicely, well implanted, no MR, no MS. And the only thing she had at residual is the ASD, and it was a big one. And this is one of the issues that you could do it also, is to put a device to closure. Thank you.
Thank you very much, Dr. Fatma. As usual, very excellent presentation. And we will leave the question at the end of the session for the sake of time. And I will introduce our next speaker, Dr. Zakaria bin Musa. He doesn't need much of introduction. He's a very senior echo consultant, and he's the head of echo division in Prince Sultan Cardiac Center. He is very expert in the imaging of structural heart disease and doing a lot of proctoring inside the kingdom and outside the kingdom. So he will talk to us about the role of echo in mitral valve clip screening and guiding the procedure. Dr. Zakaria.
Assalamu alaikum. Good morning, everyone, and thank you for the organizing committee for the nice invitation and this organizing this important echo meeting. So we'll go over some tips and tricks in mitral valve screening for percutaneous intervention, namely mitral valve tear, whether mitral valve clip or Pascal. These are my disclosures, and it started. The story started in 1991 when Professor Alvieri, he had a patient who was a young lady, and she had severe MR, and he was thinking to do a repair for the mitral valve that will allow her to get pregnant later on. So he came up with this stitch. Alvieri stitch technique, where he is creating a double orifice mitral valve. It was 1991. It didn't widely implemented in the surgical community. They didn't like it, the cardiac surgeons. And the result was not that great, except in his hand. He's an expert surgeon. Then in 1999, Dr. Gore, who was a cardiologist who was in the United States, he was working on some inventing a device for percutaneous repair of mitral valve. He read an article read by Professor Maizano, who was the registrar of Professor Alvieri, about this surgical technique, and it sparked him the idea of the mitral clip. And that was the early design of mitral clip, and it went through multiple development till in 2001, that was the final design. In 2003, they did the first patient in Venezuela. Actually, they didn't do it in the States or Europe because, you know, the regulations and the approval and these things are complicated in these countries. This lady, she survived from 2003 till 2019 when she died because of COVID. So she didn't die because of cardiac disease. So this proves for us, or give us an idea how good is this technique. Although the initial design was very primitive, was very difficult and very, let's say, different from what's the current situation we have now. So it started, sorry, can we go back? Okay, here. So it started with Everest trial. It was a feasibility trial where it proved that this is a safe procedure with a good result. And that was in 2011. And in 2018, it came the co-op trial where it showed a benefit for mortality and hospitalization with good outcome, good result for those patients with their functional or primary. The guideline then adopted the procedure, and you can see that in the primary MR, the edge-to-edge repair is class 2A, and we know that it will not be a class 1 because surgery for these patients are the definitive treatment. But for high risk or prohibitive surgical risk with anatomy favorable for transcatheter approach, where the surgeon will say no, the only option for you is the edge-to-edge repair, and I would say for those patients, you might consider it as class 1A indication because you have no other options. This is the American. The European, they give it class 2B, which I don't know why, but anyway, it is also a good option for prohibitive risk. So for primary MR, the class 1 indication is surgery, but we are frequently seeing patients very old, 80s, with a lot of comorbidities where surgeon will say, I will not take this patient. So the only option for them would be the mitral valve tear or edge-to-edge repair. Now, what about the functional? The functional or the secondary, MR, actually, the guideline now giving the edge-to-edge repair is class 2A compared to surgery, which is class 2B in both the American and the European guidelines. So we know that these patients, isolated mitral regurgitation repair or isolated MR to send them for surgery is class 2B. Now, unless you are sending them for concomitant CABG and mitral valve repair, that's a different story. But you know, with the wide use of percutaneous coronary intervention, you will always see these patients where they have isolated mitral regurgitation, and I would say mitral clip is the choice for treating such patients. So to start with, you have to select your patient. You have to optimally medically treat them. You have to do coronary revascularization if it's indicated, resynchrotization therapy if it's indicated. If they remain with severe MR, with recurrent hospitalization, symptomatic heart failure, then you should think about mitral valve clip, provided that, or if it is primary, they are high or prohibitive surgical risk. Now, the spectrum of mitral valve is wide from very appropriate to prohibitive or not suitable. So from suitable to non-suitable. The ideal case for mitral clip is it is a single jet where it is in the location of A2, P2, no commissural jets, thin mobile leaflets, no leaflet calcification, no MAC, no rheumatic valve changes. Posterior mitral valve length is more than 10 millimeter. Mitral valve area is more than 4 centimeters square. No gradient, not very large gap, no severe LV dilatation, adequate septal height. We know that it's very difficult to find such patients. So you might see some patient you will find one of these in the from the green category, and then you might find another another features in the complex or very complex category. So I would say now we are doing most of these cases. except rheumatic mitral valve or severe mitral valve calcification. These two things are very prohibitive for mitral valve tear. Otherwise, you can do either of these features. So what you need to do to screen from echo perspective, the mitral clip is echo-based. They depend heavily on echo before the procedure and during the procedure. So you need the transthoracic echo. Transthoracic is our main player in here because you identify the patient initially, you identify the mechanism, whether primary or secondary severity, and you have to spend some time to give a qualitative and quantitative assessment, give assessment for the LV size and function, and look for the prohibitive condition like rheumatic or high gradient or calcification. TE will give you more detailed mechanism of segment and restrictions, mitral valve apparatus, unfavorable features, and intra-arterial septum and LA appendage, and then the choice of device. So, as we said, from transthoracic you can identify whether it's a primary or secondary, where there is a restriction of the leaflet. You have to give you have to spend some time to assess the severity of the MR, and you have to apply all your knowledge in assessment of the MR within whether it's qualitative, semi-quantitative, or quantitative assessment. Then you have to spend some time to assess the LV size and function. This is important because we know that the COAPT trial, and which I will show that the COAPT trial, where it showed a good result because simply the volume of the LV was lower as compared with the Mitral France trial, which showed negative result simply because they choose the very advanced patient. The volume was severely dilated compared to the COAPT and the Everest trial. So you need to pick your patient in this range and early compared to if you pick them late with the volume dilatation, the result will be suboptimal. So please don't wait on your patient, because if you wait longer, the LV will dilate more, and unfortunately the result will be suboptimal for those patients. The TE, again, it will identify and the segment of, the disease segment, whether it is A2, B2, or commissural, medial, or lateral. It will identify the gaps. It will identify for you the clefts, which is another features you have to be aware during the procedure. It carries a special consideration during the procedure. Again, the gaps and the clefts in the same, you have to identify during the TE. Then you have to assess if it is a primary, the flail gap and flail width. And then you have to look for the posterior mitral valve leaflet, where you should measure the mobile part and avoid to measure the chordae. MR jet also carries important, because you need to identify whether it's single jet or multiple jets. This will affect your strategy, treatment strategy during the procedure. Whether you will use one device, two device, small device, narrowed NTW or NTR or XTW, XTR. All these important during the TE. You should assess these things before the procedure. I will just skip I will go back here because I want you to concentrate more important on pulmonary vein flow reversal. These are, and the LVOT VTI. These two things that also it carries importance of, it is an indicator of successful procedure. When you put a device, you might see colors from everywhere, but if you see, the pulmonary flow reversal normalized, this is an indicator, hemodynamic indicator of success during the procedure. The LVOT VTI, now, most of the patient, when you reduce the MR, the LVOT VTI will increase. It's a forward flow will increase. But you have to be careful in interpreting these because some patients will drop their ejection fraction after the procedure immediately, and the LVOT VTI will drop as well. So yes, it's a good indicator, but you have to interpret it carefully because of the LV dysfunction. Now, in this view, I will concentrate more on the chordae because sometimes you have jet coming in very lateral or medial, and you have to be careful during the procedure not to entrap with the device if you decide to go into between the chordaes. Gradient and mitral valve area, I prefer to do it in the MBR, in the 3D MBR multi-planar reconstruction. Gradient is less important, I would say, because it depends on the heart rate, and sometimes it's affected with the MR, but more important is the mitral valve area.
3 minutes left here.
Okay. The intra-arterial septum, you have to assess it during also, because it is the key success for your procedure is a good transeptal puncture. So you have to identify the fossa, you have to look for any thickening or, don't go through BFO because the BFO will limit your manipulation during the procedure. Now, I'll go the procedure guidance. Simple, it is transeptal puncture, device introduction into the LA, optimization in the LA, diving, and then grasping. So we'll go transeptal puncture. It should be mid-posterior. I prefer always mid-posterior, so the mid between superior and inferior. And posterior, this is the aorta. Anterior, you should go posterior. And the height should be around from 4 to 4.5. So mid in the bicaval and posterior in the short axis will give you a height of 4.5, something like that. Then you have to introduce the guide. You have to be careful not to touch any of the structures, not to induce any pericardial effusion. Then you introduce the device. You position it here on the mitral valve, above the mitral valve. Then it will come to the optimization in the LA. If you do your work in the left atrium, but you have to perfect it, the procedure will be simple. You need one grasp. You don't need a lot of manipulation in the LV. So you have 3 steps in the LA, you have to do them. First, positioning of the mitral clip. You have to position the device on your target. If it's a primary MR, you should position the clip above the primary flail leaflet. If it's a secondary MR, it's A2, B2. Then test the trajectory. The trajectory is something like, it's an idea of how the behavior of the device when it moves into the LV. It should be directed toward the apex. This is always, you use the commissural view because it gives you 2 dimensions. With explain, it will give you 2 dimensions. Medial, lateral, and anterior, posterior. So when the clip, you test the trajectory, when it moves into the LV, how does it move? It should move toward the apex, not medial, not lateral, not posterior, not anterior. It should go in the middle because you need to dive into the cord-free zone, which is A2, B2. You see these cords? Your target is to move into that area, not to get entrapped during the procedure. Then you have to do the final check, which is the perpendicularity. Now, if you are dealing with the A2, B2 MR, or I mean, if your target A2, B2, it should be 12 to 6. If you go more lateral, it should go 1 to 7. If you go more medial, it should be 11 to 5. You have to respect the smile of the coaptation line, the smile of the mitral valve.
1 minute, yeah.
If you perfect these 3 steps in the LA, you have to spend most of the time, 90% of your time in the LA doing these things. Then you dive and simply you grasp. You don't need to do anything more during the mitral into the LV when you are in the LV, because if you manipulate too much in the LV, you are asking for trouble. Then you grasp, and that's it. You are done. Sorry, it's not moving, this one? Okay, it's moving. So you check now after the grasping, you have your job is to make sure that your grasp is perfect, is good. You have enough grasping of tissue grasping from the posterior leaflet and anterior leaflet. Now, I have only 3 slides. If you, it's not that much. Most of the difficulty I'm seeing during the procedure that how to optimize our image. We get used during the lab, during our TEE in the lab. We put the patient in the left lateral, and we do our procedure as usual. We flex. We used to this type of procedure into the lab, but most of the patients, when we are in the OR or in the cath lab, they are lying in their back, so images get distorted, or we cannot get the proper imaging. So you have to understand the manipulation of the probe. Most of the time, that's what I'm doing in the procedure, during the procedure. I don't retroflex, I don't antiflex, I retroflex. I extended the probe. Actually, opposite what I'm doing during the TEE, normal TEE. I extend the probe, and I get a better image. Look, if you extend the probe simply, you are putting the mitral valve into the plane, because the patient is lying on his back. The shape of the heart is different. Another trick is this. Use the left and right, the small wheel. We don't use it frequently during the procedure, during the TE procedure. But intra-procedural, I'm using it very frequently, simply because if I see that the LV is foreshortened, I will use this right flexion, and most of the time I'll get what I need. So finally, the choice of device, we know that we have now 2 companies, 2 devices, Pascal and Mitral Clip. The Mitral Clip has 4 models or 4 devices, NT, NTW, XT, XTW. So the NT, it means the short, the W means the wide. So all depends on the features of the posterior mitral valve leaflet, how long it is, and then how wide is the gap. Again, it's applies the same for P10 and ACE, and in the Pascal, both P10 is wider and larger, and ACE is smaller. It's almost compared to XTW, the ACE. Finally, this is the take-home message. I want to remind you, mitral clip is not anymore a palliative treatment. It's a definitive treatment for mitral regurgitation, and it affects both mortality and quality of life. You have to be careful for selection of your patient, and careful optimization of echo steps during the procedures. Each step you have to perfect it, and remember it's based on echo. So you are the main player in the room. The interventionist will follow your instruction. Thank you.
Thank you very much, Dr. Zakaria, for this excellent presentation. I think we will change gear now from mitral clip to tricuspid clip. Dr. Ashraf Anwar, he is going to talk about tricuspid or role of echocardiography in edge-to-edge tricuspid valve repair. Dr. Ashraf is a consultant cardiologist at King Fahd Armed Forces Hospital. We work together for more than 15 years. Dr. Ashraf. لا 15 50 years, half a century.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Basha, for introduction. Thanks to Dr. Ala and for organizing committee invited me to be with you here in this second course. My presentation will be regarding the discussion of role of echo in tricuspid valve tear. And my job now is very easy after nice demonstration by Dr. Zakaria regarding mitral valve tear. It's nearly equal in certain points, but we have some differences. I have no disclosure for this presentation. And as you know, all of us faced with such patient, significant tricuspid regurgitation, normal side, left-sided heart, and this reflected to the patient with symptoms and signs of systemic venous congestion. If you selected this patient for medical treatment, maybe have some improvement of his symptoms and signs, but by the end, the mortality rate is 66% after 5 years, even with moderate or moderate to severe TR. If you send this patient to cardiac surgery, most of cardiac surgeons are reluctant because also they have high operative risk mortality. That's why the interest was towards tricuspid valve tear, since it was introduced surgically first by Alfieri stitch and also then by mitral, it was applied for the tricuspid. And this is the latest meta-analysis published only 1 month ago, showed that success rate was 97%. It's included around 15 studies, observational, retrospective, and prospective. After reduction of tricuspid regurg volume, after reduction of the annulus, after reduction of the regurgent orifice area, it was reflected to the patient outcome in the form of 6-minute walk test, and NIA class was also improved. Also, nice article compared the tricuspid regurgitation by edge to edge or by valve replacement. It was also enhanced or encouraged to use mitral valve tear in certain circumstances with good outcome. Let's start by role of echo. The role of echo, as also demonstrated by Dr. Zakaria, is essential in all steps. Pre-procedure to select the patient, during procedure for safety and perfection guiding the procedure, and also post-procedure for the outcome. If we started by the pre-procedure, we need to select patient properly, because the role of echo now is for functional assessment and also anatomical assessment. The functional assessment will include tricuspid regurg and right ventricle. You have to use all modalities that you have by transthoracic, by transesophageal, color Doppler, pulse Doppler, to quantify the severity of tricuspid regurgitation. Whatever you have in handled, because mitral valve is a little bit easier than the tricuspid valve, whatever you have available for tricuspid valve, you have to collect all of these parameters. If you are able to calculate regurgent orifice area, if you are able to calculate regurgent volume fraction, you have to use all these to end with a list of parameters that can help you to judge for the severity. And if you look for the severity, the parameter is not so much. But if you look to the severity now, the new classification of tricuspid regurg is not so simple like before. Now the severe form of tricuspid regurg is divided into severe, massive, and torrential, based on these parameters. And also, after you classify mitral tricuspid regurgitation, you have also to look for the underlying etiology. And again, it's not so simple like before, primary or secondary. Nowadays, the secondary tricuspid regurg is subdivided into atrial, functional tricuspid regurg, ventricular functional, and the last one is intracardiac devices. Because again, based on this classification, the management will be so different between all of patients. Look to this patient. If you have patients such like that, you have CRTD, multiple wires inside the right ventricle, inside the right atrium, and all of these are crossing the tricuspid valve. If the patient has significant tricuspid irritation, it will be a challenge. Go to the second assessment of echo, is the functional assessment of the RV. And again, the complex anatomy of the RV, making it so difficult to use only one frame or one image. You have to rely on a lot of images, whatever you obtained from parasternal, from apical, from subcostal. You have to use all these views. And again, you have to use all the available parameters that indicate right side, right ventricle size, either normal, dilated, or massively dilated, either dimensional, if you use basal dimension, if you use area changes, and by the end, you have also to rely on simple parameters. It's indirect parameters, yes, but this is available parameters for assessment of the RV. If you relied on TAPSI, simple. If you relied on fraction area change, if you relied on tissue Doppler for S velocity, and all these parameters for abnormality. There is no grading for the severity, but at least to know that you have normal or abnormal. Even if you can rely on performance index, before we are talking about TI index, either using pulse Doppler for tricuspid and for pulmonary, or you can use tissue Doppler, and this is a nice article published here with the collaboration of Dr. Basha at that time. This is normal reference value, categorized by male and female, and all age group. Strain quantification also help you better to assess, especially if you relied on the free wall longitudinal strain for the RV, and this is a meta-analysis for normality included more than 4,000 patients, subject, normal subject, and this is a normal reference value if you relied on it for the assessment of normal or abnormal. If you have the 3D software dedicated for the RV, also will helpful for quantification, now accurate quantification for the end-diastolic volume, end-systolic volume, and ejection fraction. And also this is a large study published recently, 2023, included more than 1,000 patients, and this is the normal values for male and female. By the end, if you collect all these parameters from 2D, from 3D, from dimension, from area, you can also understand now the right ventricular remodeling and the response for right ventricle from normal subject to hypertension for pulmonary artery pressure or for dilatation for volume overload. Last step for the echo before you select the patient is the hemodynamics assessment of right atrial pressure from the IVC, very simple, and also assessment of right ventricular systolic pressure, pulmonary artery systolic pressure predicted, pulmonary artery mean pressure, or pulmonary artery diastolic pressure from simple parameters, as you all of know, from continuous wave Doppler and from pulse Doppler. If you finish our functional assessment, the second step will be anatomical assessment. And now we are targeting the tricuspid valve. We will target the leaflets, we will target the jet, what we have to identify the jet, and also the jet we are targeting to repair. This is a complex anatomy. Again, it's a complex like mitral, but even more complex for the tricuspid valve. And if you can imagine, before the 2005, before the era of 3D, there is no consensus between all the famous textbooks regarding which leaflet that we can see in each view. 2006, I started to use, please. Excuse me. I started to use the 3D to identify the leaflets. Yeah, simply you can see that this is septal leaflet, this is anterior, this is posterior. But what about the transthoracic? At that time, I was putting a landmark for the septal leaflets, and I tracking here this mark in each view. And you can imagine that we have septal leaflets in fourth chamber. 100% this is the septal leaflet, and also 100% this is the posterior leaflet. When we are looking for parasternal inflow, 100% this is the septal leaflets, 100% this is the anterior leaflets. But in short axis, it was a surprise. 90% that this is the posterior, but this one, maybe 50% that we have anterior, 50% that is septal. Where is the movie? No, the first one. Yeah. This is the image by transthoracic. At that time, there is no available transesophageal. And it's already published at that time, and then repeated later on by many investigators. Why is this difference? Because this is related to the cut plane. If your cut plane is here, and you are just deviated 1 millimeter up or 1 millimeter below, you will obtain different segmentation and different leaflets. For a simplification now, because we are understood the situation, there is no doubt about apical fourth chamber, but the difference will be in RV inflow and will be in parasternal short axis. This is a RV inflow. If you see in your image that this is a coronary sinus, so simply you can identify these leaflets by this cut plane. If you didn't see it, so now you identify another leaflets. In short axis, also, this is a, like we said before, this is a, oh, nobody answer? Anterior or posterior? Perfect. This is a posterior, this is anterior, because this is a little bit related to the aorta. So this is anterior, this is a posterior. So what about the TE? Because all of us now are familiar with the TE, simply also that we have to understand the situation. If you are near to the aorta, this is the anterior, this is the posterior. If you are using X-plane, also you can track it, this part. So you are sure this is the posterior. So if you look to the other part, this is the posterior, but this one is the septal. If you have cut plane or X-plane on this part, so this is the anterior, for sure the anterior, the other one will be septal, and this one will be the posterior. So that's why all of us assuming that we have 3 leaflets, and we are trying to track septal, anterior, and posterior. But imagine that anatomical studies showed that only 54% of the patients have 3 leaflets, and we have more than 40% of patients have additional leaflets, 3, 4, and 5. And this is not very rare, as we are assuming this is very rare. This is one example of patient we done already last 2 weeks in our center. Sorry. How many leaflets that you can see?
3.
It's not 3. Yeah, just try to consider this is a movie image and this is a fixed image. It is the same image like I saw you here in this part. So 1, 2, 3, and 2 small. And this is all the commissures in the semi-closure or semi-opening that you can identify these leaflets. So we finish the tricuspid valve assessment, anatomical assessment, then do the same in same sequences, either by transthoracic or transesophageal, to identify the regurg and to identify not only the severity now, because already we finish the severity, but to identify the jet, where it's localized, between which leaflet and at where it is at the commissural part or at the central part of the leaflets. Same sequences, started by fourth chamber view from mid-esophageal, started also by RV inflow, RV outflow. Save your time by using X-plane. This will help you to identify the jet. If you are going to deep esophageal also or lower esophageal, it can be helped, because sometimes we are using standard views in mid-esophageal and we can't be able to assess the severity or assess the localization of the jet. So use also upper esophageal, mid-esophageal, and use also lower esophageal with the same angles that you are doing it from 0 to 30. X-plane, it will be 60 to 90, and also mid-esophageal.
3 minutes, please.
3 minutes, okay. Again, deep esophageal also will help you. Then after you identify the jet, it will be easy for you to track. Why we are doing all these assessment, functional, anatomical, tricuspid gauge, RV, because this is the key of success, as this demonstrated before by Dr. Zakaria, for patient selection and for the decision. And this is the ideal feature. We have to rely on it. So it's included the morphology of the leaflets, yes. It includes the coaptation, yes. But nowadays, it's included the presence of devices or not. Remodeling also is counted. If you have a patient with normal RV, normal function, normal size. If you have a patient with normal pulmonary artery pressure, this is the ideal pathology to deal with it. If you have a patient with some abnormality in the RV, dilatation or dysfunction, if you have device but not the cause of impingement of the leaflets, if you have also short leaflets or if you have coaptation gap larger, it's a challenge. But here, this is the contraindicated criteria, and if you tried even with high experiences, you will not be able to get optimal success or resonant success. For proper decision, not all cases are candidate for tricuspid valve tear. You may use in these situations according to this algorithm, but you may also add annuloplasty to help for the outcome. As demonstrated by Dr. Zakaria, we have two devices, either Pascal or a mitral tri-clip. During the procedure, I will save your time for this one because the time is running, and this is just demonstration for nice case already done 1 month ago in our center. You can see this patient have severe TR, okay? And we started already planned for the tricuspid clip. Now with tricuspid tear, we haven't intraseptal puncture. So coming from the femoral vein to the right atrium, inferior vena cava, right atrium, superior vena cava. Then we'll pull back your device and guiding catheter to be faced towards the tricuspid regurg. Start use the color to put the device at the center of the jet. You can guide it by the TE, 2D, or 3D will help you also. Open the device to select for perpendicularity according to this, which leaflet you are targeting, septal anterior or septal posterior. Diving inside the right ventricle, open the clip again, coming close to the valve. Make sure that both leaflets are laid down. Make sure that you are not in the commissure. Make sure that you are not at the tip, only of one of these leaflets. Then we start to do partial closure. Assist after partial closure, the residual jet, mitral main gradient across the valve. Then, if you are satisfied with your result, do complete closure of the device. And this was the final result for this patient. I think it was residual trace to mild TR. If you are interested with this topic, not only for the tear, but also for the tricuspid valve, you can revise the chapter of tricuspid valve in the first edition and second edition, and was honored to be the first and second author for all these chapters. And also this textbook is free online from Springers also, including all these things, chapters from medical, from clinical, from imaging, and also from management. And this is the latest also guiding to all of us regarding the structural heart disease. Nice article published 2 years ago by Rebecca Han, but also still working well. My final message will be the role of echo is crucial for tricuspid regurgitation management by tear in all stages, and this is the key of success. The pre-procedure scanning is very, very important because it helps you to understand the mechanism, the severity, and guide you for selection of the patient. And this will also necessitate to have a learning curve from time to time. You can use transthoracic in addition to transesophageal. You can use a standard view that you are familiarize yourself with it. And this is the last thing, so I bring Allah subhanahu wa ta'ala at the end of Shaban. Allahumma balighna Ramadan.
Thank you very much, Dr. Ashraf. Really comprehensive, very useful talk. And our next speaker is Dr. Hisham Naim. He is a consultant in Medina Heart Center. He is very expert in imaging structural heart disease, long experience, and he will show us challenging cases in mitral valve clip. Hisham.
What is this mitral valve? في حاجة مش كده؟ طيب, this is the final result of the procedure. Then we will go back to see what happened. This is as Dr. Zakaria explained for the mitral clip. This is septal puncture, and try to go as much as posterior here, and to measure it 4.5 centimeter. The depth of the catheter is very crucial for the interventionist not to go out. And this is the first clip, and there is posterior or medial to the clip. There is still mitral regurg. We try to put the clip at the same side as usual. Again. And this is the result, and we find there is moderate regurg medial to the clip. To leave or to put another clip, challenging. Every interventionist, every echocardiographer, he want a perfect result. He didn't want to have a residual mitral regurg. I believe this is not the correct concept. So in some cases you should accept a medium result, not try to complicate the things. This is the first clip, and this is the two orifices, as you can see. And we decided to try to put second clip for this moderate residual regurg. After putting the second clip, there is again regurg in between the two clips. So it is more than before. We cannot leave it. So we decided to go to put third clip in between the two clips. Gradient was good. Okay. Gradient allowing us to put the third clip. So this is the residual regurg. Still. So second clip and third clip for the echocardiographer is a nightmare. You cannot see leaflets. You cannot decide grasping very well at the first clip because the shadow of the first clip is covering you. So we bought the third clip in between the two clips, and still you can see all the mitral valve is disturbed, and still there is significant regurg, or even severe regurg again. So what can we do here? Fourth clip. Send them for surgery. Okay, because we believe that most of this regurg is coming in between both clips. So we think why we didn't deal with this one as a paravalvular leak. Why we didn't close this defect between the both clips by a device. This is the severe residual regurg, and this is the paravalvular leak device. Vascular plug, I think 12 millimeter. We put it in between both clips. Okay, this is the one device. The regurg decreased, but still there. So again, we didn't accept. We bought another device. So we bought another one. Where is the second one? Oh, what happened to the mitral orifice? This is the mitral orifice remaining, and this is the three clips first, and this is the vascular plug first and second. So we close this area completely, and we remain mitral valve orifice only this one. This is the devices. This is this is one device, two device, 3 clips. The main gradient at the end was with this small orifice, 1 millimeter mercury. I don't know. I don't know why. How come? This is a now 4, yani, 4 accepted also. This is the residual mitral regurg at the end. It is like trace to mild.
Who is paying for these 5 devices? The patient or
the 3 clips with the same price. There is no extra cost for them. And the 2 vascular plugs is not that expensive. Don't worry. This is the final result. I will show you. We call this one is Taiba technique, and we publish it in JAC. And this is the final result. This is the valve, and this is the regurg here. This echo is 3 months after procedure. The patient is doing very well. Trace mitral regurg. This is the short axis. All the mitral valve here is disappeared. Only this area is working. This is the mitral orifice. You can see it. Again, short axis. And this is 3 clips and 2 devices. And this is a residual mitral regurg. So, no, this is not moderate. I will call it trace, don't worry. And this is the follow-up. Mean gradient now, you see, sometimes 5, sometimes 8, should be increased. So the home message from this case, you never expect what you are facing during mitral valve clip, especially trapping, especially for the second and third clip. You didn't see grasping. You grasp only with guidance of the site of the first clip. You didn't see actual grasping of both leaflets. So this is one case.
what was the planimetry for that orifice, the residual orifice?
You cannot measure it. You cannot. Okay, second case is mitral valve ring. This is mitral valve ring. You can see the ring is far away from the orifice, and there is severe, the annulus, and there is severe mitral regurg here. Severe mitral regurg at the level of the leaflets down and coming from the ring up. The 3D here is very nice. I want to show you the 3D. This is the mitral valve ring, and this is the defect where is the regurg is coming. So you can call it what? Para ring leak, maybe. So you can ask me why you are presenting this case here. You should present this case in the first lecture with the paravalvular leak closure. You can put device here and close this regurg. You see, this is this hole, all the regurg is coming from it. This is the one. This is the ring, and this is the hole, and all the regurg is coming from here. So the first thing, we can put a device here and close the leak. But if you go back, you will find the origin of the regurg at the level of the leaflets. Not here. It is coming at the level of the leaflets, then going to this. So we think, why, if you put clip for the leaflets and the regurg disappear, then there is no blood will come to this orifice. And this is what happened. So we decided to start with mitral valve clip. Mitral valve clip in presence of mitral valve ring is again very challenging, because the shadow of the ring covering on you, and you cannot even get good 3D images for the mitral valve from the atrial side. So this is the clip here. We clip the leaflet down. One clip only was perfect, and there is only trace regurgitation after one clip. You can see there is no regurg here, and the 2 orifices very good. This is simple procedure. Mean gradient is 2.
This is the 3D.
So it was transvalvular, huh? It's not transvalvular, not paraannular, huh?
No, it is transvalvular and then the jet coming paraannular. Yes, this is what happened. That's why when you close the transvalvular down, there is nothing coming now from the defect out. And this patient is also doing very well. Still we have time or?
2 minutes, please.
2 minutes, okay. Let's just go for this nice one. This is a flail leaflet. After the first type, the XT now of the mitral clip, we are no longer going for 11 millimeter width of the flail gap or flail width. Whatever the flail gap and width, even if it is wide, you can go and you can try to do mitral clip for it. The distance here is 1 centimeter and the flail height is 1.5 centimeter. Again, 1.3 and 1.5. It is more than in the guidelines, but we have a longer clip, so we can go and try to grasp this one. This is a B2, the problem in the B2. This is a 3D vena contracta, and this is a B2. This is the area where you need to grasp it. Again, we go with the clip. We catch it. So now it is fixed. It is not mobile like before. It is not more flail one. Why the image is not running? Whatever, this is trace remaining mitral regurg with only one jet. So the home message from this case that now with more flail width and flail gap with XT, you can go and you can try to clip it. This is the short axis. This is the final result. Follow up this maybe after 6 months. There is only trace mitral regurgitation. So mitral clip is interesting and still dependent in the echo. And as my colleague said, it is not more symptomatic treatment. It is improving the mortality now. I think the more cases you do, the more challenging you will face. Thank you very much.
Thank you very much indeed for these excellent cases. And I think we will have a virtual talk now from UK. While they are preparing for the talk, if there are any questions, please, to the previous speakers, please go ahead. You are ready? No? Okay then, we will have time.
Hatem,
please.
Thank you so much. And I think the case of the vascular plugs was kind of unorthodox therapy. And the role of the imager is not only to guide the interventionist to the proper positioning, but also to guide the mood in the room. Because the interventionist might sometimes feel egotistical and stubborn to carry on. And I think this was kind of, because if you incarcerate vascular plug in between the slits, that's going to endanger the stability of the clips themselves. And we don't know exactly the interaction between the plugs and the clips. And I am not convinced that this patient has not mitral stenosis, or he might develop mitral stenosis down the line.
I agree with you. And then the FDA and approval and guidelines, and I think, I don't know, but yes.
The mic.
You are dealing with a patient with ejection fraction of 10%. You have severe mitral regurg on table. The patient is deteriorating, getting in shock. Surgeon is around you, everyone refusing to take the patient to surgery. So what you can do? We are thinking out of label. We are not going now with the guidelines. We are going to save the patient. So you have the chance to put the plug and see what will happen. The patient is now 5-year survivor. He survived, alhamdulillah, and he's doing well.
And regarding stenosis, yes, this case done 5 years ago. And mitral stenosis, I show you a follow-up after 1 year, the mean gradient 5 to 8. There is moderate mitral stenosis. This is very accepted, yeah. So it is not a matter of label guidelines. You can go out, I can show you many of the cases that we did it out of label because to save the life of the patient. We have a patient with infective endocarditis, left atrium, aorta to left atrium fistula, severe pulmonary mechanical mitral valve, severe pulmonary congestion, heart failure, everything, and refused to take to the surgery. We go out of label and we put a vascular plug inside the infective endocarditis to close this fistula, to bridge the patient for surgery. So a patient bridged for surgery and doing very well. So not all the guidelines you can follow actually.
Okay, thank you. Okay then. I think we are ready for the next speaker from UK is Dr. Hazem Lashin. He is consultant in cardiothoracic intensive care medicine at Barts Heart Hospital in London. He is going to talk about the role of ECMO in ECMO, which is commonly used, unfortunately, with all these procedures and interventions. Dr. Hazem, the floor is yours.
Thank you for the introduction. And let me share my slides. 1 second. Can you see my slides? Can you see the presentation? Yes.
Yes.
Thank you. Thank you for the introduction. This is a very quick overview of the role of echo in ECMO. I have nothing to disclose. So the objective of this talk is to briefly go overview of ECMO setup for those of us who are not so familiar with it, and also the role of echo in the diagnosis, ECMO implantation, cardiac monitoring on ECMO, complications, and explantation. The focus of this talk will be primarily on peripherally implanted ECMO because this is probably more common, and also on the use of TTE rather than TOE. What is ECMO? It stands for extracorporeal membrane oxygenation, which is basically a pump and an oxygenator. And it is used as a temporary support for acute severe respiratory failure. And this is what we call VV, veno-venous ECMO, where the blood is drained from the venous side of the body and returned to the venous side, usually to the right atrium. And also it could be used as a support system for acute severe cardiac failure, where we call it veno-arterial ECMO, VA ECMO. And the blood is also drained from the venous side, but this time is returned to the arterial side, usually to the femoral artery, to provide the body with oxygenated blood when the heart cannot do its job. Traditionally, TOE has been the modality of echo that has been often used with ECMO, but with advances in TTE and also with expertise within critical care medicine in TTE, this has been more and more common use, and certainly in our center, we primarily use TTE for these patients. So in the first instance, the role of diagnosis in VV ECMO, these patients have got acute severe respiratory failure resulting in severe hypoxemia and hypercarbia, as well as high ventilatory pressures in order to keep on conventional mechanical ventilation in order to keep these patients alive. And usually they also require quite a lot of vasoactive medications to maintain the blood pressure. Often these patients will have a right ventricular dysfunction, as you can see in this clip, before they go on ECMO. The vast majority of patients, once they put on ECMO, and the gas exchange has improved through the device, this RV impairment resolves to a great extent. However, in some patients it doesn't, and this may it's something to be aware of when you are implanting ECMO, and also because that will influence the management, as well as if it persists, it may require a combination of VV and VA ECMO to support this patient. Therefore, it plays an important role in decision making. In the VA ECMO, it's the cornerstone of diagnosis in order to identify the causes of cardiogenic shock, and also to see if the patients are suitable or not suitable for VA ECMO. By and large, the most common indication is LV dysfunction, secondary to acute myocardial infarction, myocarditis, or decompensated dilated cardiomyopathy. Also RV dysfunction, as we've seen in the previous clip, or in patients who had RV infarction. And these are the most common causes of implantation of VA ECMO. Also, ECMO will help us to diagnose acute valvular heart disease causing cardiogenic shock, such as acute severe aortic insufficiency or mitral insufficiency, and these are not suitable for VA ECMO. Also, LVOT obstruction as a cause for cardiogenic shock, again, not suitable for VA ECMO, and pericardial effusion, which only usually requires drainage. Another aspect of diagnosis before implanting VA ECMO is the degree of aortic insufficiency. So patients who have, let's say, LV dysfunction, severe LV dysfunction, requiring VA ECMO, but they have got aortic insufficiency, this can result, is a relative contraindication to ECMO because of the counterflow of blood from the return cannula can result in increase in the LV, left ventricular end diastolic pressure, and that may make the LV dysfunction worse. So again, this is another aspect that is important for decision-making in this cohort of very sick patients. A quick overview of ECMO setup. On the left, this is a standard setup for VV ECMO for respiratory support. There is 2 cannulas implanted, usually to the bilateral femoral veins. The drainage cannula is usually a 25 French multi-stage cannula implanted into the IVC, as you can see in the schematic, just before the RA-IVC junction. And the return cannula, which the oxygenated blood is returned to the body, is usually a 21 French cannula, which is implanted slightly further into the right atrium with the flow of the return blood towards the tricuspid valve. And the significance of this will be discussed later. On the right-hand side, we have the VA ECMO for cardiac support. So the blood is drained from the same place as the VV ECMO through the IVC, most usually. And the return cannula is usually a 15 French return cannula into the femoral artery, which returns the blood into the aorta in order to supply the body with oxygenated blood when the LV is failing or the heart is failing. So echo is very important for ECMO cannulation. As you can see in this clip, these cannulas are inserted through a Selding technique. So a guide wire is inserted first, and then serial dilatation, followed by the insertion of the cannulae. Then, so in this clip, you can see the guide wire for one of the cannulas into the IVC through a subcostal view, which is the standard practice for insertion of the VV ECMO cannulae. This is a modified subcostal view, hopefully start working, which is what we call bicaval view, where you can see the IVC and the SVC, not very well in this case, but this is the theory anyway. As you can see in this clip, there are 2 guide wires. One is quite clear in the RA, and there is another one just under it in the IVC. And now we have the 2 wires in situ, and then we can proceed into advancing into dilatation and advancing the cannula. This is the same view of the same patient, where you can see the one of the wires still in the RA, and then the cannula, the drainage multi-stage 25 French cannula, has been advanced into the inferior vena cava, as you can see there. Then once the two cannulae are inserted, as you can see in this subcostal IVC view, you can see the cannula going to the RA, which is the return cannula, and the drainage cannula just under it in the IVC. Then we use a color flow Doppler to look at the flow of blood into the right atrium, and the flow of blood, as you can see this clip, should be towards the tricuspid valve. The idea behind that, if the flow of blood is not going directly into the right ventricle, this can cause what we call recirculation, which is reduces the efficiency of ECMO, and also if it is not in the right place, it can return the blood into the hepatic vein, and that can cause congestion of the liver with all the associated complications. Then into VA ECMO, so over and above the insertion of the drainage cannula into the IVC, then a wire is advanced through the femoral artery into the aorta, and as you can see there, this is a modified subcostal view to look at the aortic valve, the aortic artery, sorry, the aorta, and you can see the guide wire into the aorta, and this is what the cannulator wants to see before they start dilating and inserting the return cannula. However, my favorite view when cannulating for peripheral VA ECMO is the lateral abdominal view. Unfortunately, I haven't got a live view of this. In this view, you can see the IVC and the aorta both in the same field. You can use a curvilinear probe or a phase array echo probe, whichever is more comfortable or familiar. And in this view, you can see the both guide wires in both vessels, and that will give me and give the cannulator confidence before starting to dilate and inserting the cannulae in these very sick patients. The next use of echo in ECMO is obviously diagnosing cardiac function while on the, or investigating cardiac function while on support. The first, in VV ECMO, these patients have got extensive lung disease, as you can see on the X-ray on the left. And this will make TTE much more difficult, and the diagnosis of to be able to look at the LV or the RV in these patients with TTE is difficult. Therefore, in these patients, we tend to use ultrasound enhancing agent or contrast agents, which improves the views significantly. And we tend to use that on a regular basis in these patients. In a recent study, we have investigated the efficacy and the safety of ultrasound enhancing agents in patients on a mixed cohort of VV and VA ECMO patients. And the results of the study has shown that it improves the endocardial body definition from suboptimal to good, and triples the feasibility of LV ejection fraction measurement in these patients from 28% to 83%. Also, we investigated the safety of ultrasound enhancing agent in these patients, and we have monitored many parameters, as you can see in this very busy table, over 24 hours following the injection of ultrasound enhancing agent, and it did not have any significant impact in any of them or on ECMO parameters. In VA ECMO patients, echo is also very important to look at the change or improvement or lack of improvement in LV function in these patients. As you can see on the left, this patient when they first gone on ECMO, and on the right-hand side, you can see when the LV function has improved. Also, a very important use of echo in these patients is to investigate complications that may arise on ECMO. In VA ECMO patients particularly, it's very important to ensure what we call AV opening, aortic valve opening. As these patients' LV function is very poor, they are at risk that they cannot generate enough stroke volume to open the aortic valve, generate pressure to open the aortic valve, and this results in blood being stagnant in the LV, and this can have catastrophic complications, as we can see later. In these patients where the aortic valve is not opening, unloading strategies have to be implanted either through an impeller or an intra-aortic balloon pump in order to unload the ventricle, so prevent the blood from being stagnant and clotting. One of the most commonly used ways of unloading the LV is through an impeller. And as you can see in this clip, the impeller is implanted, and echo will help to guide the implantation as well as check the position of the impeller cannula, as you can see in this case, which is in the right place in the cavity of the LV, not too far in, about 3.5 centimeters from proximal to the aortic valve, and also to make sure that the LV is well filled and not collapsing, and also the RV is functioning. If we fail to unload the LV, this can be the catastrophic result. I haven't got a moving image of this, unfortunately, just a picture where the LV clots, and this is usually a terminal event. Another complication that happens often in patients supported by ECMO is a thrombus, and in this case you can see a thrombus attached to one of the cannulas as you can see, it's floating around in the right atrium, and this is important because this may break off and cause pulmonary embolism. And this may have an impact on the anticoagulation strategies that we employ. Another common complications that can have also catastrophic events is pericardial effusion, which can happen anywhere around the heart. And you know more about this than I do. So another important use of echo in patients or in VA ECMO is weaning. So when we think that the patient has reached a stable situation and the LV has improved enough, then we perform what we call a weaning study. In a weaning study, we start the patient on full flow, so let's say 3.5 liters per minute of ECMO flow. And on the left-hand side, you can see a short axis image at mid-cavity of the LV on full flow. And then we reduce the flow, say by 1 liter, as you can see on the right top image. So this is reduces the ECMO flow from 2.5 liters. Therefore, this loads the heart, so more blood is going through the heart. And this is a test of how the LV will cope with increased loading. And as you can see, the LV function in this view has improved. Then we go down further to 2 liters, allowing more blood to go through the RV into to load the LV, and it seems to be coping well. In order to confirm this, we tend to use a LVOT VTI in order to have a numeric value, not just a visual impression. So on the left-hand side is the VTI of the patient when they were on 2.5 liters of flow. So that was 15 centimeters LVOT VTI. And when the flow was reduced further to 2 liters, the VTI has improved to 16.7, which is a further assurance that the LV is able to generate more output and cope with the increased loading. And this is helpful in decision-making for explantation of VA ECMO. So in summary, echo is an integral part of ECMO practice. Echo is essential for diagnosis and monitoring of progress of patients on ECMO, also diagnosing complications, and important for weaning studies in preparation for explantation. Contrast echo is safe and enhances diagnostic yield in this cohort. Transesophageal echo is an alternative when TTE is inadequate. Thank you for inviting me, and thank you for your attention. And I'd like to have any questions.
Thank you very much indeed for excellent presentation. I have one question actually. How often you need to go for TEE in such patients?
This is our chosen modality. So in our center, we hardly ever use TOE. So TTE is what we use.
Okay.
Only if TTE is inadequate or it is a valvular issue. So if it's a valvular issue, then we sometimes use TOE. But mostly it's TTE. 95% of the time, I would say.
Okay. Well, I think we have one question from Dr. Rahi.
Yes.
I'm a pediatrician, so do you do venous as well with the same strategies in children?
We only, I'm only working pediatric, in adult intensive care, so I can't answer that question. I'm sorry.
Okay. Well,
I
thank
don't
you.
know.
Hmm? Okay, I think thank you very much indeed. I think for the sake of time, we will close the session. I would like to thank all the speakers for outstanding talks today, this morning, beautiful talks, and thank you very much for the attendance, and thanks for our co-chairman, and we will see you again in 10 minutes after a short break. Thank you very much indeed.
Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds, 2 cath labs, 1 hybrid OR, a team of humans taking care of our fellow humans, with technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 hybrid OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 hybrid OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 hybrid OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones.
فيديو ايوه جرب فيه خلاص
Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almusa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 Hypert OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones.
هلا. Assalamu alaikum. I think we should start. Hello? We will start our session because we don't want to be delayed on the break later on. And today my name is Fatima Qaddoura. I'm a consultant cardiologist in Habib Hospital. And sharing with me is Dr. Fayez. He's a consultant cardiologist, full professor in the King Khalid University Hospital in Riyadh. Today we are starting with the big head people. The one I've known, as he told us, 25 years. I was a specialist, by the way.
No, she was only 2 years old at that time, for correction.
In fact, I have 3 fathers, 2 fathers and 1 mother. It's Dr. Hassan Basha, Dr. Ahmed Al-Imran, and Dr. May Shahid. I always get, if there is anything I have, it's from those people who have led the Kingdom of Saudi Arabia to the best in their echoes and their performance, their wisdom in taking decisions. So if I learned anything and I gained anything, it's Saraha, after God bless, it's from them.
Jazakallah khair. Thank you.
Dr. Hassan Basha, he's now member in the Saudi Heart, director member in the Saudi Heart Association. He left already the Armed Force Hospital and now he's working in a medical center. He's going to talk to us about the echo in amyloidosis. I think this is very interesting and very important topic. Please, Dr. Hassan.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد الخلق والمرسلين حبيبنا محمد صلى الله عليه وسلم. Good morning everybody. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. My talk, I would like, before I talk, I'd like to thank Dr. Fatima for such a nice introduction. Jazahallah kull khair. why actually the interest in cardiac amyloidosis nowadays? I think before that, we will just say that systemic amyloidosis are characterized by protein misfolding with tissue deposition of the insoluble fibrils in the tissues. There are two most common types of amyloid cardiomyopathies caused by either aggregation of trans-13, and we call it ATTR, or the other type, immunoglobulin light change deposition, and we call it AL amyloidosis. Now, now, the deposition of amyloid fibrils in the organs causing several manifestations. And we're talking about the heart. It is deposited and the myocardium and causing extracellular infiltration leading to stiffness and LVH with all extracardiac and intracardiac manifestations. Now, the cardiac manifestations involve mainly heart failure, atrial fibrillation, arrhythmias, and conduction difficulties or abnormalities. And this is what's behind the great interest nowadays in amyloidosis. This new medicine, the tafamidis, which appeared a few years ago. And before that, we had actually in these patients, we've seen deterioration in their ejection fraction, deterioration in their renal function, more hospitalization, and so on. So their life was really very dismal. Now, we have a position statement from the European Cardiac Society, appeared in 2021, and what it says, actually, you have to suspect amyloidosis if the patient has on echocardiography left ventricular wall thickness more than 12 millimeter with 1 or 2 red flags or clinical scenario. These are the red flags here: heart failure above 65, aortic stenosis, proteinuria, etc., etc. Now, there are two ways, of course, of the diagnosis. In non-invasively, we start with, as usual, in patients with ATTR, and the invasive will be required in all types of amyloidosis. We will come to the diagnostic algorithm later on. Now, these are the two types of amyloidosis, as I said, the ATTR and the AL. Unfortunately, echocardiography cannot distinguish between these two types. So that's a fact. Now, let's see what are the typical echocardiographic findings in amyloidosis. We start always with the parasternal view, and there is ventricular wall thickness, as you can see there, atrial dilatation. Sometimes we see a small pericardial effusion. And when we come to forward chambers view, again, we see biventricular wall thickness, we see biatrial enlargement and thickening of the mitral valve or valvular leaflets. I'll try to move forward. Yes, remember, actually, these tips are very important when we're measuring the septum. Sometimes we see extra tissues from the right ventricle, moderator band, or others. So that's how we have to measure it there. And if we need to, we measure the thickness on short axis view. So that is another view. Now, right ventricular wall thickness may have to be measured from subcostal views. We can measure it there, even using M mode in such patients can lead to accurate measurements of right ventricular free wall. Very important to get a proper assessment of left atrial volume index. This is extremely important, even if we have to get certain modified views. Now, what about the Doppler echocardiographic features of amyloidosis? Of course, you get the restrictive pattern. The restrictive, I think we lose in the pointer. Anyway, I don't know whether we have it's faded. First of all, we have actually the high E wave, small A wave, and the EA ratio is more than 2. We get short deceleration time. We get the blunting on the top right here, blunting of the systolic wave of pulmonary venous flow. We see reduced mitral, annular, septal, and lateral E prime velocities, leading to the E over E prime more than 14. We all know this for fact. Now, when do we have to use the speculate tracking in such patients? If the study is suggestive of cardiac amyloidosis, oh, thank you. If there is a clinical probability is high, if there is undifferentiated left ventricular wall thickness. Now, strain shows atypical apical sparing, and that's what we see here. That's actually the apical sparing with the GLS, leading to what we all know about the cherry on top. Now, this is actually because more involvement of the amyloid in the basal and mid segments, but sparing the apex usually. Now, this is what we see on the speculate tracking. Very, very interesting actually picture, and this is typical of the cardiac amyloidosis. Again, we have to remember that every vendor has got his own pictures here, and you can see whether you are using the Tomtec, the EchoPack, or the Philips. These cherry on top appear differently. Now, we have recently actually seen, this is a nice case, we have to remember there is another thing called the blueberry on top phenomenon, and that we see it in patients with apical hypertrophy, because this area is usually has very low longitudinal strain. So that's what appears here. So remember, blueberry on top, in contrary to the cherry on top, and this is in 2024. Now, these are the red flags on echocardiography. I don't think that to repeat them. Increased left ventricular thickness and right ventricular biatrial enlargement, diastolic dysfunction, grade 2 or more, severely reduced mitral annular tissue Doppler velocities, and so on. These are the common features which raise your suspicion of cardiac amyloidosis. Now, this is just an example here of cardiac amyloidosis. You see quite thick ventricle, the left atrium is dilated, thickened mitral valve leaflets, and a small pericardial effusion, and you see this cherry on top phenomenon. Now, why cardiac MRI? I think it plays extremely important role if you have it in your hospital. I think this is extremely important in such patient to improve your diagnosis. So again here, actually you get all the manifestations there on the cardiac MRI. You can see the thickness of the ventricle, you can see the small pericardial effusion, the biatrial enlargement, and so on. So you get all the features. So we cannot ignore, and this the role of cardiac MR in such patients. When there is late gadolinium enhancement, white is dead. So when you see such a picture, when you see such white areas in both ventricles and most of the cardiac chambers, you know you are dealing with cardiac amyloidosis. So another case here with the thickened ventricle, as you can see, a left atrial dilatation, and you can see that biatrial enlargement, thickened mitral valve leaflets, the cherry on top phenomenon. So that, I think, will make your diagnosis very likely, although actually it cannot be 100% sure, but you need further investigation. This is an 82-year-old patient with dyspnea and syncope, and he got biatrial enlargement, impaired LV function, and he gets an ICD. Another case of carpal tunnel syndrome, 76-year-old patient, referred for echocardiography, and this actually his echocardiogram, again showing similar pictures, similar findings of thickness of the left ventricle, left atrial dilatation, increased thickness of the mitral valve leaflets. Now, this is just sum it up again, all in one picture. So that's an end-stage amyloidosis. You can see that the patient has impaired LV function. What's important is to pick up these patients at early stage, not to wait until they reach such an advanced stage where actually the treatment may be difficult. So this is just summing up with this slide the findings on ECG. You get low voltage, you may get pseudo-infarction pattern on the right side with atrial fibrillation. And again, I think the pointer is not, okay, now it is good. Thank you. Again, the same pictures, what I've seen, what I've talked about, the high E, the small a, and we see the TAPSI reduced when the right ventricle is involved. Again, we see here the isotope scan, the technetium-99, very useful in establishing the diagnosis. And we have novel imaging nowadays with atrial strain and novel images with cardiac MRI. So there is actually some thoughts about the apical sparing. There is limitation for everything in life. So this is a recent, not article, a recent study in the European Heart Journal, appeared in January 24, and it did actually analyze over 500 patients with cardiac amyloidosis versus 200 controls, and the conclusion that apical sparing did not prove to be cardiac amyloidosis, a specific biomarker for accurate identification. But it is still very useful. There is nothing in life, 100% sensitivity, 100% specificity. We have to remember this. I will skip that. This is actually now another recent study in January 24 on the right and left atrial strain to differentiate cardiac amyloidosis from Fabry's disease. And this is small study involving 47 and 88 patients. So there are special features here on strain, left atrial strain, in patients with cardiac amyloidosis compared to Fabry's disease. Now, remember, those who worked in old days with the granular sparkle we used to talk about in diagnosing amyloidosis or raising the suspicion of amyloidosis. This is because it was at that time we were using the fundamental frequencies. Of course, nowadays we use the harmonic imaging, which attenuates these sparkling, so we don't see them very often in patients with amyloidosis. We see them in about 25% of patients with amyloidosis. Now, a new software was introduced to augment these granular sparklings, and now this actually was published, or it's about to be published in JACE 2024, and that increase the probability of diagnosing amyloidosis. Now, what happens if the patients with amyloidosis get myocardial infarction? Now, these patients, of course, they will, particularly if it's anterior MR, they will lose this cherry spot, and that actually is certainly problematic. Now, there is a recent review in February 2024 on cardiac amyloidosis causing myocardial infarction with two mechanisms: involvement of the epicardial coronary arteries and microvascular infiltration. And this actually why we need to detect cardiac amyloidosis early. So this is the latest expert consensus decision pathway on cardiac amyloidosis, appeared in JACC this last year, 23. And this is actually the pathway. I will, I think, finish in 1 minute if I got the time. So I will not actually talk about this because it's outside the scope of the talk, but I think it is there. So it is why it is very important to make the diagnosis, because the therapy can be different. We always use in heart failure beta blockers, but it was found that using beta blockers in patients with amyloidosis can be harmful. So you have to establish a proper diagnosis. Again, this is a case of summing up all the features in a patient with carpal tunnel syndrome. He got low voltage, he got the echo features. I talked about the cardiac MRI, the isotope, high uptake in the cardiac area. Okay, again, and the cardiac MRI picture. So in conclusion, ladies and gentlemen, echocardiography is the first-line test to identify non-specific signs such as ventricular thickening and restrictive LV pattern, although it is not sensitive or specific enough to confirm the diagnosis, but it is still very important, providing the clinical information or critical information regarding the disease status, the cardiac function, and follow-up in the setting of good imaging quality and high index of suspicion. So it paves the way to a proper diagnosis of cardiac amyloidosis. With this, I will stop. And thank you very much indeed. I will have a little gift for you. I know they are very generous here in giving gifts. I cannot compete with Dr. Ala gifts, but this is a small gift. These are my books from, they are all free, 40 books free from my website. If anyone goes there, he will find these pictures, these echoes. Thank you very much indeed for your attention.
Thank you very much. It was excellent and clear talk as usual, Dr. Hassan. Any questions? Yes. No time? Okay. Sorry for it's at the end of the session. Okay, so next speaker, Dr. Muhammad Salah Muhammad. He's a consultant in adult cardiology and echocardiography, head of non-invasive lab in Mohammed bin Nasser Cardiac Center, Jizan, KSA. And his talk is about the cardio-oncology, role of echo in cardio-oncology patients. Dr. Muhammad?
Good morning, or good afternoon, everybody. It's my pleasure to be with you again next day. Now we are flying with Dr. Hassan. Now we are landing. I will share with you this topic, the role of echo in cardiology oncology. no disclosure. First, I will start. This is a 65-year-old male patient who has coronary disease, diabetic, hypertensive. Plan to start anti-cancer therapy for there is treatment to be started, and they're supposed to answer this question. Patient will have to do full transthoracic echo, including 2D, 3D, systolic function, and JLS, or transthoracic echo follow-up every 6 cycles, then 3 months, 12 months, or the cardio-oncology team is needed for management plan, and all are correct. This patient, he has baseline chemotherapy showing GLS, global glycogen strain. On the right, here baseline when the ejection fraction is normal, 65. At 6 months is 58, and at 12 months as 59. And the GLS increased from 23, then dropped to 18, then dropped to, then increased to 21. At 6 months, his ejection fraction was 57. GLS is 15.8 with no limiting symptoms. So the GLS dropped. Now, how to approach this patient? To start cardioprotective management, that means standard treatment of heart failure as reasonable way, or we cannot start cardioprotective therapy, or contraindication, or not sure. So background, annually in the USA, around 650,000 patients receive chemotherapy. Out of 15.5 million are cancer patients. This number will exceed to reach 20 million by 2026. Cardiovascular risk among cancer survivors increased by 8-folds. Heart failure incidence among cancer survivors increased by 15-folds. That is a great burden. Cancer survivors are increasing, and cardio-oncology is an emerging subspecialty, is now better for clinical care. Heart and cancer are enemies. How is that? Cancer is still hitting heart either by cancer, by direct effect, or through the side effects of chemotherapy. It can affect the heart by causing myocardial dysfunction, and would end with heart failure, HFrEF. It can affect the valve as valvopathy. It can cause coronary disease, peripheral artery disease, pericardial disease, essential hypertension, and pulmonary hypertension. So the contributor of cardiovascular disease in cancer patient, the impact cancer, there is care gap between the shared risk and toxic therapy and impact of the cancer. As we mentioned, heart failure remains a devastating disease because of highly psychological, social, and economic burden. Heart failure can be anticipated in which patient who has cancer, whether they started chemotherapy or not. And I would emphasize that subclinical heart failure or LV dysfunction should be recognized as well as clinical overt heart failure. So the cardiac function should be assessed either by global systolic function, or by 2D, 3D, and tissue Doppler, or speckle tracking. We all know the limitation of ejection fraction. Ejection fraction has a lot of medication to assess the cardiac function, physiological limitation. It's like load dependent, affected by dysrhythmias, technical limitation, and clinical limitation. And so it is not the best to assess or follow cardiac patient who has oncology disease. What is strain? Strain is the formation responsible to an applied force. Myocardium is a compressible structure, shortened in one direction, associated with thickening in the orthogonal plane, and dimensionless index for change in length. And it is a percentage. Ejection fraction, as we mentioned, is just a volume. volume minus volume, and that's it. Strain is a difference in change of length. In diastolic, we have a diameter. In systolic, we have a diameter. The magnitude of the difference between the two will be delta length divided by the initial one, and the percentage will be the strain. Regarding the other modalities, the tissue Doppler, it has excellent temporal resolution, but there is weakness. Dedicated image, angle dependent, and have the regional issue. And while the GLS on the right need no dedicated image, angle independent, regional and global measures, and semi or fully automated tracks. And the weakness, lower temporal resolution, dependent on image quality and intervender variability. And this is the how the fibers in the heart look like. We have longitudinal fibers, circumferential fiber, and oblique fibers. If we look to this graph, how the angles move as the base up, it is clockwise rotation, while the apex is counterclock rotation. And we have in between the ringing motion. So the global longitudinal strain is normally in range of minus 20%, with considering variation between the manufacturing companies, but most of the time is around minus 20%. Strain imaging is useful for prognostic value, for strain useful for follow-up and myocardial disease and valve disease. So when we attempt to do the procedure on the echo machine, we have to choose the 2D image, acquired LV with correct geometry, not overshorting, optimize all the segments through the cycle, avoid under and over gain, and the width should be adjusted, and the frame rate between 50 to 70. And the image process, the type of LGS, different from manufacturer to manufacturer. Some company endocardium, another mid-wall, another as epicardium. We have to choose the cardiac cycle that represent the visualization of the myocardium. And the diastole should be defined by the peak R of the QR complex, not the Q. And tracking should be start immediately below the mitral valve. And range of interest should be reproduced with fidelity conforming all the LV anatomy. And default setting of temporal and spatial smoothing is useful in clinical practice. The standard chamber we used to acquired 2-chamber view, 3-chamber view, and 4-chamber view. And this is the bull eye. It looks like this. So some tips we have to look during doing the assessment. The impact of LV apical foreshortening. If you look to the left side, the green is the correct alignment from the apex to the base, while on the right with the yellow is wrong. Why? Because with the yellow is foreshortening, and on the green is standard. And if you see how this small error affects the GLS, it is big. In the correct, the GLS is 15.5%, that is green, and on the bottom is 17.7. So if you did it by foreshortening, you overestimate the global longitudinal strain, and you may label this patient is doing well. Again, in the left bundle branch block, we have to time the strain. This is the impact of time definition with left bundle branch in panel A. Look to the cursor. It should be at Q or R. In the beginning of QRF is considered the beginning of the isovolumic contraction time. So on the green is correct at the QR, at the R itself, the green R itself, while the yellow at the Q. So we have to use the R, not the Q. Take back to our case. This gentleman with 65-year-old who has diabetic hypertensive plan for start anticycline for cancer therapy. What's the option? Full TE with full assessment, follow-up, cardio-oncology, all are correct. I think all we correct. 6 months later, ejection fraction coming down with no limiting symptom. So we have to start the cardioprotective measurement. Again, any patient who has cancer, we have to risk stratify the patient according to the risk, basing on the baseline cardiovascular toxicity, based on clinical assessment, that's cancer treatment therapy, cardiovascular history, physical examination, and we have to do extra investigation, including biomarker, ECG, lipid profile, echo, all this. And if you look to the diagram, this diagram shows the baseline cardiovascular, and here how the risk factor of the disease as baseline, heart failure, cardiomyopathy, cancer-related cardiomyopathy, valvular incompetency, and the remaining are treatment, treatment of cancer therapy. And it can be ranged from very high risk to high risk. For example, the anticycline chemotherapy surveillance protocol, when to do the echo, how frequent to do the echo. First, we have to classify patient on low risk, moderate risk, and high risk. And we have to do all the investigation, including ECG, echo. In baseline, if you look, the echo is a must. Then with cycle 1, 2, 3, you look here, anything with green, this is class 1, with yellow is class 2. So at 3 months later, ejection fraction remains the same, and GLS improved. Because of, we detect the heart failure as subclinical entity, and we start the anti-failure treatment before patient crash down. Cancer therapy-related cardiovascular toxicity is defined as whenever the ejection fraction is dropped by 10% from baseline and ejection fraction below 53%, this is cardiac-related cancer therapy. And it ranges from symptomatic heart failure to from very severe up to mild. So taking home message, integrated approach with LV ejection fraction strain is essential to diagnose cancer therapy-related cancer cardiomyopathy. For speckle tracking, echocardiography, optimize picture, use same vendor, machine, and software. Reduction in GLS can trigger, initiate the cardioprotective therapy. Cardiotoxicity risk is not only during therapy, it should continue even after therapy, and because complication may occur several years after initiation of treatment.
Thank you, Dr. Muhammad. Saraha, it's very nice, extensive details, information about the cardiac oncology. Thank you. We'll defer it, inshallah, to the end of the meeting, the questions. Now we are going to go with the last but not least, Dr. Ala Khalil. He's the head of the echocardiography here in Almoosa Hospital, and he's a member of American Society of Echo. He's the in the Saudi board cardiology, and he's going to present to us echo in HOCM. So welcome, Dr. Ala.
بسم الله الرحمن الرحيم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Just I'll talk about overview of the role of echo in patient with hypertrophic cardiomyopathy. HOCM is inappropriate left ventricular hypertrophy in absence of other causes of LVH like hypertension or aortic stenosis. It was first described by Brunwald in 1960s. As you know that the pathophysiology of HOCM is mainly due to causing diastolic dysfunction, ischemia, obstruction, mitral regurg, and arrhythmia. This cartoon, it shows what is happening in the HOCM, which is starting by eject, obstruct, leak. And in this condition, and also there is the other pathophysiology, which is the LVH, and the LVH in this condition, it will have that non-sufficient amount of the capillaries for supply of the blood to the muscle, so it will be relative ischemia, and this ischemia, it will cause substrate for development of the arrhythmia. Then this is describing the whole pathophysiology of the patient with HOCM. Also very important things in the echo for the HOCM to concentrate on the mitral regurg. Is it already due to HOCM or it is due to the primary disease of the mitral valve? Mitral regurg in the HOCM, it results from systolic anterior motion of the mitral valve. Severity, it is related to the LV obstruction, and also it results in the symptoms of the shortness of breath in the patient of the HOCM. Mainly it is posterolateral eccentric jet, which augmented or increased from the mid to late systole. To differentiate this from the other primary lesion in the mitral valve. Mitral regurg in the HOCM, it will increase with any dynamic maneuver, which will increase LVOT obstruction. Also, we have to remember that patient with HOCM is liable to have rupture chordae, and also it may have also subacute bacterial endocarditis, so it can aid also for the other causes for the HOCM. And about 10% of the patient with HOCM may have also primary mitral valve anatomy or disease. This is a pattern of the hypertrophy. LV hypertrophy may be either basal part of the septum or the whole septum, or could be also lateral concentric. It could be lateral part, or it could be apical, or the mid segment of the HOCM. What is the role of echo? Echo, it has many roles in the patient with HOCM. It helps for the diagnosis. It helps also for monitoring the patient for the management by different ways. For the echo, simply will go by 2D or M-boot. It will show that asymmetrical septal hypertrophy with the septum thickness more than 15 millimeter, and the posterior wall will be about 3 millimeter less than the septum. Diffuse could be diffuse concentric, as we said, and also the most important thing, you will see systolic anterior motion with the SAM, and the left ventricular LVH, which is not explained by the presence of the other causes like aortic stenosis, and also hyperdynamic function of the apex. The guidelines recommendation for 2023 for the assessment of the patient with suspected HOCM is you have to do transthoracic echo. Transthoracic echo to see the LVOT obstruction, and it must be done with the patient resting and the patient with Valsalva maneuver, with other maneuver to increase this LVOT obstruction. And also according to the position, resting position, sitting, and standing position also. Class 1 indication also, if the patient already LVOT obstruction, the gradient is less than 50 millimeter mercury, is still, and the patient is still symptomatic, you have to go for a stress echo in this condition to see if it is increasing more than 50 or not. What is the role of the transesophageal echo in the patient with HOCM? It is important, it is class 2A indication. It is important to know that already the cause of the LVOT obstruction, and also, as we said before, to see that the mitral regurg, it is due to primary disease of the mitral valve, or it is due to HOCM itself. And this is algorithm showing that for the diagnosis of the HOCM in a patient with suspected HOCM, echocardiography, as we said that, resting and with Valsalva, if the maximum or provoked peak LVOT more than 50 millimeter mercury, it means that the patient directly you have to go for the LVOT obstruction management. But what about if it is less than 50? We look to the patient, symptomatic or not. If the patient is symptomatic, you have to go for the exercise echo. And in this condition, two ways. Either it is increased more than 50, it go to the SYMPAS way. If not, it will go for the medical therapy. But if the patient is from the start already LVOT obstruction gradient less than 50 and no symptoms, you have to repeat the echo in 1 year. This is from the echo, from the already either M-mode to see that the septum thickness relative to the posterior wall, and also, as we said, to look for the SAM, which already it is occurring during the systolic anterior motion, and also for the mitral, for the aortic valve, because aortic valve will show early closure in the patient with LVOT, which is very clear when you put the M-mode on the aortic valve. This is by 2D, very clear that the patient has already septum is thickness is increased relative to the posterior wall, and also there is SAM. And by the Doppler, you see that, as we said, that eject, obstruct, leak. Eject, obstruct, leak. It is the same pathophysiology here, and also for the apex, for the mid part, it's showing that hugely that already thickness increase the thickness of the septum mainly, and also you can see also there is SAM here, and here it is very clear that there is already SAM and is increased thickness, and again eject, obstruct, leak, and here the mitral regurg is posterolateral, which is secondary to the LVH. What about the rule of Doppler in this condition? Typical appearance of the late peaking signals, which is a dagger shaped, and also by the Doppler, continuous Doppler, we are looking for the Bernoulli equation to see the gradient, how much the gradient is present, because it helps us also after that in the management. And also distinguish between the MR and the already the waves for the increased LVOT gradient by looking for the beginning of this. Like here, it is dagger shape, it is late peaking, but if it is associated with MR, it will be contaminated. How can we know that if it is MR here? If it is starting from the beginning of the QRS complex here, you will find it is parabolic here, it is like this. But for the patient with LVOT obstruction, without any contamination here, it will start at the end of the QRS complex, and it will be dagger-shaped because late peaking. So we can, from this Doppler, we can differentiate if the patient also is contaminated with mitral regurg or not. Also, the systolic function is very important here, to look to the E and A, and also to look to the pulmonary flow, reversal or blunting in this condition. And the most important thing, sometimes the patient has basal hypertrophy. And in this condition with basal hypertrophy, what will happen? Already the apex will relax before the basal part of the myocardium. So what will happen by the Doppler here? You will find in the beginning of the isovolumetric relaxation time here at the end of the QRS, at the end of the T wave, at the starting of the diastole, you will find that the wave like this in the isovolumetric relaxation time. And after that coming E wave and E wave, which is reversed. So it gives you an indication here in this condition, which is a triphasic. Here it means that the patient already has mainly basal part of the hypertrophy is the basal part. This is one of our patients showing the same thing here. It is that isovolumetric relaxation there, time in this condition, and after that E and E wave coming after that. Also, the role of Doppler in the patient with HOCM. This is in the resting condition, showing the dagger-shaped appearance, and with the Valsalva, it will increase because you're increasing by the Valsalva, increases the LVOT obstruction, and also amyloid increasing more and more in this condition, and the gradient will be increased. All this is the rule of echo. This is example of the apical HOCM in this condition, and showing that in the short axis, it is already completely obliterating LV cavity. Is there any rule for the LV strain in the HOCM? Still, yes, we have a rule, very important rule. As Dr. Hassan Shamsbash talked about this, about the patient with suppose the patient has already amyloidosis or any patient with LV hypertrophy. We have to differentiate if it is not clear for us. In patient with amyloidosis, for example, will be LV hypertrophy, you will find that or LV strain, global strain, going that cherry in top appearance in this condition, sparing the apex. But what about the patient if the patient has HOCM mainly septal? It will show that in this condition, all will be preserved, but only the septal part will be global longitudinal strain, the longitudinal strain pattern will be decreased. And what about the patient with aortic stenosis? Patient with aortic stenosis would be that widespread changes already there, widespread decrease in the GLS in this condition. So it can differentiate. And also, as Dr. Hassan talked about this today, about the patient, if the patient already has hypertrophy and mainly towards the apex. Also, the left ventricular strain, it will help us in this condition. If the patient already amyloidosis, what will happen? Will be sparing of the apex in this condition, cherry in top. But in patient with apical HOCM, it will be decreased strain in this condition with this new thing he said today, blueberry. So it is also, it will help us in this condition to differentiate the patient. So there is rule already for the left ventricular strain in diagnosis in patient with HOCM. What about LS strain? Now the newly coming, the LS strain, it has also rule in the patient with HOCM. You remember when we give lecture previous year about the left atrial strain with the LV reservoir strain, which is starting from the mitral valve closure to mitral valve opening, and after that, left atrial strain conduit phase, which is starting from mitral valve opening to the before just atrial contraction, and after that, LA strain with contraction CT. It will start from the contraction of the left atrium. And you have that, you know that this is the normal number of the normal values, the normal value for the LS strain, which is the reservoir strain, it is 39%, and the conduit strain, 23%, and the contractile strain, it is 17%. What about in the patient with HOCM? There is a high prevalence of the abnormal left atrial strain in patient with HOCM. It is low. All the three parameters will be low, and mainly the reservoir strain and the conduit strain. It will be low in patient with HOCM. And it is very important for prognostic value also for the MACE, and also the patient with CT, LS strain, CT, which is the contractile part of the strain, it will be more decreased if the patient liable to develop atrial fibrillation. So it can be also diagnose this patient before developing atrial fibrillation, Memphis atrial fibrillation in patient with HOCM. And also it is given its prognostic significance, left atrial strain, it might be valuable addition to the stratification model for the patient with HOCM and for prognosis. Echo management, just last part. Echo in management of patient with HOCM. As we said, echo has a role also for the patient, for monitoring the patient for management. If the patient already, this scheme for the patient is symptomatic and already he deserves for the management, we start with beta blocker or add verapamil or start verapamil if the contraindication beta blocker, and you can add after that diazoparamide. Now there is new drug, mavacametin, which is that myosin ATPase inhibitor. It is also can be utilized in this condition. And if still the patient symptomatic by the medical management, you will have to go septal reduction therapy. But why we are talking about this? Because already after introduction of this new drug, which is that cardiac myosin ATPase inhibitor, already it is class 2A indication. You have to monitor the patient by echo. Why in this condition? It is based on the trial which is called that Explorer HCM trial, which showed that the patient with already with LVOT obstruction with gradient more than 50, it is found to be decreased less than 30 in many patients with improvement of the symptoms. But also you have to put in your mind that this drug also, it can decrease the ejection fraction. They said that from 4 to 10%. So if the patient is borderline ejection fraction, take care, because this drug also can decrease the ejection fraction more, and it will cause manifestation of the heart failure. That's why it is important with this drug also, you have to monitor by the echo. What about alcohol septal ablation? Also, it is for the management, echo has very important role. They say that international guidelines recommend the use of the myocardial contrast echo during alcohol septal ablation. Myocardial contrast echo, it is superior to the intracardiac echo. Why? Because already acoustic acquisition, it will be difficult for the patient with the intracardiac echo. This is the picture in the patient with intracardiac echo. This is the patient who is already given the patient to the contrast. See the difference? And also you can here localize the area of the myocardium which is already supplied by the septal artery. It will help the interventionist to go to this directly. What about during surgery? Also the echo has a role in the patient with HOCM going for surgery by looking for the cause of the obstruction and also diagnosing this by the color Doppler, and also to see the gradient. See the gradient here, how much before surgery? This is intraoperative, by the way. And also the surgeon will ask you, where is the most thick part of the septum to know? We have to measure for him, and also the distance from the aortic valve leaflet itself. So it is very important for him because it will be guide him for which part which he could do resection. And this is one of our patients already done, and we discovered also, he discovered during surgery, the patient has problem in the mitral valve itself, so it is ended by mitral valve repair and also septectomy, and the gradient after surgery directly, it is decreased from 111 to 25, and also after 60 days, this is the patient with already the gradient here, it is decreased, see, there is no regurg here, and already the gradient decreased into the around it is decreased already the mean gradient around 2. So, in conclusion, echo is the modality of choice for diagnosis and assessment of the severity of the obstruction in the patient with HOCM. Left atrial strain and left ventricular strain have an important role in early diagnosis and prognosis in patient with HOCM. Echo has an important role in guiding and follow up the patient in the HOCM management. And thank you.
Thank you, Dr. Ala. It was very nice, elaborative presentation. Can we open the floor now for quick questions, and then we will take the
Only
break?
2 minutes because we have to go for prayer.
أخذت 3 minutes out.
Oh.
أعطيهم 2 minutes شوي.
Okay.
Anyone has a question for? I'll just make very quick small comment about the cardiac amyloidosis. By the way, it is underdiagnosed. So many patients have been misdiagnosed until late stage. Then when it is late, usually we don't have any benefit from any medications, unfortunately. Even when they have impaired LV, you cannot give them any treatment, as is stated, the ACE inhibitor or beta blockers. So please keep an eye on those patients with LVH for no reason to have it. Patients with hypertension do not have LVH unless it is chronic and uncontrolled. So any patient with LVH, keep an eye on it and try to diagnose the amyloidosis as early as possible. Any questions? They don't want to ask. They want to go and break.
Okay, now we'll
okay.
go for...
Thank you. So you will go
we'll
for
go for
break.
prayer now and at the lunch also, and we'll come 1:30 inshallah. Okay,
so, thank
and
you,
just
everybody.
reminding
Thank
you who will stay with us till the end of the conference. There is 3 precious prizes. Okay? Everybody put his name outside. I'm the last one will give lecture today also. Please, يعني, attend with me.
Okay. شكرا دكتور علاء. شكرا. Thank you.
طيب عبد الحكيم حبيب موجود وحسن علي. حسن ما هو فيه. عبد الحكيم. طيب هشام خليل. نبدأ. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. So we continued the second day, the afternoon session. And the first topics will be the role of multimodality imaging in heart failure. And it's my pleasure to introduce Dr. Sarah Al-Harbi. She's a consultant cardiology, head of non-invasive lab in King Abdullah Medical City in Mecca. So Sarah, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to present today in the second day of the conference. I will talk about the role of different imaging modality in the heart failure. The heart failure is a leading cause of mortality in Saudi Arabia and worldwide. The prevalence is like almost 460,000 patients live with heart failure in Saudi Arabia, and the incidence is 32,000 cases are diagnosed annually with average age 57 years. We are 10 years younger than the developed country. The cardiovascular imaging is the cornerstone of the assessment of patients with heart failure. The advanced cardiac imaging following technical advance has progressed significantly, and now it's served as diagnostic as well as a prognostic tool. The heart failure patient demand constant follow-up with baseline imaging, such as echo or more advanced imaging, such as the stress imaging. The first is the baseline, the main and the first line bedside tool for the diagnosis of the heart failure is the echocardiographer, and it is important in the assessment and also the prognosis for the heart failure. And it's important for the left ventricle to assess the left ventricle function as like a new definition of the mid-range ejection fraction of the heart failure, and it's class 1 indication. And also it's important for the diastolic assessment and the value of exercise testing for the strain echo and the assessment of the heart, of the right heart. The evaluation of diastolic dysfunction the accurate assessment of the degree of diastolic dysfunction, it is a prerequisite for the heart failure assessment, and the key structure alternation during diastolic dysfunction in patients with normal ejection fraction. As we know, everyone sees the assessment for the diastolic dysfunction to diagnose diastolic dysfunction, and we can grade it to type 1, type 2, and type 3. And the pulmonary pressure are of crucial importance as they are indirect marker for significant diastolic dysfunction in patients with even normal left ventricle ejection fraction. This is summary with how to classify the diastolic dysfunction, preserve ejection fraction. In patients with shortness of breath and grade 1 diastolic dysfunction at rest, we can use some stress echo just to be sure for the diagnosis for the grade of diastolic dysfunction. We can use is like exercise, bicycle, or sometimes dobutamine stress echo. And to diagnose is like the test will be positive for diastolic dysfunction when all the following 3 criteria are met during exercise. Is like the average E and E prime more than 14, or septal E in prime ratio more than 15, and the peak tricuspid regurgitation velocity more than 2.8 millisecond, the septal E prime velocity less than 7. The strain echo also important to the assessment of in the heart failure. The impaired global longitudinal strain is common among the heart failure preserved ejection fraction. Patient indicated the presence of the covered systolic dysfunction beside the normal ejection fraction. The impaired strain has been associated with biomarker of the wall stress and collagen synthesis and diastolic dysfunction. The longitudinal ventricular strain has been correlated independently to peak VO2 in patients with reduced and preserved ejection fraction and has been superior identification of patients with reduced exercise capacity. And there is significant relationship between diastolic function and global longitudinal strain. Here are some examples for the longitudinal strain. The above one is, the above here is like normal, and here classical for the cardiac amyloidosis, and down here the different type for Hockham patient, here the apical, and here the septal Hockham patient. So the strain sometimes help to guide for the diagnosis for the some type of the cardiomyopathy. And also it will be important for the cancer therapeutic related cardiac dysfunction, as the longitudinal strain usually we used as a marker for the myocardial dysfunction before the left ventricular ejection fraction drop. And the follow-up, if the global longitudinal strain is the difference between more than 15% from the baseline, this is indicated for subclinical LV dysfunction. So we have, it's like example, this is live patient came in our hospital, 19-year-old female admitted through the ER with acute decompensated heart failure. There is no risk factor. Patient had congested with crepitation and lower limb edema. And here the echo, the lung, the X-ray is congested, and the echo you can show they have significant is like bilateral atrial enlargement, and they have some abnormal septal movement, is like bouncing septal. And the other measurement, they have the septal annulus velocity, it is 18, and septal E velocity, it was more than the lateral E velocity. The septal is 14 versus 14, and the mitral acceleration time less than 160. And we can see here they have the mitral inflow respiratory variation, and it is more in the diastolic. And here the diastolic reversal, it is more in the expiration, and here more in the mitral flow is also more in the expiration. And this is finding, it's more consistent with constrictive pericarditis. So what they can, other modality we can help, we did CT for the patient, and they found they have significant calcification in the pericardium. And this is the diagram which we talk about to diagnose the constrictive pericarditis. So the cardiovascular MRI, the assessment of the heart failure, it is important for assessment of heart failure during adding the diagnosis when conventional imaging modalities such as the echo, it's failed to specify the etiology, and will be class 1 when they have poor echocardiogram acoustic window, and also it's class 1 when we want to know more tissue characterization and to rule out infective disease. So the EMRs is recognized as the gold standard method for quantification of the ventricle volume. So they have many advantage for the CMR. It is more accurate, less lead radiation, and they have more information for tissue characterization. Also, we can help to identify the ischemic, non-ischemic through the like stress CMR, and also we can give important for the late gadolinium enhancement to assess the viability and to assess also the scar burden for some cardiomyopathy disease. To differentiate the type, if it is ischemic and non-ischemic. Also, the other thing for the many people with cardiomyopathy, especially with preserved cardiomyopathy, some of them related to the iron overload. So we can, the CMR, we can diagnose the iron overload, which can cause heart failure. We can do T2 star. We measure the septal. If it's a 2 star more than 20, this is no iron overload. And if it's from 10 to 20, it will be mild to moderate iron overload. Less than 10, this is severe iron overload. And this is will guide for the management and treatment. If it is this cardiomyopathy, it's the type of infective cardiomyopathy related to the iron overload. So the CMR is the primary non-invasive imaging modality for this, also the assessment for the suspected myocarditis in clinical stable patient. And also to detect the late gadolinium enhancement and know the pattern of the late gadolinium enhancement. Also, it's important when the T1, it will help for some disease when it will be elevated in some disease like hypertrophic cardiomyopathy or markedly increase in the amyloidosis. And if it is decreased, usually decreased in the iron overload, it's like here. Usually the T1, it is low in the Fabry disease and iron overload. So sometimes when we have hypertrophic cardiomyopathy, to differentiate, if the pre-contrast T1, it is low, this is Fabry disease. If it's high, could be HOCM or amyloidosis, and we can differentiate with late gadolinium enhancement, or if can markedly elevated with amyloidosis. Here also, we can diagram for some example in CMR. We can, all the information, it helped together. So sometimes we'll come with like segmental late gadolinium enhancement with corresponding elevation in the T1, and sometimes we can happen with some, it's like an ischemic endocardial and corresponding with elevation T1. Here the amyloidosis is markedly elevated, and here's some example for the, it's like rheumatoid arthritis, and here the Fabry disease, you see it is blue. This is indicates like low T1 pre-contrast. And here also the T2 help with to know in myocarditis if they have acute inflammation or myocardial edema. The CT is cardiac. It is also the latest technology modalities are also important, especially when to know to differentiate if this ischemia, to assess the coronary, if this is heart failure related to ischemia or not. And sometimes we can use it as like class 2B when if the patient cannot do CMR related, it's like claustrophobic or patient in non-compatible device, we can use the CT like with late iodine enhancement to assess also the scar and take all the more information. So the CT will help for coronary calcium score and coronary artery disease. We can do stress myocardial CT, evaluate also for LV function and volume, especially when we do a retrospective study. And we can use it like intervention, is like in FFR, and also to assess for the pulmonary vein appendage pre-ablation. They have 30-year-old male patient presented to the ER with acute decompensated heart failure. He's starting diuretic, and he's hypertensive, not in treatment, and recently diagnosed diabetes. When we did echo, he had severely dilated left ventricle with severe dysfunction, ejection fraction 20-25, with global hypokinesis, and no significant valve dysfunction. So the first step in patient cardiomyopathy, young, what we'll do for this patient? First is like to rule out ischemic-related cardiomyopathy. So we can use the CT. So when he had the CT, the calcium score 0, and there is no coronary artery disease. So the next step to know what the tissue characterization, and we did MRI for the patient. We can see they have some rim of pericardial effusion, and they have a cardiomyopathy, bilateral enlargement of the atria, and they have also flattening of the septum and some dancing movement in the septal movement is like bouncing. And also they have late gadolinium enhancement. We can see it all over. Here may be more accurate. They have late gadolinium enhancement. They have subepicardial late gadolinium enhancement. It's like in the basal and also the mid. This I just bring the mid segment. They have in the basal, and also he was in the mid anterior segment. Also here, and they have subepicardial. He had some like transmural late gadolinium enhancement in the septal wall. So it was mainly it was non-ischemic, especially when we know there is no coronary artery disease, and this is the main thing. It's element of pericarditis. This is another example patient, 32, young. They have he has diabetes, cerebral ataxia, ejection fraction 10%, normal coronary, have atrial tachycardia bixaban. We can see it's like almost like the other patient. He had very extensive constrictive, is like because he had cardiomyopathy, he had myopericarditis. It's like extensive subepicardial late gadolinium enhancement, and we can see it here very clear in the short axis. It's like encapsulated the left ventricle, and also the subepicardial, it extends also to the RV wall and also into the atrium. So this patient had extensive myopericarditis, and when we do the follow-up MRI later, the ejection fraction improved, but still the late gadolinium enhancement in this patient is still the pattern the same and not improved. So for the nuclear, they have some modality for the nuclear in heart failure. We can use it, it's like to know for patient, especially if can ischemic cardiomyopathy, they can use the PET scan to assess for the viability through the hibernating tissue and the match and mismatch for the in the myocardium. And also we can use it in the transplant patient to know the marker for the myocardial blood flow. And also we can use the pyrophosphate study, as now we can use it in amyloidosis, and also we can use the MAGA to assess LV function. So as everyone know, they have pyrophosphate now. Patients suspect amyloidosis. Now is in the European guideline, they go immediately to the pyrophosphate with some blood test and urine to assess for the amyloidosis. And according to these parameters, we can differentiate between ATTR and Hawking patient. Okay, I'm almost all done. So the PET we can, as I mentioned, to use for the FDG for viability. We can see the matching and mismatching for the scar. If this more than, if the hibernating more than 15%, this patient will get benefit from revascularization. Also, the FDG can help for inflammation, like in myocarditis, sarcoidosis as a part for the heart failure. And we can assess if they have segmental or diffuse inflammation, and they can type here the FDG and here the perfusion. If you can see they have FDG here segmental and normal perfusion, this is just inflammation. But if they have no FDG uptake and they have normal perfusion, sometimes they have late stage and like fibrosis. I'm almost
Dr. Sarah,
yeah.
Please conclude.
Yes. So this is the main thing. We'll go. This is the just to maybe 2 slides. This is the use for the marker for the heart transplant patient. We'll use the corrected myocardial flow reservoir, stress myocardial blood flow, and the cardiovascular resistant. If they have 3 is confirmed, 1 is half possible. If all these normal, it indicates like no allograft vasculopathy. And this will be, I will conclude by, I will finish by this one. They have 80 years.
I think so, Dr. Sarah, is enough. Just please go to the last slide. We have really to catch with the time because we're already late.
Okay, so the take-home message, the heart failure is the major health problem. In the Middle East, if occur at least for decade early, cardiac imaging can clearly identify the underlying etiology of the heart failure. And we may have many imaging tools. Appropriately choosing for the right modality for the right patient is very important and will be help for the clinical diagnosis and prognosis.
Thank you very much, Dr. Sarah. I think it was very comprehensive lecture about the role of multimodality. We'll move again in imaging, and it's my pleasure to introduce Dr. Ramallah Zahrani, he's a consultant cardiology and cardiac imaging at Prince Sultan Cardiac Center, and he's going to talk about the role of PET in infective endocarditis. We saw yesterday a case where there's a mass on the valve, and it was negative culture, and we're not sure. And I think some of the audience were asked, did you do a PET scan? So I think now we should hear the evidence for that.
Thank you. Assalamu alaikum, and thank you everybody for attending, and thank you for the organizing committee for inviting me to such an excellent really meeting, especially to have an advanced imaging modalities in a small place like this, just to educate the people about this advanced modality, how it can help them in in the management of their patients. And I tried to make it more simpler and more broader. So instead of talking about PET scan, I would involve some of the other advanced modality in a simple way. So starting, I have no disclosure. So it's not really a big health burden. However, with increasing use of devices now, we are seeing a good number of endocarditis mainly related to these devices in our center, Prince Sultan Cardiac Center. You rarely see you usually see at least 1 to 2 cases, and half of them almost is related to the devices that have been put, and luckily from outside, being a tertiary and referral center. However, it has a great impact on the morbidity and mortality once it happens. So the incidence is increased, especially with increasing use of devices. And also it is, the morbidity and mortality has increased accordingly. And unfortunately, still definite diagnosis cannot be done in a good number of cases, especially with devices from the baseline echo study. Now, as we know that the Duke criteria, one of the measures, depending on the presence or absence of masses, which is a major criteria. So the presence or absence of a mass has a major role in diagnosis, in diagnosing infective endocarditis. Now, most of the time, luckily, not most of the time, in a good number of patients, you can, by the echo, you can easily tell, assess the anatomy and the function. And unfortunately, this happens in advanced cases where you get a destructed valve, large masses with destructed valve, and you get a significant valve dysfunction. Again, it's not the case in a good number of cases. T also, it will add, and it can tell you again when we are dealing with an advanced endocarditis or complicated endocarditis, like this patient who have a destructed valve with perforation and severe mitral regurgitation. So if you are lucky to find, of course you will be lucky to find the diagnosis, but unfortunately the patient would not be lucky to be discovered late in such case where surgical intervention is really needed for most of the patient. Now again, if you have a complicated endocarditis, TE can tell you if you have any collection, para-aortic collection, so in this prosthetic valve, and I think this is probably Fetal procedure, and you have a collection around the aortic valve. So all of these could be easily seen and discovered by simple transthoracic or TE. However, in some cases it still be a dilemma, especially when you say, in like this example, you would say, I know there is a mass, but can you tell for sure 100% that this is vegetation or not without knowing the clinical background of the patient? Of course, you should be hesitant to do that, especially management-wise is totally different. Now, you could see little bit, the echo density you would expect it to be more than this. However, the shape goes more with vegetation, but we cannot say it is not a thrombus. However, as I said, that will have a great impact on your management, whether to go for surgery, 6 weeks antibiotic, or just to treat them with simple anticoagulation. So T sometimes, and luckily that it is few, but it is more with devices. Infection might be not conclusive, or it could not be done for any reason. So other cardiac imaging, and here I will be concentrating on CT and nuclear. MRI probably doesn't have a great rule, especially most of these are having devices. So I'll concentrate on CT and MRI. And knowing the importance of these, that already has been included in the guidelines, the American and the European guidelines. In fact, and also in the guidelines for lead or sepsis related to device infection, and it is considered as a major criteria using the CT and the nuclear to diagnose infective endocarditis. Also, the Duke has been updated to also to include assessment of masses by advanced imaging, including PET and cardiac CT. Now, the CT, it can easily, most of the time when we talk about CT and MRI, probably more helpful, more sensitive, more specific, or more sensitive when it is complicated endocarditis. Again, CT can show you if there is any masses, and it can show you the complicated cases or complication of endocarditis where you have an aortic para-aortic collection in this with this mechanical valve. Again, this could be, if you have a good experience, it cannot be missed by TEE, it could be, but at least the delineation of these collection and the extension is very accurate by CT. Now, this is one of the cases came to us from here, post-MVR, AVR, complicated by another, it was done for endocarditis, and then he developed also endocarditis on the implanted valves. And then he ended up, in fact, he came to us saying that he had multiple significant dysfunction of the aortic valve. And one of the few, you look at the transthoracic echo, you think there is a huge left atrium. In fact, it turned to be a huge pseudo. There was a rupture, myocardial rupture at the LVOT, and you have a huge pseudoaneurysm, multi-loops, and this is in fact one of the most difficult cases that we have seen post-op, complicated endocarditis, and in fact it was operated by our pediatric adult congenital cardiac surgeon, and the patient is doing fine. For the PET, most of the time intracardiac, it can detect intracardiac. It is more of a tissue characterization, and for intracardiac and extracardiac assessment of endocarditis, i.e. disseminated infection. It has high diagnostic accuracy and highly specific, and also has a very good sensitivity specifically for extracardiac and prosthetic endocarditis rather than native endocarditis. So for the PET scan, basically you are using a nuclear tracers that attach either to the cells, like FDG PET, which is a glucose analog and attached to the cells that goes inside the cells, or the white blood cells, radiolabeled white blood cells. Both of these are you seeing in the high inflammatory areas, so you would know if there is an uptake in one area that there is a high inflammatory process going in that area. Now, for the native, unfortunately, it's not as good as for the prosthetic valve, but the diagnostic accuracy is good, specifically is very good, and also it is very good for disseminated infection. The reason probably behind that sometimes the small infection, and the PET scan has a low spatial resolution. This is why probably you will miss a small masses. Now, for the prosthetic valve, it has a very high sensitivity and specificity, and in one of the meta-analysis, it was comparable on both bioprosthetic and mechanical valve, and it improves the sensitivity in cases where you have a rejected or definite prognosis, or in some patient where you have possible infective endocarditis. So it did improve the sensitivity significantly compared to the baseline investigation, which did not give a definite conclusion about the diagnosis. Now, extracardiac is an excellent for disseminated infection, and in general, it is very good when you have a patient in a prolonged antibiotic and a slow-growing bacteria and negative culture, because these things will be reflected on decreased inflammatory process at the area of infection. However, still PET scan is sensitive to detect these cases. You get sometimes transvisual, which doesn't show anything. The CT will show there is some collection there. Of course, if it is immediately post-op, you would not be able to tell is this a collection abscess or this is a hematoma. You get an increased uptake by PET scan and suggestive of high inflammatory process around this. Of course, if it is immediately post-op or within 3 months, you might not tell if this is post-surgical inflammation or really a true infection. Again, this is another case where you see clearly there is some collection around the aorta and this mechanical aortic valve. So you know this is endocarditis with high uptake around the aorta, suggestive of para-aortic root, active inflammation and collection, i.e. abscess. I know this, you can, by the CT should be enough to delineate the pathology and not to go for nuclear. Sometimes you don't see anything, but using the PET scan, you can see a high uptake in an area which not really seen by CT, opposite to the previous case where CT also did show, but in this bioprosthetic valve, you have seen these high uptake suggestive of ongoing inflammation at this area. This is a common, in fact, example we get in our CT, a patient bioprosthetic with high gradient, and you see this hypodense area or hypoattenuated area, and this is usually typical of HALT, what we call HALT, and it cannot be seen by echo, and the only thing you see in echo is slightly high gradient. So it is hypoattenuated, leaf thickening, and this is usually most of the time responds very well. It's a thrombosis, so responds very well to anticoagulation rather than really, and this is the typical, or it starts at the bases and then taper at the tip of it. This is an advanced case of HALT with severe stenosis. So the treatment in these cases are anticoagulation rather than really antibiotic. And now this is a study that shows how PET scan, of course, using glycoprotein tracker, radio-labeled glycoprotein, and of course that will be accumulated in an area where you have platelets aggregation. So once you see a high uptake, you know that there is a significant platelet aggregation at this area, so you treat them by anticoagulation rather than antibiotic. And this is the patient after being treated for good time with anticoagulations, shows significant improvement in the uptake in the thrombosis area. Now, still, as it has a limitation, as I said, the prolonged antibiotic, it might reduce the sensitivity. Again, the problem of surgery, post-op surgery, you might have a false positive due to the inflammatory process, and sometimes due to the surgical suture that you use, specifically the adhesive and the glues, that might stay, it induce inflammatory reaction or seen by PET for a long time. In general, the European Society, they advise not to avoid false positive, not to be done within 3 months after surgery. Now, again, you would have sometimes false positive related to vasculitis, neoplasm, and sterile endocarditis. Now, as I said, the incidence has been increased due to the use of devices, whether leads or even the valves, we consider them devices. For local intracardiac, again, it is sensitive. It is highly specific and sensitive for extracardiac disseminated infection. Clearly, this is a patient where you see the significantly increased enhancement or uptake around the lead, suggestive of ongoing active inflammation. And also, in general, it is more sensitive for extracardiac compared to intracardiac infection, and this is a case of a pocket infection. Again, it has been common, and we see it frequently in our center referred from outside. Septic embolization is very sensitive, highly specific compared to the intracardiac infection, and you could easily see mycotic aneurysm, distal tibial mycotic aneurysm, secondary to septic embolization from an infected aortic valve. You could see this disseminated infection in the spine, all coming from the aortic valve, and it's highly sensitive and specific. And you can also see the septic embolization in the spleen. So in the spleen. So in general, PET scan is very sensitive, very specific for disseminated infection secondary to cardiac infection. In terms of prognosis, as expected, the higher the inflammation, the worse the prognosis. In fact, the stronger the uptake, it is reflected in the prognosis of sure, 2 minutes.
Only 1 minute, please.
1 minute. إن شاء الله ما تصير وزير مالية أنت.
لا بس.
Okay, so the worse the inflammation, the uptake is the worse the prognosis, and this is the conclusion. As I said, echo is very diagnostic in most of the cases, specifically if it is complicated. The problem is what the devices that echo might not be helpful. Also for extracardiac is not really helpful. CT is excellent when it comes to anatomy of or complication of infective endocarditis, namely if it is aortic and para-aortic. The nuclear, as I said, it is excellent with high sensitivity and specificity, specifically for extracardiac and also for prosthetic valve. It has less sensitivity for the native valve endocarditis, but again, it is excellent to show any complicated endocarditis, specifically when you have distal embolization. Thank you very much.
Thank you very much, Hormallah, for tackling this difficult topics. I think we'll move now to the third talk. I think the third talk is something challenging. Dr. Basha know it well. It's Dr. Bernard Mam. He is going to talk about the role for artificial intelligence. It will be a recorded lecture. But he will be online with us after he finishes his talk if you have any question.
Dear Chairperson, thank you very much for the kind introduction. Ladies and gentlemen, it's my great pleasure to talk already the second time at the second Almoosa Echo International Conference about a very, very hot topic, artificial intelligence and what it means in healthcare and echocardiography. My disclosure slide, you know this disclosure already, but I'm a research consultant for Tomtic Imaging System here in Munich, Germany. As I'm talking about AI, and I would like to show you some of the latest AI tools, I thought I'd start with introducing my talk by myself in Arabic using a new tool called Hypertrophic. And let me just show you.
الرؤساء السيدات والسادة، لتوضيح قوة أدوات الذكاء الاصطناعي اليوم، اسمحوا لي أولاً أن أشرح لكم عنوان محاضرتي باللغة العربية والتي تم إنتاجها باستخدام أداة الذكاء الاصطناعي هيدجا. محاضرتي تدور حول إمكانات ومخاطر الذكاء الاصطناعي في الرعاية الصحية وتخطيط صدى القلب.
So you see, I can speak Arabic, but not really, so I have no clue what I say in Arabic, but I asked my Arabic-speaking colleague to check if it's fine. So, but this shows the risk of AI tools, that it looks like real, but I actually really don't know what I'm saying. So, AI in healthcare, I think there's no day without AI publications, AI news in many aspects, and there's no day where new journals are popping up and you can read the entire day articles about AI. Just let me show you some of the recent journals in artificial intelligence, especially in healthcare and medicine, from various different organizations like here in radiology or the National Academy of Medicine in the United States. And this paper, this journal was now recently introduced in January this year, Shaping the Future of AI in Medicine of the New England Journal of Medicine. So you see a big hype in papers, in publications, in journals. But I thought, why not using an AI tool called ChatGPT? And I think, meanwhile, you all know ChatGPT. And I asked ChatGPT by prompting, give me an overview about AI in cardiology. And all these points have been then worked out by OpenAI's ChatGPT. So it said it can be used for image analysis by automatically analyzing echo, CT, MRIs, and other modalities to identify abnormalities in the data, or then to come up with predictive modeling, calculating a likelihood of a patient to develop based on the specific risk factors of this patient, or then leading to a personalized treatment to identify the most effective treatment options for this patient. But probably the most important and most powerful aspect of AI is its capability to analyze big data. So it can really go to entire electronic health records of a hospital, of a country worldwide, in order to find patterns and similarities in this data and to figure out which pattern in the data is the signature of a specific disease. And this is very important for research in the future. So briefly, let me explain you the AI methods we use. So overall, artificial intelligence is just a bubble describing all kinds of algorithms in the AI, more or less algorithms which enable a computer to think. But the most prominent algorithms are called machine learning algorithms, which are more able to learn from data. And the most important subgroup of machine learning is called deep learning, which is more or less mimicking how the human brain is working with artificial neural networks. And this is now capable of learning unsupervised from data or as well supervised. Let me explain you on medical data how we do that or how this works. How does machine learning is trained? So there are two different ways to train the algorithms. One is unsupervised learning. And here we have a big group of people, an example in this picture. And the algorithm can now look for similarities and pattern to identify in this group which are the green people, which are the blue people, which are the red people, and so on. Or on the other side here, supervised learning, where we take, in example, thousands of images from an apple. We say, this is a red apple, this is a green apple, and this is a banana. And with this training, we create a model predictor based on statistics in order to let the algorithm understand the differences here. And more or less, we do the same in echocardiography. We take thousands of examples of a two-chamber view, of a four-chamber view, of a three-chamber view, and then the algorithm can automatically distinct these views then out of a stream of echocardiography images. What does it mean for echocardiography? And in 2022, there was a very nice overview article from in the Journal of the American Society of Echocardiography. And they showed more or less these 5 columns where they see AI becoming very important in echo in terms of the image acquisition, image interpretation and automatic measurements, text interpretation, and then the diagnosis and prognosis. For sake of time, I will focus with some examples on the first 3 columns here. Like if we look to the image acquisition, there are already AI-based solutions on the market which are helping you to come up with exactly the right view. An example, if you like to have a parasternal lung axis view, it tells you as soon as you have the right view, okay, this is now the view and it's recording the view. It helps you during the scanning to improve the quality. And the same is already available on the smartphone, and you know probably that some ultrasound probes can be connected to smartphones or a mobile solution, and then you can improve the scanning with this kind of GPS system. Then if we go to the second column here, the image interpretation and automated measurements, Here are already solutions implemented in the ultrasound systems and in the workstations, which can do all measurements you need to do for an echo study based on, in example, the ASE guidelines, completely automatically based on AI algorithms, all the distances, areas, Doppler measurements, mode measurements, but as well LV and RV volumes, ejection fraction, and strain can be calculated automatically. Or if we look to one of the latest publications, this was from last month, the European Heart Journal here, they compared a tool doing these automatic measurements on 2D clips, and they showed the benefit in time savings. And to do all the measurements, AI could save up to 77% of the measurement time, but not only that, it could do that with a much lower variability. So the test-retest variability was much less than with reference reviewers. And this shows the big potential, faster and more reliable, more reproducible. Then if we go to other solutions on the market, this is an example of a completely AI-based automatic wall motion evaluation software. Then for all the bullseye 70 muscle segments here, or if we go to 3D, definitely with 3D, with this dynamic heart model here, the volumes in the heart, especially the left ventricle, can be completely automatically analyzed. And this was published by Professor Lang from the University of Chicago, and he could nicely show that with this tool you can not only reduce the acquisition time, but as well the analysis time. If you do it without editing in the latest version, you save up to 82% of the analysis time doing a study. So the third column here in our Journal of the American Society of Echo Publication says text interpretation. And here many tools from big companies are coming up or are already developed, like PubMed-BERT, ChatGPT from OpenAI, or Google's MedPalm 2, which are claiming they can help in diagnosing a disease, planning a treatment, patient education, and it can be used to improve medical research. And these tools are meanwhile very powerful, and this shows that these tools, like the Google MedPalm 2 tool, passed US medical license examination with more than 86% of right answers. And not only that, it could prove that the answers are much better and much more comprehensive than answers from other physicians. So in all aspects here, orange is artificial intelligence answers. They rated better than blue other physicians. The other tool, ChatGPT, passed the US Radiology Board exam as well with a score of 81%, answering 81% of these 150 questions of the exam correctly. And this shows really the power of all these tools. Sure, where power is risk. So here the potential, and again, this was a very recent publication last month in the European Heart Journal. They say that such large language models are very valuable in the future in the field of cardiology, but we need to be aware of its limitations. And in the same journal, the same issue, there was a very critical aspect that ChatGPT was used in order to give him some questions, medical questions, and ChatGPT was providing completely nonsense answers, but they sounded very reasonable, they sounded very well, and including giving references to non-existing research papers. But if you are not an expert in this area, you could believe it because it sounds just perfect. So this shows that caution use is very important and more important than ever. Sure, these tools will get better and better. It's just the beginning, and I have no question in 5 years from now, they will be probably better than we human beings. But right now, we need to be aware of these problems here. So what would Plato say about tools like ChatGPT? And I went back 2,500 years to the history. And Plato, after the invention of the alphabet and the written word, he was very worried that the tradition of memory-based rhetoric like telling a story from the father to the son and so on, would go away, and that this will lead us to believing and seeing not truth, but only the semblance of truth. Meanwhile, we know that Plato was wrong to be afraid of the written word and see it as an enemy. And I believe we should see it as an analogy today. We should not be afraid and fear of a process that allows us to gather more information more easily, but we need to be aware of all the risks and the limitations. So saying the risks of AI, there was a big open letter from more or less all the founders and CEOs of all the high-tech companies, Google, Microsoft, Apple, Tesla, Skype, and so on, even DeepMind AI companies, and a lot of AI scientists and university professors, and they warned for this rapid development of AI without really looking to all the risks. And if we do not look at the risks, they asked the question, should we let the machines in AI flood us with probably untruths and wrong information? Or sooner or later, should we automate even fulfilling jobs away? And should we allow non-human minds to outsmart, make us obsolete? So losing the risk of control of our civilization. So, and we should take that really very serious. And if we look to machines like that, they really exist. So these are robots from US company Boston Scientific. They are not remote controlled. They can walk and act completely autonomous. And this shows the risk, what can happen if we are not controlling these new technologies. Another fascinating but as well difficult tool is called Sora. This was just published, and it can create a video from text. So I put it here in text. So input to Sora is said, create a video from an old man wearing a green dress, a sun hat, walking around in Mumbai during a sunset. And then OpenAI Sora tool is creating this beautiful video, but it's all created. Nothing is true in this video. Even the people are created, they are not really existing, but we cannot really identify anymore that this is not reality, that this is not a real scene, it's made up. And this shows the fascination, but as well the risks of AI, what is true, what is wrong. It looks so good, and then we would believe it. So AI challenges in medicine. Can AI make doctors obsolete? Yes and no. And I found this statement from Google's chief clinical officer. He said, healthcare AI should happen with the clinician, not to them or not against them. So again, one of the recent publications from the European Heart Journal, they said AI will soon completely revolutionize clinical practice in improving diagnosis and clinical decision making. So it should not be considered a threat, but a powerful tool in the future. So for sake of time, we need to come to an end, looking and summarizing the potential and risks. In our area, healthcare, and specifically in echocardiography, I see much more potential to make the diagnosis much faster, much more reproducible, so giving the physicians more time to focus on the patient. And sure, we should not blindly believe the results of AI, or the legal and privacy liability should be taken in care. And don't forget the warning from all the AI technology leaders I showed you before. With that, I would like to thank you very much for your attention.
Is Dr. Bernard with us online? Okay, do you have any question for him?
Dear Chairperson, thank you very much for the kind introduction. Ladies and gentlemen, it's my great pleasure to talk already the second time at the second Almoosa Echo International Conference.
Diagnosis of patient indicated in future for device. It's like recovery and also for ICD device. So they have many information we'll get it for cardiac MRI.
Okay, Ghormallah, what do you think?
About
doing doing cardiac MRI for all patients with cardiomyopathy.
I think this is not my field, but I mean it's an excellent for tissue characterization, and unfortunately the patient have a lot of comorbidity, including diabetic, hypertensive, ischemic heart disease. So MRI clearly can differentiate between different types of cardiac involvement.
Was the problem was question about all, because it's really in terms of cost effectiveness and also practicality of doing it. We have no doubt that it's really very helpful, and also give us certain diagnosis that is we will never reach to it by echo or other modality. But the problem, can we afford to do it? Let us just go to Dr. Bernard and then we'll see. Doctora, let us just address something for him because he's online with us, and later on we can have other question. Do you have any question for Bernard Ham?
Thank you so much, Dr. Mum, for such an intriguing talk. Now, just for the physicians, can you put back the slide of the 3 AI references that most doctors would go to? Chat, you said chat, Google, and can you put that slide back, please? Is it possible?
Yes, I can open it here. So more or less, let me see if I can share my screen. It was more or less the MedPalm 2 from Google.
Google and chat and what?
Just view this. Just a second.
Just let us know more. If you could tell us more about each one. Are you using them? People are using these 3 references, drawbacks, and so on.
Yes. So while searching for the slide, like the Google tool, MedPalm 2 is really used in several important big hospitals in the United States. Like Google has a big collaboration with the Mayo Clinics, and the Mayo Clinics and Google are now together using this tool in order to improve the artificial intelligence tools within the Google tool. And this makes it so important for the future. Right now, as I showed you, the tools, they have really risks because the tools can give you completely stupid answers and they look great. And even with the references I showed you, they give you clinical references to scientific publications which just do not exist. They are made up because statistically from the tool, this sounds reasonable. And by training the tool with real clinical valuable data, like done in the Mayo Clinics, this tool will be improved. And let's say in 3-4 years from now, I have no doubt that this tool will be much better than any human being, because it can look to a lot of data, big data, and no human being can always have all the latest research information available, all the big data available. So, OpenAI's tool, ChatGPT, they will do the same with other hospitals. So I have no doubt that this will come up and will be valuable. Don't use ChatGPT right now for your clinical decision making.
So out of the 3, the 3 references that you put, can you compare all the 3 references? Can we say compare between the Google and ChatGPT and the third one, pros and cons?
Yeah, I would say, as it sounds, that Google is doing the most collaborations with hospitals. And I would say probably the Google MedPalm 2 tool is the most advanced one if it comes to medical things. But this is just for the moment. ChatGPT can be used for many other aspects. But I personally would right now say the Google tool probably is the most advanced today.
Okay, thank you very much. We are looking for this AI to be incorporated within the software of the different echo machines. Because I think if that's done, then I think our sensitivity, the velocity of doing the procedure will be much faster. Do you agree on that? Okay, thank you very much.
Completely, yes.
Thank you very much for joining us. Have a good day. See you in another event. Thank you. Okay, I think because of
you.
the time, we're going to move to the next session.
Now we want to invite Dr. Nawaf, Dr. Heba, and Dr. Rima Al-Badr. بس انتوا بقى هتقدموا مع حضرتك
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. At the beginning, I just want to express my gratitude to the organizing committee for this extraordinary conference. I'm Dr. Nawaf Al-Bloui, pediatric cardiologist from Johns Hopkins Aramco Healthcare. During these 2 days, really I was excited and have a good refreshment for the previous medicine background for me. I am pediatrician and pediatric cardiologist, and Dr. Hiba, Dr. Muhammad Al-Khamis, Dr. Rima Al-Badr, all are pediatricians, and we enjoyed the previous sessions, especially when we face in some presentations and interesting echoes. There's a lot of cases with shared point of view of structural abnormality like subaortic membrane or aortic abnormality, left ventricle non-compaction, a lot of shared point of interest between pediatric and adult cardiology. We have this opportunity to share with you and refresh your memories with a congenital abnormality of aortic valve. Dr. Hiba is a consultant from National Guard Hospital, King Abdulaziz Cardiac Center. She is a pediatric cardiology consultant, and she will share with us excellent, as I know Dr. Hiba is the excellent pediatric cardiologist. She was the honor in her training fellowship. Me and she was at the same day graduated, and she is the best fellow at that time. So, Dr. Hiba, you have the time, 15 minutes, to present your talk about the congenital variant of aortic arch.
Okay, Assalamu alaikum, everybody. Thank you, Dr. Noah, for this nice introduction, and thank you for the organizing committee for this invitation. My talk today will be about the congenital variant and anomalies of aortic arch. So the anomalies of the aortic arch, actually, it is like of many types, and it is diverse, and it is have broad spectrum of clinical manifestation. It is ranging from just incidental finding, asymptomatic, to severe symptoms because of the compression of airways and esophagus. Sometimes there is isolated lesion, and sometimes it is associated with congenital heart disease. And in pediatric, echo can depict the course and branching of aortic arch abnormalities. However, CT and MRI really play a major role, and usually we use it for diagnosis to have an exact relationship of the abnormality of the arch and relation to adjacent structures. So to understand this abnormalities and variant, we have to know the development of aortic arch. We will go back to embryology, actually. And we explain these abnormalities in the the hypothesis of the hypothetic theory of the double system aortic arch. Actually, it is a hypothesis, but at the end, it can explain almost all the arch abnormalities. And it is double system because we have like double of 6 aortic arch, which is started in like beginning of the 2nd weeks of gestation till the end of 7 weeks of the gestation. If we can see here, I don't know the light, yeah. So here we have what called truncus arteriosus. This is coming from the heart. Truncus arteriosus, after septation, will give us the main pulmonary artery and the aorta. Then from here, we have the aortic sac, and we have two dorsal arches that at the end join and fuse to give us the dorsal arch, which is the descending aorta in the future. So the 6 arches from cephalic to caudal, the first right and left arch, second right and left arch, third, fourth, fifth, and sixth right and left arch. The hypothesis said that first right and left arch will regress, and at the end will give us the small like maxillary arteries. The second arch also will regress, and the remnant will give us like hyoid artery. And the third arch, right and left, will give us common carotid right and common carotid left arch. And the fourth arch, the left, will give us the aortic arch, the left aortic arch. While the fourth right will give us part of the subclavian artery. Then the sixth arch will give us right and left pulmonary arteries as well as the ductus arteriosus. If you notice, I jumped the fifth arch because actually it's supposed to regress completely and there is no fifth arch. This is what the theory. So if we go to the, next slide. So if we can see here, the normal arch. At the end, we have like one arch, we have 3 branches of the arch. Then, if we can see here, this is what we have at the end. One arch, nice arch, and we have 3 head and neck vessel branches coming from this arch. And the first branch supposed to give us the right subclavian artery and right common carotid artery. Usually in pediatric, we will trace this first branch as here, and when we see it's giving us, it's bifurcate and giving us the subclavian artery, right subclavian artery, and right common carotid artery. Let's see, I'm going back. So now we need to know also the arch and relationship to the adjacent structure. And here we can see the normal arch, it's coming and crossing the left bronchus. We are very keen to know the surrounding structure, which is the bronchus and the esophagus. So the arch, normally it's come and crossing the left bronchus and going to the left side. So this is left arch. At the same time, we have 3 branches. First branch with bifurcate, second and third branch, and nothing crossing behind the esophagus or the trachea. So what abnormality we can find? Either abnormality of the branching or abnormality of the position, either right arch or cervical arch, or abnormal number, double aortic arch, fifth aortic arch, or isolated branches, coarctation or interruption. The clinical manifestation depends. Either there is compression, so we'll have stridor, recurrent pneumonia, hyperextensive extension of the neck for babies, swallowing difficulty, choking of the food, and also still if there is disconnection of the one of the branches, so we'll have like claudication or cerebral insufficiency. So the first abnormality we can see is what called common brachiocephalic trunk, and this is like one of the common abnormality of the branching, in which we can find, instead of 3 branches, as we said, we have 2 branches. Because the first branch will share the common carotid artery, left common carotid artery will share the origin from the first branch, so we'll have 2 branches instead of 3. But it is like misnomer, like bovine arch. Actually, it is not a true bovine arch. The true bovine arch, which is found in cattle, when we have only one single branch coming from the transverse arch, giving rise to all 4 branches, and this is not reported in the human. This is the common branching abnormality, but so to be benign. However, there is some study coming that there is increased risk to have like dilatation and torsion deceleration injury. And this is by echo. We can see instead to have 3 branches, we have 2 branch. This is one, and this is the other branch. The other one of abnormal branching, I put a case here. This is a real case. We have 40-year-old female, weight 86 kg. She presented with progressive dysphagia for 1 year, mainly for solid food. An examination, general examination was unremarkable. GI endoscopy revealed like a pulsatile compression of the esophagus, and the barium is swallow showing this, which is posterior indentation of the esophagus. So what do you think? Any thought for this? Sorry? Exactly. So this patient, actually, she had like what called arteriorrhizoria. We can see here, this is a clear left arch because it is crossing the left bronchus, but instead of 3 branches, we have 4 branches, first, second, and third, and the fourth one is the right subclavian artery going behind the esophagus and making compression, and usually this artery cause like what we call non-ring formation. And this is here how we can get the, sorry, can we, can we show the video here? Yes, both. So how we know from pediatric, we can detect that there is apparent subclavian or right subclavian artery, because as we said, the first branch should be giving us 2 branches here, which is the common carotid and subclavian artery. However, in this case, we have only 2 parallel branching. So this is give us a clue that there is aberrant left subclavian artery. So it's like 0.5% of general population, but higher in Down syndrome, mostly asymptomatic. But if there is symptoms, we need to refer to surgery, which will be like implantation to the common carotid artery. The next abnormality is abnormality of position. As we mentioned here, this is the normal left arch crossing the esophagus here, crossing the left bronchus. Here, the right arch is crossing the right bronchus, but at the same time, the first 3 branches giving us head and neck vessels. And this is called mirror image because it is mirror image for the normal arch. And usually mirror image right aortic arch, it is usually associated with intracardiac abnormality, mainly like tautology of followed conotruncal, TGA, and tricuspid atresia. And this is how to detect the, I think you need to, okay, no, just, okay. So here, if you remember the first one, the first branch should go to the left. So it is right aortic, left aortic, the first branch supposed to go to the right side, so it means left aortic arch. Here, the first branch is going to the left, so it means right aortic arch. And usually we ask our sonographer to put the right aortic arch in this direction, so we know this is right aortic arch. And this is with mirror image because I have the first branch giving 2 branches here. Then we have the abnormality of the position, the cervical aortic arch. Can we open the video here also? So the cervical aortic arch, and the theory behind that is that the 4th aortic arch is not formed, and rather it is the 3rd aortic arch. That is why it is in higher position. And it may be associated with like right aortic arch and sometimes with DiGeorge syndrome. And it is rare anomaly. Usually it is above the level of the clavicle, and the presentation will be like pulsatile mass in the supraclavicular fossa. The differential diagnosis like aneurysm of carotid or subclavian artery. And as mentioned in the book, if you compress this pulsatile mass, you should lose the femoral pulses. But I am not sure about this. It can cause vascular ring, and intervention will be based on symptoms. If no symptoms, no need for intervention. Then we will go to the vascular ring, which is like congenital anomaly of the aortic arch derived vascular and ligamentous structure, and it should usually encircle the trachea and esophagus. We have many types, but mainly we will go through double aortic arch, right aortic arch, and apparent left subclavian artery, and circumflex aortic arch. So in double aortic arch, again, the theory stated that both 4th arch will persist, the right and left arch. That's why they will encircle the trachea. So it will make like a vascular ring and compression of the trachea. And usually the right arch is the one dominant, and the symptoms depend on the tightness of the ring. And the infant usually present early with like a barky cough and stridor, and usually they will divide the less dominant arch. And the symptoms supposed to be relieved. By echo, we can detect.
2 minutes.
Okay, so we can detect this by echo, double arch, and then we need the CT, of course. You can see clearly the CT, and we have double arch here. It circles the trachea. And then we have right aortic arch with apparent left subclavian. Also, it is a vascular ring. And this is like causing right arch. And we have 4 branches. The fifth branch is left apparent. And with the ductus here will cause a ring around the bronchus and the trachea. And usually there is no associated congenital heart disease. And also here we can see apparent. And also by CT we can see the abnormalities. The last one is the circumflex aortic arch. And we can see clearly it is coming from the left and crossing behind the trachea going to the right side. And also presented mainly with like dysphagia. And this is treatment like this disconnected and joining with the ascending aorta. Okay, this is persistent fifth aortic arch, just make like double lumen, but usually associated with congenital heart disease. And the isolated vessels, like isolated left subclavian artery, and usually it will come like some symptoms of claudication and like Steele syndrome, and also the treatment is also you have to do surgery for this kind of. I think it is not moving.
Dr. Hiba, can you conclude?
It's not moving actually. So just we can we just go to the last slide? Okay. So also we have the interruption here. And just the take-home message that congenital variant and anomalies of aortic arch include diverse malformations that may clinically be silent or may present with severe symptoms depending on the compression. Non-invasive imaging as CT and MRI allow comprehensive evaluation and of the abnormalities in relation to the surrounding structure, but familiarity with the spectrum and imaging appearance of all variant and anomalies essential to accurate diagnosis and guide the management. Thank you very much.
Thank you, Dr. Hiba. Thank you very much. It's my pleasure to introduce Dr. Rima Al-Badr. Professor Rima Al-Badr is a professor from King Abdulaziz University in Jeddah. She is consultant of pediatric and pediatric cardiology, and her interest in fetal pediatric cardiology. She is the president and founder of the Fetal Gulf Heart Club group. So she will present for us indication for fetal echocardiography and the update for that. Can you present? 15 minutes, Dr.
Yeah, thank you so much, Dr. Nawaf. I'd like to thank all the organizing committee for Almoosa. This is my second year to come here. I'm very honored. And I'm also honored to be part of an adult group, because I always believe is that we have to share children, adolescent and adult. We have to have some knowledge about other medicine and vice versa. Now I'm going to take you to the fetal life, because fetal life is the origin of everything. You know, the Barker theory and everything, even hypertension can start in utero. So I'm going to talk, but not very complicated talk, because I know this is not your field. The message here, objective, is that you understand that the story starts during pregnancy in most of the congenital heart diseases, if not, and some of the acquired, like the diabetic mothers and others. Next, please. Oh, I have to do this? Okay. Next. Do I have to do it? Okay, I have no disclosures. So cardiac malformations are common, affected 8 per thousand. The incidence of congenital heart disease in the world. In Saudi, we have probably 12 per thousand, many studies, but they're not reflecting all of Saudi, some of the right side of Saudi, left side, and so on. We don't have a consensus for congenital heart disease in our country. And of course, a lot can be diagnosed antenatally if you have the interest and the training. It's important to detect serious forms of congenital heart disease in the fetus because congenital heart disease have extracardiac anomalies. So you can have heart disease plus chromosomal anomalies. You can have heart disease plus renal anomalies. You can have heart disease plus cardiac anomalies. So it could be the red herring. So fetal heart is very important to understand. So in pediatric cardiology, and then there's a sub-branch called fetal cardiology, you have to scan the baby, but also look at other organs, which is the kidneys most of the time, and the brain and spine. So as we said, the prognosis of the diagnosis starts if you start in utero. Now, the message here, most of congenital heart disease that are obvious in utero have much poorer prognosis than the ones that present postnatally, 6 months, 1 year, or 2 years. Because if they manifest antenatally, it means that this is a serious malformation. And many of the deaths that we have in utero, abortions and IUFDs, are related to congenital heart disease and multiple defects as well. Now, what is the advantage of prenatal diagnosis? One is to the society, because as we know, if we diagnose antenatal, we transfer the fetus in utero to the hospital where the mother is going to deliver. This is the opposite to what's happening in most of our centers, that we wait until the baby is born, and then we do the oxygen testing, and then we find at day 2 there's hypoxia, and then you start thinking, oh my God, it could be congenital heart disease, and then you call the cardiologist, and then the cardiologist will do the echo, and he wants to transfer from Almoosa to wherever who will accept the case. It might take a week, it might take 2 weeks, and then you will have hypoxia. Also, many congenital complex heart disease are born with hypoxic brains already, and this baby or this fetus, used to be a fetus, will have problems in open heart surgery. So let's make the difference in antenatal diagnosis. So I said it's good for society. Also, it reduces funds to the country. If you diagnose antenatal and transfer antenatal, the cost of the transfer in utero is much less than the cost of the Medivac. So you're transferring the mama to another center. So this is very cheap and very safe with the placenta and the environment in utero. And outcomes, of course, has been proven in transposition that if you diagnose antenatally, transposition has better outcome. Hypoplas are not yet to be proven that even if you diagnose antenatally, the outcome is not very good, even antenatal, because it has a lot to do with the physiology of the perfusion of the brain and other anomalies. Now, medical professionals, for me and people like me, I find it intriguing because it's very mysterious. When I diagnose a baby at 12 or 14 weeks, at 20 weeks, the picture could be different, could be worse, could be more or less the same. When we come at 35 weeks, the picture will be even more different. So in counseling, this is very important that you know that this heart is still in the process of formation, and this is progressive. Now makes our job interesting, very interesting, although it's time consuming. If one lady would take 45 to 50 minutes to scan, because you don't tell the fetus turn right and turn left, you wait until the fetus turns right and turns left, and God knows when. And so you turn the mother as well right and left, and sometimes mothers are so big. There are lots of difficulties in the practice of proper fetal cardiology. And of course, the fetal therapy. We have a lot of mothers coming, and the obstetrician will say, oh, we have to deliver, we have to take the baby out. The heart rate is 250 in utero. So we tell them, no, we're going to give mama some medication in a higher dose, and we're going to take care of the mother until the arrhythmia arrests. So we can do fetal therapy. And also we can do fetal therapy for bradycardia, sometimes in heart block, and we can do now fetal therapy with valvoplasty of the aorta and the pulmonary artery. We can do a lot antenatal. So limitations, of course, is the training, the machine, the knowledge. If you're trained, you have a bad machine, you will not get a good outcome. If you have a good machine, but your eyes are not trained, you will not have a good outcome. Of course, the maternal habitus and gestation. So gestation used to be 18 weeks. Now you diagnose starting from 13 weeks onwards. Of course, this is I'm not going to bother you, but we have levels of cardiac screening antenatally. So we just look at the basics, and then we look at the function outflow tract. It's very complex, very, very complex, especially that the fetus is, the size of the fetus is, the heart is like a small coin. Okay. Now I just wanted to show you the beauty of having, okay, oh, can you go back? No. No. Yeah, the one before. The one before? Can you run it? So what I'm showing here, if I can, this is the 4-chamber, this is a 3D of a normal heart. So you do, 3D of a heart is important because you look at the cavity from inside. Can you, this is of course a 4-chamber view of a normal heart. I wanted to run, is it possible? Now, when you look at, I don't want to show you a 3D because it's not you start with 2D, but just to attract your attention, 3D in the fetal heart is very important because I can tell you the size of the ventricles properly. You can get it?
I think
well, let's move. Let's move.
Yeah.
Let's move. حتى move ما في? Okay. لا. What's going on? So normal anatomy is important. You have to know the normal before you go to the abnormal. So normal 4-chamber view is very difficult to diagnose. No, go back one, please. And keep it still. So the foraminal valley that we see postnatally is very important to see antenatally. And this is a 3D this is 2 atria and 2 ventricles. The direction of the flap is towards the left. In antenatal diagnosis, you don't know which is the right ventricle and which is the left ventricle, which is the right atrium and which is the left atrium. So you have to go morphologically, not by position as we do postnatal, because you can have atrioventricular discordance or concordance or plus transposition. So we look at the flap and we say, if the flap is opening to this side, then this is the left atrium. Even if you have pulmonary veins opening here, it doesn't mean that this is the left atrium. Next, please. Okay. Okay. So this is, I'm going backwards? Okay. And who does the scanning? It's usually the sonographers, obstetrics. This is where we get the referrals. And then pediatric cardiologists. The difference between pediatric and fetal cardiology. In pediatrics, fetal is a subspecialty. But many pediatric cardiologists, of course, during the training, they do like 6 months or 2 months or 1 year of fetal cardiology. But to really practice properly, you have to do at least 2 years of perinatal and fetal cardiology. And of course, our fetal-maternal specialists. So we are here, and we get from obstetrics, and we get from fetal-maternal, and we get from primary care physicians as well. You can get a lot of referrals if they know that you are interested. Indications is one is the maternal, fetal, and familial. So we have mother, baby, and family. Yeah. Okay, we'll finish. So we have here maternal indications, and very important in Saudi is the diabetes mellitus and PKU, teratogens, mothers that are depressed on lithium, alcohol, fetal alcohol syndrome, anticonvulsants, with written A for young ladies that want to have a nice skin, and they have to be free of pregnancy for 3 months. This has caused a lot of damage to the fetus. I've seen one in Austria, and she was Turkish, and she knew that she's pregnant, but she continued to take the written A for her skin, and the baby was terrible. Maternal heart disease, of course, if the mother has VSD, tetralogy, whatever. Also, paternal heart disease as well. Maternal autoantibodies in cases of SLE. This is very important. We get a lot of referrals. Of course, fetal indications, non-immune hydrops, chromosomal anomalies, arrhythmias, and so on. Now, when we talk about familial, this is where you have a pattern of inheritance of autosomal dominant or recessive. We have tuberous sclerosis, Noonan, and then Holt-Oram. Paternal heart disease usually is less risky than maternal, but we don't forget that. Previously affected childs because the recurrence risk is going to be bigger. This is the book that I had the pleasure of and the honor of being the primary author with my 2 mentors. This was an Elsevier book. We're preparing the 2nd edition, available online from Mosby as well. Now, this is a summary of what we have. So it's about 40 indications. So when I first started, I didn't get a lot of referrals, but later on with a lot of lectures, a lot of talking to our colleagues, we had really better options. Now, can we have this running? This is a case of transposition antenatally. When you see two parallel great vessels antenatally, this is very important, and we know that this is transposition. So we have the aorta is anterior, and this is outflow tract, and the pulmonary is posterior. Now, what do we see postnatal? Can we click here? Can you click on postnatal? So when you see postnatal, you see them also parallel. This is the hallmark of the diagnosis. Can you click on this? And a post-op, we do something called arterial switch. So you switch the aorta to the LV, and you switch the pulmonary to the RV. So before, in the past, it used to be atrial switching. Now it's arterial switching. And this case I've done in Tunis. And in Tunis, they don't have surgeons doing cardiac surgery except missions. And that was a beautiful case. Outcome, I don't know. Now, also we're doing a lot of fetal series. I'm organizing these courses with the Congenital Heart Academy and the Children's National Hospital in Washington. So far, we've done 29 cases, 29 series, and I advise you to take this link and look if you're interested in fetal and pediatric cardiology. We have the whole world teaching us fetal and pediatric cardiology, and for free. Now, coarctation, this is the horror of any fetal cardiologist. It's very difficult to diagnose, but one of the hallmarks is the ventricular asymmetry before 32 weeks. And so you have the arch here, and if you look at this one here, you find the narrowing here. This is the antenatal coarctation. And there is a little bit of ventricular discrepancy. We always see them back and back and back, and when they're born, usually they're not blue, but we have to look at the duct and sort of make sure that the duct is when the duct closes, the symptoms appear. It's a case, a young mother that came to me with masses in the heart. And if you look at the masses, can we go back again and play it? I don't know what's going on with these things. Can you play this? So what we see here, masses, I have to have 1 more minute, excuse me. This is, yeah, no, you have to, because this is not working, it's not my fault. So look here, you find here masses in both ventricles, and there's AV valve regurgitation. If you see this in antenatal, you say, oh my God, what is this? But actually, the lady completed her pregnancy and delivered, but before delivery, I will show you a horror 4-chamber. Can you please play this one here? We had this one here. No, go back. So you look at this one here. This is the 2D, and this is the 3D. So in the 2D, you only see sheets of masses. Out here, you can see the rhabdomyomas, rhabdo going on. And this is the rhabdo blocking the LVOT. But this was dynamic, so it didn't affect the baby. Baby was born at birth at 40 weeks, and at day 2, hypoxic because of the LVOT on and on dynamic obstruction, and he went to surgery and had this out, but we left, of course. This is postnatal. Usually the natural history is that it disappears, but this is a complex of the tuberous sclerosis complex. So the heart is okay, but then the baby will have other diseases of neurology. Now we can also diagnose starting from 12 weeks. This is a lady I've seen. She was not gestational, she was diabetic as a child, and we had can you run this, please? And at 12 weeks, you can easily see the ventricles, and you can see the thickening of the septum that we see secondary to the high insulin, low insulin changes. So 12 weeks, you can see that. It's very interesting because usually we don't see that a lot later on. Okay, next, please. Another case is, this is that you're interested in, the hypoplast. Hypoplast is very important to diagnose and very easy to diagnose. You see only one ventricle. Can you run this again, please? One ventricle here. But if you do 3D, you'll find another hypoplastic ventricle. You see, this is the this is the big ventricle and small. So it's not it's a hypoplastic. It's not absent. So this is we call physiologically dominant ventricle, which in this case is the LV. But this is another. So it's God-made. It has to have 2 chambers at the bottom, but this is non-functioning. So this is a physiologically single ventricle, but anatomically you must have 2 ventricles most of the time. Okay, خلاص.
Dr. Rima, can we conclude?
Wait. I have one more. And so this is the AV canal, and we call atrioventricular septal defect. And you see the deficiencies here. This lady, she was 33 weeks. She self-referred herself because she was afraid that she could have a Down syndrome, and she did have a Down syndrome as well. So this is the AV canal antenatally, and what you see here, oh my God, this is terrible.
So sorry, Dr. Rima, but you passed the time.
Yeah, no, just let me conclude. So we have, this is, I'm sorry about why is this thing not going? We stayed 2 hours preparing it. Anyhow, so this is postnatal, and you see here the AV canal, and this is very easy to diagnose. The outcome of AV canals, just run it to the next one. The outcome of AV canal depends on the AV valve regurgitation. This is a 3D, and run. I just want to show you one thing at the end. And so just follow us, and that's it. Thank you. Follow us on the YouTube, and we have a monthly webinars with the Congenital Heart Academy. Thank you. I'm sorry about the defect that happened.
Thank you, Dr. Rima. Are you willing to put this lecture in your YouTube channel?
No, this is not my lecture. We have a... Which YouTube channel? Oh, no, I'm not sure about that. But I'm talking about the Congenital Heart Academy Club that we have. Yeah.
Okay. Thank you very much, really. Thank you, Dr.
It's not really worth it because most of the clips didn't work.
Yeah. But really, like, very comprehensive, really lecture.
It should be better, but I'm not sure why did this happen. We ran it before.
So it's my pleasure now to present the next speaker, Dr. Mohammed Al-Khamis. Mohammed Al-Khamis is a pediatric cardiologist. He is working now at Maternity and Children Hospital in Al-Hassa as well as Almoosa Specialist Hospital. And he is going to present us the congenital coronary artery abnormalities and their clinical implication. So Dr. Al-Khamis.
Thank you, Doctor, for the introduction. I would like to thank as well the organizing committee for inviting me to present such talk. We'll be talking about congenital coronary artery abnormalities. I know I might be an intruder in this forum because I'm a pediatrician, and I will be talking about coronary arteries in presence of adult cardiologists and those who are expert in coronary arteries. However, just bear with me. We will see it from our perspective rather from adult cardiology perspective. So how do we define congenital artery abnormalities? We know that any abnormalities in the 3 main epicardial arteries will be defined as congenital coronary artery abnormalities. However, if you put such definition to those 3 coronary artery abnormalities, it means even if you have separate origin of LAD and circumflex, you will define it as congenital coronary artery abnormalities, which will end up with a chunk of cases that is normal, and it has been labeled as congenital coronary artery abnormalities. So what has been agreed upon that to label patient as congenital coronary artery abnormalities, it has the prevalence to be less than 1%. So anatomy of coronary artery, simple. We have the left main, which divides into circumflex and LAD, and we have the right from the right coronary sinus. So how do we evaluate the coronaries in pediatric population? We have the luxury in pediatrics because of better window, higher resolution images. So we are using a higher frequency probe. Usually we use S8 or S12, which is with such luxury usually not available in adult population. So usually we use those views to see the coronaries. And if you want to optimize your echo views for coronaries, you have to just modify. If you want to look for the left coronary artery, just slight clockwise rotation from parasternal short axis, and you will see the whole length of the right coronary artery and its division. And just counterclockwise a little bit from the parasternal short axis, and you will see the right. You can use the modified parasternal view, just modification of parasternal view, and you will see the length as well of the left and right coronary artery. Subcostal views also is helpful, but I thought most of the adult patients, you don't have the subcostal view that clear. So just a review. Can you just play both of them? This is parasternal short axis view. You can see on the left of the screen, the left coronary arteries, and it's dividing into the left anterior descending, and we can see the circumflex. As you counterclockwise a little, you will see the right coronary arteries, the origin of the right coronary arteries. Okay, so what are the congenital abnormalities in the coronary arteries? We can classify them as abnormalities in the origin or abnormalities in the course of the coronary arteries or its end. So first, we'll see the origin, where the coronary artery originates. And the most commonly known in pediatric population is anomalous origin from the pulmonary artery, where the coronary artery originates, one of the branches originate from the pulmonary arteries. And the most common one is the Al-Kaaba, in which the origin of the left coronary artery from the pulmonary arteries. We have less likely to have right coronary artery from the pulmonary artery. You might have just circumflex from the pulmonary artery. And the rarest, I haven't seen it actually, I just saw it in the literature. Both coronary arteries are originating from the pulmonary artery. Okay, this is typical case. Usually we see it at 2 months of age. Just to play it if you don't mind. This is typical case for Al-Kaaba, where we can see the echogenicity difference in the heart and the depressed function, as well as the mitral regurgitation. And typically, you will see the papillary muscles as echogenic, bright. And just if you put the short axis modified view, you can see, I hope the marker is seen. Yeah. This is the aorta, this is the pulmonary. Just you go a little bit higher in the short axis, and you will see the left main coronary artery actually is originating from the pulmonary arteries. And you, as well, if you put the color Doppler, you will notice, the reversal flow. Actually, the blood is coming from the coronaries back to the pulmonary artery because of the difference in the pressure. Okay, this is the only case I have for Al-Kaaba. This is just zoomed view, and we are run it slowly so that you can see it. This is the pulmonary, the aorta. The aorta. And this is the pulmonary, and you can see the right coronary artery is not originating from the aorta. Actually, it's originating from the pulmonary artery. Usually, this is benign lesion. Usually, it doesn't cause depressed function. And with significant collateralization, it resolves with time. So mostly, they don't need intervention. This is an interesting case, 3 months old. You can see the function somehow is preserved. However, you can notice the echogenicity in the papillary muscle, which tells you there is problem with the coronaries. Okay, run both of them. You can notice in the left side of the screen, this is the pulmonary, this is the aorta, and you can see the left is originating from the pulmonary artery, and this is the right as well as originating from the pulmonary artery. So the case is actually anomalous origin of both coronary arteries from pulmonary artery. So this is one example of the origin of the coronaries from the pulmonary arteries. So the other anomalous origin of the coronary arteries, it might be the origin from the not typical position from the aortic root. And this is different pathways that the coronary arteries or those branches originate from. You can have the left coronary artery originating from the right coronary sinus, and it might have variable course, and the most serious one, as we will see, is the intra-arterial course. Or you can have the right from the left, or you can have one of the branches, the LAD or the circumflex from the right, and so on and so forth, or you can have the inverted origin. Just run them. So this is, just focus on this one. You cannot, it seems to be normal. However, if you run it slowly, you will see actually the left coronary artery actually is originating from the right coronary sinus, and it has interarterial course. And this is the most serious one. This is the modified parasternal view. You can see this is the pulmonary, and the coronary artery is actually running in between the pulmonary and the aorta. Okay, this is another example. You can see the left main coronary artery is originating from the right coronary sinus. However, the course is not intra-arterial. It runs intraconal, or they call it supracrystal. It runs just deep below the aortic valve, below the RVOT. And you can see it here from the modified view as well. Okay. It is not only the origin might be abnormal. It might be the valve, the artery itself is stenosed. You can notice here from parasternal long axis view, the origin of the right coronary artery, there is flow acceleration, and it might suggest there is ostial stenosis. So, and you can see it from here. There is bilateral ostial stenosis, and this patient deemed inoperable because of severe stenosis of both coronary arteries. Okay, it is not only ostial stenosis, you might have ostial atresia. There you can see from the color Doppler, this is the left coronary artery, however, there is no flow across it. And you can notice the function is affected as well. Okay, so we talked about the origin of the coronary arteries. Now we will see another, which is the course. And you can notice here the hugely dilated right coronary origin, and the diagnosis is what? Coronary artery fistula. And you see the coronary cameral fistula. That was the origin, and it would wrap around and end in the right atrium. So this is just CT to show you the course of this fistula. You can see it starts from the right coronary, it goes through the AV groove, and it ends in the right atrium. And you can see it from the coronal cut as well. So, how to diagnose congenital coronary artery abnormalities? Usually, if they didn't manifest in the neonatal period or early infancy, usually it is incidental finding. However, the
4
one
minutes
with
remaining, sorry. 4 minutes.
2 minutes, okay. However, in young with ischemia-like, they might manifest with ischemia-like symptoms. Echocardiography, as we've seen, it is helpful as initial screening, and it will tell you about the functions. Strain might be helpful, especially if you have the affection of the coronary tributaries. The gold standard for diagnosing coronary artery abnormality is CT angio. However, MRI might be helpful for functional assessment. Angiography was there before, but with presence of CT coronaries, it is less commonly used. However, it might be helpful with IVUS and FFR. You need to assess the patient functional status. Even if you find coronary abnormalities, you have to assess with exercise tests, stress echo, or other tests. So it runs like this. Just the anatomic first, you defined by CT angio or angiography or echocardiography. Then you have to do functional assessment, whether this coronary artery abnormality is functionally affected or it can cause ischemia-like symptoms or not. If you done it, and you can do also those new techniques to evaluate the coronaries. This is I will conclude with those. This is functional status. This is ACC-AHA guidelines for adults with congenital coronary artery abnormalities, which recommend the class 1 recommendation for doing not only imaging, but functional assessment to assess the affection of those coronary arteries. And those guidelines also recommend for class 1 recommendation for any L-CABA or any coronary artery abnormalities in which there is functional affection. Okay, I will conclude with this slide because this is the future. We talked about what we have today, but the future, probably you heard about ultra-fast ultrasound, in which we know our frame rates range up to 100. However, those ultra-fast ultrasound, it talks about thousands frame per second. So with computational imaging, you can notice, you can take part just of the segments of the ventricle. With computational assessment and filtration, you can separate the perfusion from the walls, and it will tell you the perfusion for each segment in the heart. Thank you.
Thank you very much, really. Very nice talk, Dr. Khamis. Okay.
Thank you very much for this session, which is the first time we do. And special thanks for Dr. Rima Al-Badr, Dr. Nawab, Dr. Heba, and Dr. Mohammed Al-Khamis for sharing this with us. And inshallah, we'll consider this in our future conference, inshallah. And we'll try also to give more time for discussion and all these things. Because of short of time now, we'll give a break 10 minutes for prayer and break. And inshallah, we'll last session. Last session, it is very important, by the way, but the time. It is very important, really. It is already for echo in the emergency, which is very important. And the most important also, there will be prizes. 3 for people who will stay with us till the end. Okay, 10 minutes.
cardiac tamponade.
Okay, assalamu alaikum. Thank you very much, Dr. Ala, for inviting me to this echo conference. I'm going to be talking about the role of echocardiography in cardiac tamponade. So we normally have some pericardial fluid that is seen during systole. That is why it's important when we think of pathology to measure the dimension during diastole. So we take the maximum diameter or dimension of the pericardial fluid during diastole, and if it's less than 10 millimeters, then that means it's small effusion, and the volume is usually less than 100 ml. When it progresses, it becomes between 10 to 20 millimeters during diastole again. That means it can be up to 500 ml of pericardial fluid. And more than 20 millimeters is called large pericardial effusion. It's usually circumferential, and the volume is more than 500 ml. So what is cardiac tamponade? Cardiac tamponade is when we have accumulation of pericardial fluid in the pericardial cavity. We have increasing pressure in the pericardium, and it starts impairing the diastolic filling and eventually decrease in the cardiac output. So that's basically what cardiac tamponade is. And the most important thing is actually the rate of accumulation, not the volume. So if you have rapid pericardial effusion that's even 80 to 200 ml, it can lead to tamponade. However, if it's slow and over a long time, the pericardium can accommodate even 2 liters of fluid before the patient goes into tamponade. The clinical signs, we all know the Beck's triad. We have jugular venous distension because of the impaired filling, so we have high JVP. We have muffled heart sounds because of the fluid, and we have hypotension because of the decreased cardiac output. Another important clinical sign is the pulsus paradoxus. So normally during inspiration, we have negative intrathoracic pressure, brings more preload to the right side of the heart, and there's less blood going to the left heart. So normally it can put down the systolic blood pressure by up to 10 millimeters of mercury. But when you have pericardial effusion causing tamponade, it further decreases the LV output, and the pressure drops by more than 10 millimeters of mercury. What do we see on ECG? We see electrical alternance. This is because the heart is moving freely in the pericardial sac. So when it's closer to the precordium, it's going to give us a higher voltage. And when it's further away, it gives us a lower voltage. And this is what a typical swinging heart looks like on echocardiography. All right, so we said we have increasing pericardial pressure, right? So which chamber in the heart has the lowest pressure? It's the right atrium. So once the pericardial pressure increases above that of the right atrium, it's going to cause it to collapse. This is a very sensitive sign of tamponade. Sensitive meaning if it's absent, then it helps rule out tamponade. And if we actually look at the duration of collapse, not just aria collapse, but the duration of aria collapse in relation to the whole cardiac cycle, and if it's more than 1/3 of the cycle, that's very highly sensitive and specific. You can see it reaches up to almost 100%. We need to keep in mind that we might have false negatives. So if we have pulmonary hypertension, we might not have this RA collapse because there's high RA pressure. So when the pericardial pressure goes up even further, it becomes higher than that of the RV during diastole, right? And this is very specific. Specific means it helps rule in cardiac tamponade. Initial stages, it's only seen early during diastole. And it's seen during expiration because the right-sided pressures are lower during expiration. Starts with the RVOT. As it progresses, it can be seen throughout diastole, can be seen during both inspiration and expiration, and starts involving the RV body as well. Okay. We said we have decreased or impaired filling of the heart. We have high pericardial pressure. This is all reflected back on the veins, including on the IVC. That's why the IVC diameter is usually more than 21 millimeters. And on inspiration, there isn't a more than 50% collapse. Again, this is a very sensitive sign of tamponade, about 97%. And here we need to be careful about false negatives. If we have hypovolemia, you might not have IVC plethora and still have tamponade. So you need to take the whole clinical picture in context and not just depend on single signs. Another important feature is ventricular interdependence. So we said we have pericardial fluid, and it's restraining the movement of the cardiac chambers. So the ventricles start depending on each other. As I said, when you take inspiration, you have more of blood flow going through the right side of the heart. So this is going to push the septum towards the left. And conversely, during expiration, we have more blood going to the left side of the heart, which is going to push the septum to the right side. And this kind of interdependence or exaggeration in respiratory variation can be documented on pulse wave Doppler. So when you put the pulse wave Doppler, take the difference between the E velocity, whether it's on the mitral or tricuspid valve, and take the difference between expiration minus inspiration, divided by that during expiration. So if it's more than 25% on the mitral valve, so mitral valve is on the left side, so the velocities are going to be higher during expiration. On the tricuspid, they're going to be higher during inspiration. So these are the cutoffs, more than 25% on mitral, more than 40% on the tricuspid, and more than 10% variation in the outflow tracts. This is a summary slide of echo features. He said sensitive signs are RA collapse, IVC plethora. Specific signs are RV diastolic collapse. And if you look at RA collapse in terms of the cardiac cycle, if it's more than 1/3, that's the sign with the highest sensitivity and specificity. Special population that we need to keep in mind is those with pulmonary hypertension, because they already have high right-sided pressures. They have high pressure in the RA, in the RV. So even if the pericardial pressure goes up, it's not going to be able to collapse the right side. Instead, what we see is LA collapse, as you can see in this case here. LA collapse during diastole, because it's normal during systole. And also, we find LV compression during diastole. And this is very tricky, so always keep it in mind in cases of pulmonary hypertension, because sometimes it's missed. If you don't think about it, you're just going to be looking at the right side. You see that there is no compression. The patient has worsening effusion. And you might think that patient does not have tamponade. But we need to keep in mind that look at the left-sided chambers. All right, so what's the treatment? Because it's fluid causing compression, we need to remove this fluid, right? Before we think about removal or pericardial drainage, we need to make sure that we don't have any contraindications. So the contraindications are ascending aortic dissection, ventricular free wall rupture post-MI, iatrogenic hemopericardium, because it's going to be difficult to control the bleeding, if we have bleeding diathesis, and severe pulmonary hypertension. Previously, pericardiocentesis was done blindly, and this is the first case of echo-guided pericardiocentesis. This is from 1979, done at the Mayo Clinic, where they used 2D echo to locate the pericardial fluid, to decide on their angle of axis, and help drain the fluid. So the role of echo, we need to see where the biggest window is, whether it's closest to the precordium from the apex, from the parasternal window, or from the substernal. And we also need to help decide on a direction of drainage. So for example, if you look at here, if you go in this direction, you have risk of probably injuring the heart. You need to pick a direction where you're going to be safe. You're not going to be injuring any vital organs. Obviously the cardiac chambers, the lung for pneumothorax, the liver, and the thoracic vessels. Nowadays, we have this scoring triage system since 2014, and it's recommended by the European Society of Cardiology. Once we have evidence of cardiac tamponade, the first step is to score the etiology of this pericardial effusion. And the etiology with the highest score is malignant disease and tuberculosis. Interestingly, some etiologies actually have negative score. So if you have thyroid dysfunction or autoimmune disease, it gives you negative score. The next step is to score the clinical presentation. And again, the sign with the highest score is if you have orthopnea when you're lying down and your lungs are clear, there's no crackles. The other important sign is obviously pulsus paradoxus, and if you have rapid worsening of symptoms. And if it's a slow chronic disease, then that gives us negative points, all right? Then the third step is to score cardiomegaly on chest x-ray, ECG changes, and the echo signs that I talked about the volume, the chamber collapse, IVC plethora, and if we have a swinging heart or not. Obviously, if you have any of the contraindications that I mentioned, these patients should be going for urgent surgical management regardless of the score, okay? Otherwise, we calculate the total of all these three steps. If the score is 6 or more, these patients need urgent pericardiocentesis. However, if it's less than 6, we can probably wait on them for even up to 48 hours. All right, each axis has its advantages and disadvantages. The apical approach is usually about 1 to 2 centimeters lateral to the apex beat. Here we have risk of ventricular rupture and pneumothorax. Parasternal is at the left fifth intercostal space, just next to the sternum. And if we go more laterally, then there's risk of injuring the internal thoracic vessels like the internal mammary artery. Subxiphoid is between the xiphisternum and the left costal margin. Here there's risk of lacerating the left liver lobe, and it's also the longest distance to the heart, actually. This is the adequate position. Patient should be in a semi-reclined position. We prepare them in sterile methods, make sure we have a sterile sheath for our probe, locate the effusion, decide on the angle of entry. So in this case here, we have pericardial effusion. It looks like a modified apical approach. You can see the needles coming in. However, the angle, it's a bit tricky, right? If you go a bit deeper, you might injure the ventricle. So you need to be careful. Make sure you're going away from the cardiac chambers. And while you're putting in the needle, we need to put negative pressure so that once we're in the pericardial space, you're going to see pericardial fluid coming into the syringe. And make sure that the tip of the needle is in the pericardial sac during all cycles of systole, diastole, inspiration, and expiration. We can also inject a small volume of agitated saline just to make sure we're in the pericardial space and not inside the cardiac chambers. After that, we put in a J-wire and introduce a pigtail catheter to allow for drainage. So complications are quite rare, especially if you use echo properly, we do a good guidance, we can avoid most of these complications. However, one complication that we need to think about again is those with pulmonary hypertension. So we said these patients have high right-sided pressures. We relieve the pericardial pressure, there's going to be a gush of blood coming into the right heart. And this really impairs the cardiac output from the left side of the heart. So there's multiple small studies or actually case reports where they talk about the speed of drainage. So if we drain the fluid rapidly, it's going to cause bad outcomes. So they recommend to do 500 to 750 ml initially just to relieve the tamponade, and then the rest of the fluid should be removed over even 24 to 48 hours. All right, so that's my last slide. In summary, we said cardiac tamponade is raised pericardial pressure when it exceeds the intracardiac. Rate of accumulation is more important than volume. The sign with the highest sensitivity and specificity is the RA collapse more than 1/3 of the cardiac cycle. Don't forget pulmonary hypertension in terms of diagnosis and drainage. A score of 6 or more in the absence of contraindication. These patients need urgent pericardiocentesis, and echo is essential in guiding throughout the procedure. Thank you very much.
Thank you so much, Dr. Akram. Thank you for sticking to the time precisely and striking the pragmatic points about tamponade. Next is Dr. Mahmoud Shihata. He is a lecturer and consultant cardiology in Port Said School of Medicine, University Hospital. He had special training in advanced 3D and strain, and his talk is going to be about, this is his second time presentation, is going to be about echo in cardiac trauma. Welcome, Doctor.
Bismillah ar-Rahman ar-Rahim. Thanks for having me. For the second time, I have a talk about the role of echo in cardiac trauma, and part of this will be covered in the session, like tamponade, dissection, and so on. So, first of all, the incidence of cardiac trauma is around 25% of trauma's deaths is due to cardiac trauma, which is either blunt trauma, which represent around 70% of the cardiac traumas, or penetrating trauma, 30% of traumas. The penetrating traumas may be due to stab wounds, which represent around 60-70% of the penetrating traumas, and may be due to gunshots, which represent 30 to 40%. What we should know, this term is a cardiac box. This cardiac box is the danger zone. This box is bounded by the pulse clavicles and the mid-clavicular line and the costal margin. So any injury inside this cardiac box can carry a very high risk to cardiac trauma and cardiac injury. But to be noted that even some injuries outside of this box carry the same risk of hitting the heart and penetrating or planting the cardiac structures. What is in this box? This box contains the cardiac structures, the pericardium, the great vessels, and also contains the esophagus and the intrathoracic trachea and the main bronchus. Penetrating trauma usually affects most commonly the right ventricle, which is the most anterior structure. And if it penetrates inside the heart, it can cause a VSD, which is the most common intracardiac injury. While the non-penetrating traumas, the blunt traumas, can cause what we call previously myocardial contusion, and can cause also coronary artery injury and AV, atrial or ventricular chamber rupture. The management of cardiac trauma is how to be emergent, urgent, and early. You have to have early first aid, early basic and advanced life support, and early advanced therapy like repair, and early rehabilitation of the patient. So you have a very important rule for echo in cardiac trauma patient or in trauma patient in general, because echocardiography has a role in the evaluation of the cardiac as well as non-cardiac trauma patients, not only in the trauma resuscitation phase, but also during the critical illness period. Oftentimes is very limited, and detailed echocardiography is possible only in the post-resuscitation phase. In resuscitation scenario, focused assessment protocols are used to evaluate for life-threatening cardiac injuries. And in the post-resuscitation phase, echocardiography may help unmasking a pre-existing cardiac pathology or trauma-related pathology, which may influence the management. And transesophageal echocardiography can play a role and should be considered if the transthoracic views are inadequate. So we have to apply some of this knowledge. This is a case presentation. This is a 30-year-old male, and he has no past history. And he came with anterolateral chest stab wound during a street fight. And when he presented to the ER, the already assaulting knife was removed. And this is another advice. If you have an assault, if you have a stabbing wound, so keep the assaulting tool in place till you have a sternotomy. He presented to ER with blood pressure hypotension, 70/40, 120 beat per minute at steady pulse, and overt bleeding. And as I said, the assaulting instrument already removed. Emergent ultrasound protocol received showed the precardial tamponade. Emergency thoracotomy. With the operative data, they found an RV anterior wall tear, simple suture repair with evacuation of the precardial hematoma. And the patient was stabilized and discharged 1 week after. After 3 months, he began to complain of dyspnea grade 3, orthopnea, and BND, and he referred for a follow-up echocardiography. I believe we have a case yesterday like that. This is the parasternal long axis view. And remember, the patient has no previous cardiac history, and he has presented with a mitral regurgitation. And we have an impression that this mitral regurgitation is not coming from the orifice of the mitral valve. It seems to come from the posterior leaflet itself. And in a focused view, we have a defect in the posterior leaflet around 3 millimeters. The forward chamber view revealed a little bit mildly reduced LV function, maybe 45 to 50. Again, there is a mitral regurg, which comes from a plane outside the orifice of the mitral valve, and the Doppler flow show a dense mitral regurgitation, indicating that it is significant. And going to the two-chamber view, we have noticed the abnormal color in the anterior wall in a recess or a pseudoaneurysm, or what you call in the anterior wall. This color is going into this recess and coming back to the left ventricle in a to and fro way. In the short axis view, again, this recess in the anterior wall, and biplane method revealed ejection fraction of 45 to 50. The transesophageal echocardiography was a little bit low quality for this patient, actually. This is the forward chamber view. And this modified 5-chamber view, I was not that happy about the posterolateral wall of the left atrium. It seems to have a recess like what we see in the left ventricle. If I have that. This one. Putting color, the color does not mimic the LV. It does not go inside this recess in the left atrial wall. Again, there is a severe mitral regurgitation. And this mitral regurgitation does not enter this recess. The hole in the posterior mitral leaflet is already very small, 2 millimeter. And in this another modified view, we can appreciate here the recess in the anterior wall we have seen in the transthoracic echocardiography. So this recess dimensions, length was about 2.6 centimeter with the orifice diameter about 5 millimeter. So the theory is that stab wound 3 months ago just came outside from the pericardium, RV, and hit the anterior wall, going through the posterior mitral leaflet to the posterior left atrial wall. The cardiac MRI confirmed the diagnosis, and the patient was referred to surgery. This editorial comment came from the JACC in 2020 revealed the rule of focused ultrasound. It described it as a masterpiece in the puzzle of the chest trauma evaluation. And they stated that the diagnosis of cardiac trauma is usually not easy, and the ultrasound evaluations through the EFAST, which is the extended protocol, is a method of choice to provide initial information about the presence of pericardial effusion with sensitivity of 100% and specificity of 97%. And the gross changes in the function and structure of the heart can be elucidated. Subsequently, a comprehensive transthoracic echocardiography should be performed in all patients with blunt chest trauma or refractory shock without a clear etiology, with the goal of identifying changes that may require immediate intervention. This is the EFAST protocol, all or no, the subcostal view to assess the function, the chamber size, the pericardial effusion, and then go to the right upper quadrant view and left upper quadrant view to show the liver and the spleen respectively, and go down to the pelvic view and fifth and sixth intercostal spaces and anterothoracic views for pneumothorax. This is the EFAST protocol. The EC guidelines published in 2013 about the emergency echocardiography stated that in chest trauma, you have to do echocardiography to detect pericardial effusion, myocardial contusion, or laceration, regional wall motion abnormalities, acute valvular regurgitation, and aortic dissection in patients with severe deceleration injury or chest trauma. While patients with only mild chest trauma with no electrocardiographic changes or biomarker evaluation, routine evaluation using echocardiography is not indicated. The limitation to use echocardiography, although it is a bedside, portable, and you can do it for every patient, trauma patient, mild, moderate, or severe trauma patient, that the patient may be unstable, the image quality with a stabbing knife in the chest, it can be of questions, and the time. The surgeon wants the patient rapidly in the OR, and you are telling him, I will do him a full echo report. So when you have the opportunity to look at your patient with echo, you have a framework to do. You have to assess the volume status to help in guiding the resuscitation, the LV and the RV function, the valves, the pericardial effusion, the aorta, and the other cause of shock. You can notice the hemothorax, you can notice the pneumothorax and ascites. And my take-home message is just this picture. When you use an echo, it can be as if you have a situational awareness. You are not focused on the pericardial effusion, but it is, and you are saying it is fine, I drained the pericardial effusion, while the whole house is burning out. Thank you.
Thank you so much, Dr. Mahmoud. Now we move on. Okay.
Our following speaker is also a well-known Dr. Abdurrahman Jamil. He is a consultant of adult cardiology and echocardiography. He's an assistant professor in King Saud Ibn Abdulaziz Hospital, University. He has a fellowship of Saudi board in adult cardiology, many certificates in echo, diploma, American, European certificates. Welcome.
Thank you, Haitham, for nice introduction, and thank you again for having me today. So my talk will be about role of echo and POCUS in critically ill patient and emergency room. So I will start with this case. I will show you real cases from our hospital. All these patients, I am personally involved in their management. So the first case, 45 years old, patient with end-stage renal disease, referred for dialysis from other hospital. While he in the medical ward, suddenly he developed severe shortness of breath, severe tachypnea, and you can see his chest X-ray, globular heart, and tachycardia with pulses alternance. So it's not difficult to guess with this history. The technician who is doing the echo immediately she called us, and it's not difficult to guess why the patient is collapsed, and we tried to save him, but unfortunately we were not able to save his life. He died, unfortunately, because they sit on him for 2 weeks in hospital, tertiary hospital, until he collapsed. They didn't. Anyway, so it's a very sad story. My colleague, Dr. Akram, he already touched the cardiac tamponade. I will not talk about this one, but these are all signs of echo tamponade. The second case, 37 years old female, known case of SLE and antiphospholipid syndrome, came to ER with severe shortness of breath, tachypnea, tachycardia, and hypotension, desatting, and also it's not difficult to guess what she has. She has acute pulmonary embolism with compressed, very hyperdynamic small cavity LV and RV. Dr. Ala, I think, will talk about pulmonary embolism. I will not waste your time. So I'm sure he will give us a very good review about pulmonary embolism. But this is how echo can diagnose these patients in ER. And the RVSP in acute pulmonary embolism, it will not be more than 60 usually, because the RV will fail before generating a high pressure, not like in the chronic pulmonary embolism. This patient, we found the saddle-shaped thrombus in the pulmonary trunk, main pulmonary trunk, and she went, that time we take the patient for surgery, this patient. Case number 3, 72 years old, gentleman, diabetic, hypertensive, ischemic heart disease, PCI 3 years ago, and post-non-cardiac surgery in ICU. They call us, page cardiology on call, the patient in cardiogenic shock. Okay, so when we did an echo, and this is his ventricle. Do you think this is jumping and hyperdynamic ventricle? The patient has cardiogenic shock? No way, okay? And you see the IVC. So the tank is empty. This patient has internal bleeding discovered by cardiologist, okay? The patient hypovolemic shock, not cardiogenic shock. So this is one of the important role of echo in ICU. Case number 4, 61-year-old lady admitted with late STEMI, cath 3 vessel disease accepted for CABG. While she was waiting for CABG in CCU, she developed pulmonary edema, frank pulmonary edema. And this is her echo. So the mitral valve looks okay, but she has severe mitral regurgitation. But we don't expect this mitral valve, which structurally looks normal, to give us this pulmonary edema. So this is her short axis again, and we see some flickering here, but we don't know what is this flickering mass here. Okay, again, severe MR. And when we do focus view, we found that she has papillary muscle rupture as a complication, mechanical complication of MI. And this is a very severe AI, so patient went for CABG and mitral valve replacement. Case number 5, this 47-year-old female came to ER with severe chest pain and severe shortness of breath in ER, cardiac arrest, and this is her bedside echo. So again, she has papillary muscle rupture, this time avulsion of the papillary muscle, and she has severe pulmonary edema in ER. Again, we couldn't save this patient. She died after arrest in ER. So this one, okay. Can we go back? Sorry. Found LV failure, RV infarction, LV aneurysm, or ischemic MR. All this condition will give us cardiogenic shock. Pump failure. Another patient referred to ER with sudden severe shortness of breath, remote history of shortness of breath and murmur, tachycardia, hypotensive. This is his transthoracic echo, patient tachycardic, very severe eccentric swelling MR, but we don't know what is going on. So we did a TE, and you can see very clear chordal rupture with severe mitral regurgitation. Patient went for mitral valve repair. This patient is similar to cases presented by Dr. Mahmoud. This is patient had multiple trauma following road traffic accident, and they call us cardiology because the patient had pulmonary edema, and they don't know what is the reason. They don't know why this patient went into pulmonary edema. So we did transthoracic echo, but unfortunately, patient has multiple fractures, chest tube, bilateral, intubated, very bad quality. So I did for him TE, and this is his TE. Can you, yes, can you play? Okay, thank you. So we see flickering mass here, and with very severe eccentric MR, and when we did 3D, we found that this patient had avulsion of this scallop, P1 scallop, and giving us severe mitral regurgitation following trauma. Okay, he had blunt trauma. Okay, so the next case came with chest pain, and this is his ECG, inferior ST elevation MI, very severe chest pain, 10 out of 10. Patient is screaming from pain, and this is his echo. Okay, sorry. So he had aortic dissection. I think there is, we have talked also about aortic dissection, so I will skip this one. But this patient also very helpful transthoracic echo and we have many cases diagnosed by just transthoracic echo. Case number 12, 32-year-old female, had fever for 1 week, severe shortness of breath 1 day, heart murmur, and this is her echo. Can we play the video, please? Thank you. Okay, so she has endocarditis, okay, of the aortic valve with a flail and torn leaflet or cusp of the aortic valve is very severely high. This patient also unfortunately died in ER. Very, very sad story. So, okay, and we see the very cute AI. This patient has mechanical valve. Can we play this one, please? Okay. So, mechanical valve, only one leaflet is moving, okay, and chunk of mass here. This patient has obstructed mechanical mitral valve, stuck valve due to subcerebratic INR, and these are the steps how we access or how we assess the mechanical valve obstruction or dysfunction. I will not, for the sake of time, and not go this one. Okay, so you see one disc is stuck, the other disc is moving nicely, and this is by 3D, very clear that the disc is on. So I finished with the role of echo. Now, role of POCUS, point of care ultrasound. I will be quick here for the sake of time. So in POCUS, this is very important. I think in ICU and in ER, each physician should master this one because it saves life of patients. So rapid ultrasound in shock, there is something called rush technique. or rush views, where we have like 9 views. Okay, this will diagnose all emergency pathology by POCUS, parasternal long axis, apical 4, inferior vena cava, and hemothorax, bilateral, splenorenal, the region, bladder view, aortic slide views, pulmonary views. Anyway, we need to master this because we can diagnose a lot of emergencies by this one. So what we examine by rush technique, we examine the pump function of the heart, we examine the tank, whether it's full or empty, and we examine the pipes, which is the vessels. If you have dissection, aneurysm, or DVT, these are very important, and this is the rush technique. This is the evidence, how the role of IVC, and these are all studies done about the effectiveness of POCUS and importance of POCUS, and when to use POCUS. We use it in critical care setting, emergency department, outpatient clinic, and it is used by anesthesiologists, by physician, by cardiologists. All of this, when to use POCUS, when we suspect cardiogenic shock, septic shock, or something else, or hypovolemic shock, we can differentiate by this one. And this is the evidence of benefit of POCUS. I don't need, I think, to convince you that the POCUS is very important. It is cheap, readily available, accurate, reproducible, easy to use and interpret, and no complication, no side effects. Okay, and it is very accurate. And nowadays we have handheld echo. الشباب عندنا الفيلوز عملوا قطة سماها بالسعودي قطة كده، نحن سماها خطة أو جمعية أو شيء، اشتروا لهم هاند هيلد ايكو بكم 15,000 أظنه شباب عبد الرحمن، ايوه 15,000 أظنه اشتروها. اوكي، بدل يستعملوا الاستيثوسكوب حطوها على جنب وبدأوا يستعملوا الهاند هيلد ايكو for each patient ويرسلوها للكونسلتنت اللي معاهم او السينيور for this very helpful handheld echo. ممكن توصلها بالجوال، ترسل الصور كده. اوكي
2 minutes دكتور
طيب.
عبد الرحمن.
Yes, yeah, خلاص I'm finished. This is my last slide, sorry. So take home messages, bedside echo and POCUS in specific has a tremendous role in the ICU, where it can be used for initial diagnosis assessment of critically ill patient. POCUS is the non-invasive test with good accuracy, no radiation, can be performed at bedside anywhere. POCUS has been a recommended part of critical care fellowship, and the training needed, I think we do training for technicians, for radiology technicians, for doctors, all levels. I think they should have training of POCUS. Thank you.
Thank you, Dr. Abdul Rahman, for the nice cases. The following speaker also is well known to the audience, Dr. Huda Shahada. She has presented a nice case yesterday. She is a consultant of interventional echo at King's College Hospital in London. She has many degrees in echo, master degree from Egypt, fellowship, and PhD from Italy. Yes. She will speak about aortic dissection.
Thank you. Thank you for the introduction. Good afternoon, everyone. And thank you for staying late on Saturday. So my talk for today, it's about the role of echocardiography in aortic dissection, where every seconds count. So first of all, I have nothing to declare. For the background of aortic dissection, actually it's graded as a rare but catastrophic aortic syndrome, which is associated with high 30-day mortality rate, especially in type A aortic dissection. The diagnosis of classical aortic dissection is depending on the presence of an intimal flap, which separates the aortic lumen into two lumina, true and false lumen. So when we go back toward the anatomy of or the histology of the aortic wall, we can check that the thin layer of the aortic wall, which is called the intima, the inner layer, which is formed of thin layer of endothelial cells. And then we go to the middle layer, which is the thick layer, and the most important one, which is the media containing the smooth muscle cells, elastic fibers, and collagen fibers as well. And the last one, which is the outer layer, which is called the adventitia, which contain the blood supply and nervous supply to the vessel wall. And then regarding the zones of the aorta, actually it's divided into 5 zones. The first one, which is called the aortic root, from the annulus till the sinotubular junction, and then the ascending aorta from the sinotubular junction till the innominate artery, then the arch of the aorta till the left subclavian, then the descending thoracic aorta from the left subclavian till the diaphragm, and then the abdominal aorta. Regarding the definition of the aortic aneurysm, many definitions have been settled, but actually the most true one and accurate for definition of aortic root and ascending aortic aneurysm is to use the cutoff with more than 4.5 centimeter for the ascending aorta and the aortic root. However, in the patients with extreme deviation in the size, like the patients with too big or too small body surface area, we can index the aortic size to the height, to the body surface area, or even the cross-sectional area to the height. Regarding back again to the aortic dissection, so we have 2 famous classifications. So the first one is called Stanford classification, which classify the aortic dissection into type A and type B. Type A, this include any dissection in the ascending aorta, and type B include any dissection away from the ascending aorta, including the arch descending thoracic aorta. And then the Becky classification, it's subclassified, the Stanford classification according to the site of the intimal tear. So if we have an intimal tear here in the ascending aorta and extending into the descending thoracic aorta, this is type 1. If it's just confined to ascending aorta, this is type 2. And then type 3 is classified again into 3A and 3B. 3A, if it's the intimal tear is in the descending thoracic aorta and confined there, and the 3B if it's extending more into the abdominal aorta. There are 3 common types of acute aortic syndromes. We should know the difference between them. The commonest type here is the aortic dissection. The clue here, or the hallmark, is the presence of the intimal tear here that allow the blood to creep from the lumen into the media here and creating, this is the true lumen and the false lumen of the aorta. The second one, which is less common and less complicated, the intramural hematoma. And we can appreciate that there is no intimal tear here. So, and also there is no color flow could be seen here in the echo, as we are going to see later. The last one is the penetrating atherosclerotic ulcer. This is usually more chronic process. It happens in the patients with multiple cardiovascular risk factors like dyslipidemia, hypertensive, smoker, and then the ulcer rupture into the wall here and the blood start to creep inside the aortic wall. So what is the most common presentation? Sometimes the patient comes with malperfusion and organ ischemia. So the mechanism of end-organ ischemia in this patient, either to the brain, to the gut, to the renal, or the kidneys. So the most common mechanism is a static one. So the dissection flap extends into the lumen of the feeding vessel, complicated by thrombus, or either dynamic. There is no dissection extending to the feeding vessel. However, the intimal flap compressed the ostium of the feeding vessel secondary to the false lumen compression, or maybe static and dynamic. So back again, what is the rule of the echo? So transthoracic echo, actually it's diagnostic, but it's more sensitive in patients with type A aortic dissection, reaching to 90% sensitivity and 96% specificity. However, it's much lower in type B aortic dissection. Contrast TTE has increased the accuracy of the diagnosis, reaching a sensitivity nearby close to the TOE in diagnosis of type A aortic dissection, but still more limited in patients with non-extended or localized dissection, intramural hematoma, or aortic ulcer. So this is a case of a type A aortic dissection here. We can start with the parasternal long axis view. We can appreciate that we have an intimal flap here, and also there is loss of intimal support to the one, either none or left coronary cusp here. Even we have a flail cusp and severe aortic valve regurgitation. And also we have, sorry? Is it okay? Yeah. And then we have also maybe a dissection flap here also in the descending thoracic aorta. And then when we go to the parasternal short axis view, we can appreciate here with modified view that we could see circumferential dissection here, and even it's extending to the non-coronary cusp with severe aortic valve regurgitation. In the apical views, there is a severe aortic valve regurgitation with color flow, with PISA, and also with the pressure half-time. And don't forget to look at the suprasternal view to see the extent of the dissection flap here, so we can see clearly that it's seen even in the arch of the aorta and also descending thoracic aorta. This is another patient of type B aortic dissection, discovered accidentally. The patient has a mechanical mitral valve replacement, just was coming for assessment of the mechanical prosthesis, and accidentally we discovered this dissection flap in the echo. However, what about the TTE? TTE is a good positive tool for the diagnosis of aortic dissection, especially type A, of course. However, if it's negative, we couldn't rule out aortic dissection. So especially if we have red flags, like the patient is presenting with persistent chest pain, aortic root dilatation, new aortic valve regurgitation, or pericardial effusion. So we can go for the TOE at this point. The TOE, the sensitivity and specificity is reaching 100%. We can see the whole aortic tree except for the distal part of the ascending aorta, and also it can help in the differentiation of the intramural hematoma from the aortic dissection. When we have a circular or crescentic thickening of the wall more than 5 millimeter, no flow, which is important, the hallmark, and displacement of any intimal calcification, this go more with the intramural hematoma, or if we have a smooth inner margin of the intramural hematoma, all that is suggestive for diagnosis. However, all of us, we are afraid of the risk of aortic rupture, especially if the patient's coming with persistent chest pain or hemodynamically unstable, or with cardiac tamponade. So if we are going to do it, so it's better to be done on table inside the theaters. And also, if we are going to do it as an outpatient, be sure that the patient has no chest pain, hemodynamically stable, adequate sedation with strict blood pressure control. So, and also another question that we are going to be asked inside the theaters by the surgeon if he's going to do the cannulation of the aorta. The preferred side is to do axillary artery cannulation, but I have seen in the hospital in King College that sometimes they do the cannulation into the arch of the aorta, so we need to differentiate between the true and false lumen. Because if you are going to put the cannula, we should insert the cannula inside the true lumen. So how we could differentiate that? Actually, the false lumen is bigger than the true lumen, and also the true lumen has systolic pulsation, systolic antegrade flow, and if we injected contrast echo, we can see that the contrast swirling early and fast in the true lumen more than the false lumen. Also in the echo, either transthoracic or transesophageal echo in the transgastric view, we need to check for pericardial effusion. The most common mechanism and carried the worst prognosis, which is the extravasation of the blood from the aorta into the pericardium. The second or the third question that we are going to be asked about the aortic regurgitation, which is seen in 40 to 76% of the patients. We have many mechanisms for the aortic valve regurgitation and aortic dissection. Maybe dilatation of the aortic annulus secondary to the part of the aortic aneurysm here, or maybe loss of the intimal support for the one of the cusp, and this causes partial or complete prolapse of the aortic valve, or maybe prolapse of the flap itself inside the aortic valve, or the patient has a previous aortic valve disease like bicuspid aortic valve. Coronary artery involvement, also the involvement of the coronary artery could be seen in 10 to 15 patients, most commonly with the right coronary artery. So we have to look for new regional wall motion abnormalities in the TTE as well. The most common mechanism either to include the coronary ostium in the dissection or associated coronary dissection is seen. So we can see it here. This is the ostium of the right coronary cusp, and it's originating from the true lumen. And here in the biplane, we can see the left main origin as well. So if I have a suspected aortic dissection, if I have a TTE-based service, I will start with TTE, and this is the most common protocol. So if I have type A aortic dissection, confirmed diagnosis, the patient should go immediately to the theaters. If we have type B aortic dissection, I need to do TOE or CTE. And if the patient has no conclusive, I mean, as we mentioned before, it's not a good negative tool. So we have to do TOE or CT. If we are based more CT-based service, so we can start with the CT, but at the end we are going to do the TTE because we need to know the aortic regurgitation, if the patient has new regional wall motion abnormalities, and the LV function and size as well. So the rule of preoperative TTE and TOE is to assess the entry tear location, mechanism, and severity of AR, aortic root dimension and annulus, pericardial effusion, and tamponade physiology if present left ventricular function, global and segmental. The most common treatment for those patients is usually replacement by a composite graft, synthetic one, with valve, mechanical prosthesis, and reimplantation of the coronary artery, especially if you have significant aortic regurgitation caused by aortic root dilatation or branches. So at the end, if I have a patient with acute aortic dissection with malperfusion treatment, and I have a patient with type A aortic dissection with rupture or tamponade or stroke, I'm going to the theaters immediately with ascending aorta and the arch surgery or replacement. If I have a malperfusion syndrome, I mean that the dissection is the extending renal or the gut or the lower extremity, we are going to replace the aorta and then going to antegrade TEVAR. And then type P aortic dissection, if it's complicated with rupture or tamponade, TEVAR is the most commonly used treatment modality. And if the patient has mesenteric or renal malperfusion, again, TEVAR. But this is for the complicated type B aortic dissection. So what are the surgical options in patients with type A aortic dissection? The main issue here is the extent of the dissection and also the aortic valve regurgitation.
2 minutes.
Oh, sorry, I'm nearly done. So if I have a partially dissected root but no significant aortic valve leaflet pathology, we can do aortic valve resuspension instead of doing aortic valve replacement. If we have extensive destruction and flail aortic cusp, so we are going to do aortic root replacement plus mechanical or biological aortic valve conduit in selected patients where the aortic valve is spared totally, so we can do valve sparing root repair. In patients with involving a small tear, intimal tear in the arch of the aorta, we can do hemi-arch repair. And finally, as we mentioned, if the dissection flap extending into the descending aorta, we can do TEVAR in addition to the replacement. So, and this is a case here, preoperative. This is TOE on table. We have type A aortic dissection, moderate aortic valve regurgitation with dilated annulus. And here we can see the synthetic graft here. Is just do suspension of the aortic valve with no residual aortic valve regurgitation. So maybe I can jump to the conclusion. So to conclude, echocardiography plays an important role in the diagnosis and follow-up of aortic disease. Transthoracic echo permit adequate assessment of several aortic segments, particularly the aortic root and the ascending aorta. TTE is vital in emergency setting to detect the intimal flap, pericardial effusion, and LV function as well. TOE should define the entry tear location, mechanism, and severity of AR and true lumen compression. Although other imaging techniques such as CT and MRI has great value in diagnosis, however, still echo portable, rapid, accurate, and cheaper in the diagnosis and follow-up of most aortic disease. Thank you so much.
Thank you so much. Thanks a lot. Okay. Now we come to the last presentation, Dr. Ala Khalil and pulmonary embolism. Dr. Ala is the gentleman, the leader behind this conference. So please, before he starts, join me to congratulate him for this astounding success with warm round of applause.
Assalamu alaikum. I would like to thank you all that you are kept already holding with us until we finish our event today. I'll try to be very fast, inshallah, because most of the people already talked about many things which I'll cover. Echo in pulmonary embolism. As you know that the gold standard for pulmonary embolism is CT angio and ventilation perfusion scan. But echo is the most used image modality for evaluating and managing patient for the pulmonary embolism, because as you know that it is easy and available and also reduced one. In the echo, we are looking for the patient for pulmonary embolism. Mainly, we are concentrating on the right side, on the right ventricle. In the right ventricle, we say that already for dilatation. The dilatation of the right ventricle, it means that already we measure the diameter of the right ventricle at the basal part, which is more than 42 millimeter, or in the mid part more than 35 millimeter. And also looking for the ratio between the right ventricular side and the left ventricular side, which will be more than 1 in this condition. And also we'll see that about the movement of the right ventricular interventricular septum with the paradoxical septal motion, which is one of the signs also of the RV dysfunction, as we'll go for the other signs for the RV dysfunction, which is that RV hypokinesis and the sparing of the apical part, which is that meconal sign. We'll go for this in details. And also increase of the TR velocity are also, this is the evidence of the patient with RV dysfunction. Echo markers for systolic dysfunction. We are all using this in our lab, using the TAPSI, and the TAPSI, if it is in the patient with pulmonary embolism, it will be less than 1.6 centimeter. In this condition, it will be associated with higher pulmonary artery pressure, okay, and the higher incidence of the RV dilatation and the free wall hypokinesis. In addition, the tricuspid annulus systolic velocity by tissue Doppler, it will be less than 10, and in some papers say that less than 9.5 centimeter. Or this is derived from the Doppler, from the tissue Doppler on the lateral tricuspid annulus. It is another way to assess for the RV dysfunction. This is the way we are measuring the TAPSI. And also some point also, when we are looking for decrease the RV free wall motion in the systolic function, you are in a mess in this condition. Is it due to right ventricular hypokinesis? It is due to the infarction, RV infarction, or it is due to pulmonary embolism? In pulmonary embolism, we will find that the presence of the pulmonary hypertension is there. It will be indicative that it is due to pulmonary embolism, not RV infarction, because RV infarction will be the less power in this condition. So it is the differentiating point. What about the meconal sign? Meconal sign, it is the patient with acute pulmonary embolism, which shows decreased RV free wall movement, mainly bulging of the right ventricular free wall, and hypokinesia of the basal part, and the akinesia of the mid part of the RV, and sparing the apical part of the RV, which is called as meconal sign, and it has sensitivity of 77% and the specificity of 94% for diagnosis of the acute pulmonary embolism. And this is, as we said already, in the meconal sign by description. And you will find also the apex of the left ventricle is hyperkinetic. And this is already high, and the sparing part of the apical part of the RV, it is due to the tethering to the left ventricle. That's why it appears to be already preserved function in this condition. This is an example of the meconal sign. As we said, right side or right ventricle is already dilated, and the bulging part of the right ventricular free wall, akinesia of the mid part of the RV, with sparing the apical part, which is the typical of the meconal sign. There is one sign now they are putting in this, which is called a 60-60 sign. One of the sign of the diagnosis for acute pulmonary embolism. What is 60-60 sign? The patient already, it is identified as pulmonary flow acceleration time less than 60. You know that pulmonary acceleration time, when it is decreased, it means that there is pulmonary embolism, there is pulmonary hypertension, or like this. But if you find that the pulmonary acceleration time less than 60 millimeter in second, in presence of the tricuspid regurgitation, pressure gradient less than 60, as Dr. Abdurrahman Jamil who said before, less than 60, with TR velocity less than 3.9, it is high specificity for the diagnosis of the acute pulmonary embolism. Specificity is about 98%, sensitivity 48%. Combination of 60-60 rule together with the McConnell sign, it will increase more the sensitivity without affecting the specificity. Also, there is something also very good and new also to look for. For the patient with acceleration time, as we said that in the patient, acceleration time will be less than 60, and also the deceleration time with the early systolic notching in the pulmonary Doppler flow, it is this tracing. This is early. This is the deceleration, the acceleration time which is decreased, and when deceleration here, it is early notching here like this. Early notching in the deceleration, it is indicative of the massive or submassive pulmonary embolism. So this is two criteria. It is now they are considering this. From this, you can diagnose acute submassive or massive pulmonary embolism, which is already decreased this acceleration time less than 60, and the presence early notching of the deceleration in the same wave here. It is specificity about 92%. And also this is showing that other things here for the which is that the presence of the TAPC also, which means that right ventricular side dysfunction, and also if you can see that thrombus in transit in the main pulmonary artery. Also, to diagnose acute pulmonary embolism, if you find, as Dr. Abdulrahman also said, when you see that already actually the thrombus which is present in the any branch of the pulmonary artery or in the main branch by the echo. Now, we can ask ourselves, when we see that already signs on the right side and the right ventricular dysfunction like this, it is acute or chronic right ventricular dysfunction. How can we differentiate this by the echo? They said that if right heart thrombus, if you saw that right heart thrombus in transit or anything, it means that it is acute, like acute pulmonary embolism. If the right ventricular free wall thickness less than 5 millimeter, it is acute. If more than 5 millimeter, it is chronic. And also tricuspid regurgitation pressure, if gradient, if it is less than 46, it is acute, and if it is more than 46, it is chronic. Also, pulmonary artery acceleration time between 60 to 80, less than 60 to 80, it is acute. But it is more than, it is less than 105, it is going with the chronic. Also, the sign, as we said, 60-60, it means that acute because acute pulmonary embolism. And also pulmonary artery, early systolic notching, as we said, it is going with that proximally located higher risk for the patient for pulmonary embolism. It is acute. McConnell sign, of course, it is an acute. And also right atrial enlargement, if it is equal to the left atrial enlargement, left atrial size, it means that acute. But if it is more than left atrial size, it means it is already chronic. So from the echo, we can differentiate between acute or chronic this cartoon, this diagram showing that, summarizing all what you are looking for with the patient by echo for acute pulmonary embolism. If you find already thrombus in transit like this, if you find that, if you go to the tricuspid valve, if you have already tricuspid regurg with the velocity more than 2.9, or that the gradient around more than 49, as we said, and also to the tricuspid annulus, we'll look for the TAPC, and also you look for the velocity by tissue Doppler, as we say that if TAPC already less than 1.6, and also by the tissue Doppler less than 9.5, the velocity is also indicative of the acute pulmonary embolism. Look to the right ventricle, the size of the right ventricle comparable with the left ventricle. If it is more than 1, it means that already suggestive of the acute pulmonary embolism, and also looking for the free wall motion in this condition. When it is already McConnell sign with already akinesia of the middle part of the RV free wall and is bearing the apical part, it is a McConnell sign. It is an indication also of the acute pulmonary embolism, and also interventricular septum. When it is flattened already and with D-shaped of the left ventricle, it is suggestive also of the acute pulmonary embolism, you will find that the left ventricle completely normal. And also, if you look to the pulmonary artery, you look in this condition. If you can see thrombus, also we'll see that the acceleration time, as we said, if it is acceleration time less than 60 milliseconds, also we can also look for the sign 60, and also if they already mid-systolic early notching, as we said. So this is summarize all what you are looking for in the patient with the echo with acute pulmonary embolism. Echo also, it is important to assess the therapy for the patient with acute pulmonary embolism. Like when you are giving thrombolytic therapy, you will find the dramatic changes in the already. When we say that the finding you will find in the acute pulmonary embolism, right ventricular dilatation and the right ventricular dysfunction. You will find that reversal of the RV size back to normal, and also reversal of the RV dysfunction back to normal, either if you are giving thrombolytic therapy or we are using suction embolectomy. So it will be dramatical changes within 24 hours like this. You can see, and I'll show you examples for this. Role of POCUS also in the pulmonary embolism, I'll not go for details for this because Dr. Gamil already talked about this, but the only thing here, when already the physician, POCUS, it means that you are not bringing the technician to do the echo and not bringing the one which is expert in echo to do the echo, but you are training your people, physician, already who are in the ER, who are in the already in the ICU or any other place, just to utilize this POCUS to focus on the diagnosis of the things. For the patient to diagnose pulmonary embolism by POCUS, only looking for if you look for the parasternal long axis, you look for the right side, it is dilated or not, and also look for the RV free wall hypokinesia or like this. And also if you look to the short axis, you will see that the D-shaped left ventricle and dilatation and the dilatation of the RV and the flattening of interventricular septum. And if you look to the apical fourth chamber, either you find that already thrombus in transit, or you find that tricuspid regurg, as we said, and also looking for the meconal sign and also all the signs of the RV dilatation relative to the LV and all other criteria. We talked about this. And subcostal view also is very important for the IVC, which will be loss of the collapsibility in this condition in patients with acute pulmonary embolism. There is also, last two slides, just to also summarize something which is very important for prognosis. They found also RVOT, VTI. It will predict low cardiac index in the intermediate risk pulmonary embolism. And they find that RV, VTI, if it is less than 9.5, it increases the mortality rate in the patient with pulmonary embolism. So it is also something new we have to look for. And also they found that LVOT, not RV, LVOT, VTI, is also associated with adverse short-term outcome in acute pulmonary embolism. They found that LVOT, VTI, less than 15 seconds, it also associated with in-hospital death and or cardiac arrest more than if compared with the other people with normal personality. So it is very important nowadays. They are looking for anything which help for early diagnosis of the acute pulmonary embolism, not to keep him for a long time, because embolectomy now we can do this by catheter. I'll show you that two examples. This is example of the patient with acute pulmonary embolism. What is this? Meconal sign. Already right side is dilated, and there is meconal sign very clear. Ratio. Meconal sign here, this right ventricle is dilated, and RV free wall already bulged out, and there is akinesia or severe hypokinesia of the mid part of the RV wall, and this is the apex. It is sparing the apex. Apex is contracting very good. Sorry? Mid free wall. Hypokinesia. Hypokinesia, and sparing the apex only. Apex is contracting very nicely, and you will find to the left ventricle is already contracting normally. To get this view called as focused foreshortened side, focus the view for the RV. You are doing foreshortening of the left ventricle and concentrating on the RV only to get this sign very clearly. Okay, It is very clear here, McConnell sign. And also, as we said, that measurement for dilatation of the RV already at the basal part, you see that 4.7, and also in the mid part, it is 4.5. It's more than 3.5, so it is already dilated. And also, this is what? Looking for TAPSI. TAPSI also, it is very low. You see that the TAPSI very low. You see that less than 1.6. It is 0.9. Okay, and also the tissue Doppler in the free wall here, it is only 5.8 millimeter. So it is diagnosis, helping for diagnosis acute pulmonary embolism. Second case, here is the short axis. See, what is the abnormality here? You see that RV hugely dilated, LV it's small in size, and also flattening of the interventricular septum with the D shape of the left ventricle. Here, again, McConnell sign, the same thing. It's already dilated RV, akinesia of the free wall, sparing the apex, so it is McConnell sign. Okay, here is a tricuspid regurg, but it is not so high. Again, the size dilated RV. After thrombectomy, this patient already we did for him thrombectomy by catheter. 24 hours. See that difference? RV, the size returned back to normal, and also the function returned back to normal. See, the whole RV free wall, it is contracting very nicely now. So it is showing you the effect of the management for the patient. The same thing. And also see the TAPSI. How much now? 2.1. It is the same patient after thrombectomy. And also RV free wall tissue Doppler. See how much? 16, above 10. So it is completely normal. To conclude my talk, echocardiography is the most used imaging modality for evaluating and managing patients with acute pulmonary embolism. Most available, cheap, and non-invasive, doesn't require contrast agent or radiation. It aids in the management strategy, risk stratification, and the prognosis in patients with pulmonary embolism. And thank you for attending with us till now.
Thank you. I think by this we conclude, and the mic back to you for closing remarks.
Okay, thanks a lot. And now we'll select 3 and give them 3 prizes, inshallah. Okay? Dr. Hatem. على مهلك. اهو قدامكم اهو ماليش دعوه بحاجه اهو الدكتور حاتم. طب نور النور بقى شغل نور النور. اوبن وسعد. ابتسام موجودة؟ موجودة؟ اتفضلي. فين الأخ اللي بيصور؟ مفيش حد بيصور ولا إيه؟ طب حد يصورنا حتى بالموبايل مفيش مشاكل. ها؟ اتفضلي. حد يصورنا صورنا بالموبايل حتى. اتفضلي. جزاك الله خير. يلا احنا عايزين 2 تانيين. بيقول لك رشيد شوف له حاجه رشيد. فين؟ موجودة؟ اتفضلي. استنى خلينا نشوف. مش عايز تصور مش مشكلة، خدي الجايزة طيب. مش عايزة تصوير؟ خلاص اتفضل. ألف شكر. الثالثة بقى. والله طب مين هيصورنا طيب؟ دي اجمل حاجه دي. اتفضل يا حبيبي. الله يكرمك. الله يكرمك. شكرا شكرا وجزاكم الله خير، وان شاء الله نشوفكم السنه الجايه ان شاء الله، ونرجو ان احنا ما نكونش قصرنا معاكم في حاجه. الله يبارك فيك. الله يبارك فيك يا حبيبي. الله يبارك فيك يا حبيبي. الله يبارك فيك. الله يبارك فيك. نجح بيكم. الله يكرمكم يا اخوان. الله يكرمكم. جزاكم الله خير. جزاكم الله خير. الله يبارك يا حبيبي. الله يكرمك.